So, very good morning to all of you. How are you all? How is the life going on? Everything is fit, fine? Great. So, you all must have read the topics what we had covered yesterday. And today we are moving to our very important section, that is the disease and its related national programs. And as we had seen that around 7 to 10 questions are asked from this section, and here we are mainly concerned with the important diseases and their related national programs. Now, in this, we'll be talking the diseases not as per their causative agent, like not as the bacterial diseases, viral diseases, or the fungal protozoal diseases. We'll be studying the diseases as per their route of transmission, and we'll be broadly classifying the diseases into the two headings. The one is a communicable disease, and another is a non-communicable. Communicable means they are transmitted from the one to another, and the non-communicable means they are not able to transmit from one to another. In the communicable group also, we'll be talking as per the route of transmission. If they are the vector-borne diseases, means transmitted by the certain vectors. So if we are controlling the vectors, we can avoid all those diseases. Then I will be talking about the intestinal infections. If we are having a safe water supply and the proper management of the fecal, the sewage disposal, we can avoid all the waterborne infections. Then we will be talking about the sexually transmitted infections. If we are giving an education to the community to have a safe sexual practices, we can avoid the sexually transmitted infections. We'll be talking about the respiratory infections. If we avoid the respiratory contact, we can avoid all those infections. Then the zoonotic diseases. So here we'll be talking as per the route of transmission, because the management or the prevention depends upon the particular group. Clear? And we'll be talking only those diseases for which we had a prevention or we had an important national program for that. Otherwise, it will be all the general medicine will be discussed here. And for those diseases, if we don't had any prevention, we'll not be talking here only. So first group, what will be starting as the vector-borne diseases, and main important vector is the mosquito. And the three very important diseases which we'll be talking here is malaria, filariasis, and the dengue infection. Now, I'll be talking the Japanese encephalitis and the leishmaniasis under the zoonotic group, because we had some involvement of animals in their cycle. So first, we'll be starting with our first group of the disease, and that is the vector-borne infections. Now, we had one very important national program. We are supposed to remember the logos of these programs. So this is a cycle, which the family, this is husband, wife, and the kid, which is prevented from the bite of these mosquitoes. So the first question is that what are the diseases included under this program? As we know that this is a national vector-borne disease control program. So control means we are trying to control only those diseases for which we had some problems. So one very important disease that is not included and that is commonly asked is a yellow fever. So all the diseases are included except yellow fever. That is very important to remember, because yellow fever we don't had in India. So we are not trying to control. Means we are not trying to reduce the new cases. We are not trying to reduce the total cases. Our purpose is not allowing the entry of this yellow fever in India. So it is not a control activity. So the diseases included under this are the six important diseases like malaria, filariasis, leishmaniasis, Japanese encephalitis, dengue, and the chikungunya. So these are the six very important diseases included under this program except yellow fever. Remember this point. So first is malaria. So just try to understand the basic cycle of what malaria parasite does. So whenever this mosquito sucks the bite, the gametes, they enter into the mosquitoes, and as we had already discussed yesterday, that mosquito is a definitive host for malaria. So in the mosquito, the fertilization happens, and the this zygote is formed, which is converting into the ookinete, which is going into the proboscis of the mosquito and developing into the sporozoites. When this mosquito bite, these sporozoites are dropped into the human body. They reach into the liver. This is a pre-erythrocytic phase, means before the entry into the RBC. So they passes through the liver cell and they develop, and these liver cells, they rupture and they liberate the merozoites, and then these hepatic merozoites, they enter into the RBC. Now the this erythrocytic phase starts, and then the RBCs, they passes into the trophocytes, schizones, and the merozoites. So when these erythrocytic merozoites are released, then we had a spike of fever. So this process takes around 48 to 72 hours depending upon the species of the malaria parasite, and we had a spike of malaria fever after 48 hours or the 72 hours. Then some of these trophozoites, they are converted into the gametes which has been sucked by the mosquito, and again this cycle happens. Now just remember the two important points here is that suppose if it is a blood transfusion induced malaria, so only the form which is present in the RBCs will be entering into the human body, so it is bypassing the liver phase, so will not have the relapse, because mainly the relapse happens because of the slow maturation of these hepatic merozoites. So if it is a blood transfusion induced malaria, will not have the relapse case. So this is number one. Number two is that we are developing a malaria vaccine that is blocking the entry of these sporozoites into the liver cell. So once these sporozoites are blocked, they are not entering into the liver phase, that further process has been stopped, and this is how the malaria vaccine is working. Then the next point is that if we have to do the confirmation of the malaria, we have to take a blood, and we have to prepare the smear. So two smears are prepared. One is a thick smear to look for any of the malaria parasite, and then the thin smear to see for the type of the malaria parasite, whether it's a Vivax or the falciparum, because the drug is different for the Vivax and the falciparum malaria. And in those areas where the report is supposed to be available in 24 hours, but it is not available, then we are going for a rapid diagnostic test kit. In this, various antigens which are present on the malaria parasite, we are checking those antigens. So this is a rapid diagnostic test kit, but it is not a best test. Best test for confirmation of the malaria is only the peripheral smear test. So these are the few important points. So now I will be writing about, there should not be any confusion about the agent or the vector and all. So the agent for malaria, it is a plasmodium. So agent is plasmodium, and its species can be either the Vivax or the falciparum ovale or the malariae. The most dangerous is the plasmodium falciparum, but the most common is the plasmodium vivax. The vector is Anopheles, a vector which is transmitting the infection, and we can have a various varieties of the Anopheles or the species of the Anopheles. Now you can remember one or two. The Anopheles culissifaciens, it is seen in the rural areas, and we can remember like in the Delhi we had a St. Stephen Hospital, so you can remember as Anopheles stephensi, it is in the urban area. So Anopheles culifacius, this is spelling just correct, it is a culifaciasis, the CULI. It is a Anopheles culifaciasis, it is in the rural area, and Anopheles stephensi, it is in the urban area. Now biological cycle, yesterday we had discussed that in a vector, it is only it is undergoing both increase in the number and the maturation. So the cycle is, it is what? Cyclopropagative, cyclodevelopmental, or the propagative, both is happening. So this is the cyclopropagative cycle. So biological cycle is the cyclopropagative cycle. The definitive host is the mosquito. So mosquito is the definitive host, and the man is supposed to be the intermediate host. Now incubation period is entry with the first symptom. Now there is a two type of incubation periods are there. One is in the inside the human body, and second is the time required in the development of the organism inside the vector. So extrinsic incubation period, it is about 10 to 20 days, and the intrinsic is inside the man. So extrinsic is inside the vector outside, and the intrinsic is inside the man. So various species are having a variety of the various range of the incubation period, and on an average you can remember as for 14 days for the Vivax and the 12 days for the falciparum. So we can remember like as a 12 to 14 days is the incubation period inside the human for the malaria. Now as I told you that if a mosquito bite is happening, then the form which is entering is the sporocyte, and always there is a possibility of a relapse. Possibility of the relapse is present, but if it is a blood transfusion induced malaria where directly the trophozoites are entering, there is no relapse is seen. So no relapse is seen in the cases of the blood transfusion induced malaria. Now diagnosis is done. The best test for the diagnosis is the peripheral blood smear examination. It is supposed to be the best test. Now, the point what we have to remember is that who prepares the smear? Smear is prepared by multi-purpose worker male. Multi-purpose worker prepares the slides. Where he can prepare the slides? He can prepare the slides either in the village or in the sub-center. So he can prepare the slides either in the village or in the sub-center. The number of the slides, he is preparing the two slides. One is the thick smear, another is the thin smear. Now, what is the purpose of the thick smear? The purpose of the thick smear is to confirm the malaria. We have to look for any of a malaria parasite, and the purpose of this thin smear is to know the type of malaria. So the two smears are prepared, the thick and the thin smear, prepared by the multipurpose worker. Now, where they are checked at? They are checked at the primary health center. At what time it has to be prepared? It can be prepared in any time. So these are the points what you have to remember about the peripheral blood smear examination. So important is it is prepared by the multipurpose worker male. Two smears are prepared, the thick and the thin smear. And another important point is that a report should be available within 24 hours. Because if the report is not available within 24 hours, then we are going for a rapid diagnostic kit. So report should be available within 24 hours. So this is about the peripheral blood smear examination. Now, second is the rapid diagnostic test kit. RDT is rapid diagnostic test kit. If a report is not available in 24 hours, so when the report of the peripheral blood smear is not available within 24 hours, we go for a rapid diagnostic test. So if the report of the peripheral smear is not available within 24 hours, we do for the rapid diagnostic test. Here, little bit a higher point, if you can remember, the antigen what we are trying to detect is the HRP2 and the LDH. Histidine-rich protein and the lactate dehydrogenase, these are the two antigens what we are trying to detect. And you all had studied in your micro classes the interpretation of these kit, that usually these are the bivalent kits. Bivalent means we are checking for both the falciparum and the Vivex. So if there is only line it is present against the control, it means that it is a negative report. But if it is present against the control for the falciparum and the Vivex, so it is both the falciparum positive as well as the Vivex positive, both are positive. If it is only present against the Vivex, it is only the Vivex is positive. If it is only present against the falciparum, obviously it will be present for the control. It is falciparum is positive. And you can make another one that if control is line is not visible, if it is only present against the falciparum or the Vivex, then this becomes invalid, because already there is a criteria that the line should always be present against the control. If a line is not present, then it is considered as invalid. So this is an important point what we have to remember for the diagnosis. Now once we are diagnosed, then we are going to treat, and as per our national program, the treatment depend. Now please try to listen, because here the clinical questions are asked. For the treatment, first of all, we have to see what type of the species is there, whether it's a Vivex or the falciparum. Second is that we are treating the pregnant woman or we are treating a general population. The third is if you are treating a pregnant patient, it is in which trimester of the pregnancy. Fourth is if you are treating any one of our general or the pregnant patient, whether the person is living in a northeast area or person is living in other areas, because we had a different drug protocol for the northeast and other, especially for falciparum infections. So these are the 4 points we have to look for. First is if it is we are treating in a general population. So first category is if you are treating the general population, obviously in a non-pregnant state. For the 5x in all the states, so for the 5x in all the states, the drug of choice is chloroquine. So in general population, for the 5x in all the states, the drug of choice is chloroquine. Dose you may or may not remember, it is not asked. It is 25 milligram per kg the body weight in 3 divided doses. In 3 divided doses, total is 25 milligram per kg the body weight. Along with the primaquine, we are giving chloroquine, we are giving the primaquine. And here we have to remember the dose of the primaquine we are giving as 0.25 milligram per kg the body weight per day. This is given for 14 days. So this we have to remember. The primaquine is given as 0.25 milligram per kg the body weight per day for 14 days, and we are giving the chloroquine. So this is a vivax infection in all the states in a general population. If it is a falciparum in the northeast states, because the northeast states may be at a high mortalities, so we are giving a higher group of the drugs. So in the northeast states, we are giving the ACTL therapy. ACTL therapy. Now ACTL means artemether and L for lumefantrine. So we are giving a combination of an artemether and lumefantrine for 3 days. Here again the doses are not required, but yes, we are giving a primaquine along with this artemether lumefantrine, and here you have to remember the dose of the primaquine, that is given 0.75 milligram per kg the body weight as a single dose. Means higher dose 0.75 milligram per kg we are giving as a single dose. 5x may smaller dose 0.25 milligram per kg daily for 14 days. Now if it is other states, the treatment what we call as the ACT-SP combination. SP is a sulfadoxine pyrimethamine. So what we do here, we are giving the artemisonate for the 3 days, and on the day 1 along with the artesunate we are giving a sulfadoxine pyrimethamine as a single dose, and on the day 2 we are giving the primaquine. And primaquine is also again the same dose what we had discussed in our northeast states as 0.75 milligram per kg the body weight as the single dose. Clear? So this is how we are treating a patient in a other states. So very commonly they ask like this: a person is coming to the clinic with a high grade fever, the chills and ligers, living in the Delhi, and on investigation confirmed to be having a falciparum infection, what will be the drug of choice? So अगर दिल्ली में रह रहा है falciparum infection है तो ACT-SP combination है. अगर कहेंगे कि आसाम में रह रहा है falciparum infection है तो ACT-L combination है. अगर कहेंगे कि vivax infection है, it is living in a Delhi, it will be, or the Assam, it will be the chloroquine. So we have to see the question carefully. So chloroquine with 14 days of the primaquine, while here ACT-SP with a single dose of the primaquine. Now how we are treating in a malaria and pregnancy, because some of these drugs are not safe in pregnancy, especially the primaquine. So primaquine, it is absolutely contraindicated in pregnancy, because primaquine जो हम देते हैं, it is to avoid the relapse. And हम ये कहते हैं कि पहले first we deal with the pregnancy, manage the acute state, and relapse will be dealing after the delivery. So malaria with the pregnancy, if it is a vivax infection, the vivax infection, the drug of choice is chloroquine. Drug of choice is chloroquine, and in all the trimesters, in all the states. So drug of choice is chloroquine only in all the trimesters and all the states. What it means? Suppose a person is living in a northeast state or other states, or the person is coming in a first trimester, the person is coming in a second trimester, the third trimester. In all the trimesters and all the states, for the Vivax, it is only the chloroquine. But the primaquine is a contraindicated. So no primaquine, but only chloroquine. Clear? So only chloroquine we are giving and primaquine is a contraindicated in a Vivex infection. But if it is a falciparum infection, then please listen carefully. In the first trimester, we cannot give the artemether or artesunate drugs. So in the first trimester, the drug of choice is quinine. Drug of choice is quinine. In the first trimester, the drug of choice is quinine in all the states. In all states, may whether the person is coming in from the Assam or from the Delhi, Gujarat, it is all the states. It is only the quinine, and as well as the same is that primaquine is contraindicated. So primaquine is contraindicated, and the drug of choice is quinine in all the states for the falciparum in the first trimester. Now, second and third trimester, it is depending upon the location. Now, in the northeast states, the drug of choice is ACT L therapy, while in the other states, it is the ACT SP combination. ACT SP combination, and just cut this number 3, the primaquine contraindicated is a part of this only. So, second and third trimester, depending upon the states, it is a northeast state ACT L combination, other states is an ACT SP combination, but primaquine is contraindicated. So, see the choices, see the question very carefully, and we have to open all our choices carefully, and we have to analyze and then come to the answer. Clear? Another very commonly asked question is, if a person is going in a malaria endemic areas, can that person take a prophylactic drugs? So chemoprophylaxis or the drug is taken in advance. So it depends upon how long that person is willing to stay. If a duration of stay is less than 6 weeks, agar duration of stay is less than 6 weeks, then doxycycline is preferred, which has to be taken daily, and it has to be started 1 to 2 days before going to that area. But agar duration of stay is more than 6 weeks, then person cannot take a tablet daily. Then person has to switch on the weekly tablet, and the weekly tablet is either the chloroquine, which has to be started 1 week before, or the mefloquine, which has to be started 2 weeks before. So, doxycycline, less than 6 weeks duration, more than 6 weeks is chloroquine or mefloquine. Please make a note, in pregnancy, whatever is the duration of a stay, the drug of choice for the prophylaxis is chloroquine only. So pregnancy may doxy is also not given, the meflo is also not given. So we are preferring as a chloroquine, whatever is the duration of the stay. Clear? Now another very important question is asked is, once we are leaving that area, should we stop immediately or should we continue for some time? So it has to be continued for 4 weeks after leaving the area. We have to continue for 4 weeks after leaving the area. So this is very important. Now coming to any national program is having the indicators, and we have to understand that what are the indicators of that national program, where those activities are being conducted, what are the infrastructures, what are the goal, and how we are fulfilling that goal. Clear? So indicators of this national program is one very important is the API. So first question, API is related to which? Malaria program. What is the full form of an API? Is an annual parasite incidence. Now how we define the API? The API is defined as new confirmed malaria cases, per 1,000 population per year. So new confirmed malaria cases per 1,000 population per year is the annual parasite incidence. Now you can understand with the words. Incidence is the new cases, annual means every year, and obviously it is an incidence, it has to be expressed as per 1000. So it's a new confirmed malaria cases per 1000 population per year is the API. But problem here यहाँ पे problem है कि कभी कभी person is having a malaria bite a few years before not having any symptom and now can have a symptom. So if we want to know whether the malaria transmission happens in the past 1 year, this API will not work. So we have to study the malaria in the last 1 year born children only, because if they had a malaria parasite, definitely they had a bite in the last 1 year only. So the infant parasite rate, if you are checking the malaria parasite in the infant, that is giving us an idea that malaria has transmitted recently only. So very important question asked is, what is an indicator of the recent malaria transmission? It is infant parasite rate. So infant parasite rate is an indicator of the recent malaria transmission. So it is an indicator of a recent malaria transmission, infant parasite rate. While annual parasite rate will be indicating an active transmission. It is not that it is in the recent year, it may be any time in the past. So annual parasite incidence is giving us an idea about the active malaria transmission. Active transmission of the disease, but the recent transmission is detected by in malaria infant parasite rate only. Clear? Now, what is an annual blood examination rate? Means how many percentage of the population is checked with the peripheral smear. So, annual blood examination rate is percentage of the population checked with peripheral blood smear. Percentage of the population checked with peripheral blood smear, and this is giving us an idea about the working of the multipurpose workers, because if they are visiting house to house, they are doing an active surveillance, then only they are checking for the peripheral smear. So this is an indicator of the operational efficiency of worker. So annual blood examination rate is a percentage of the population checked with the peripheral blood smear, and operation, this is giving us an idea about the operational efficiency of the worker. Now what is slide positivity rate? Slide positivity rate means जितनी आपने slides बनाई उसमें से कितनी positive है. Percentage of slide positive for malaria parasite. Percentage of the slide positive for malaria parasite is slide positivity rate. Okay, suppose if I say that in a population of 5,000, slides prepared are 100. In a population of the 5,000, slide prepared are 100 and the positive slides are 30. So what will be my annual blood examination rate? 100 slides are prepared out of the 5,000 population. So how many slides will be prepared out of the 100 population, because it is present in the percentage? It is only the 2%. So annual blood examination rate is 2%. But what is my slide positivity rate? 30 slides are positive out of the 100 slides. So it is 30%. So see, the annual blood examination rate is less in this situation, but whatever the slides are prepared, the 30% are positive. So like that, they can ask a small question. So we should be clear with that also. Clear? Now, in malaria patients, some are showing a enlarged spleen. So spleen rate is only for the epidemiological survey. So these are the important indicators. At least if you are not able to remember all, at least remember these first four, that and out of these first four also the first two are important, that is the annual parasite incidence and the infant parasite rate. Now coming to where these slides can be prepared, what infrastructure we had. In the periphery we had two centers. The one is a drug distribution centers and fever treatment depot. Now drug distribution centers are means those who are positive. Suppose if you had visited house to house and you had come across a positive patient on the peripheral smear examination, patient is asymptomatic, and अगर आप उसको बोलोगे कि भाई जाके अमेरिका में जाके दवाई लेके आ जा, he will not go. He said that I am not having any problem. You came and you had taken my blood. आप आए थे, आपने मेरा ब्लड ले लिया, चेक करा, आपने कहा कोई डिसीज है, मैं तो नहीं जा रहा दवाई लेने के लिए, आपको देनी है तो यहीं आके दे दो. So if you tell them the person to take a medicine from a higher center, they will not go because they are asymptomatic. So we are having a provision to distribute the medicine right in the village. So these are the drug distribution centers which are giving the drugs to the confirmed cases, or we can also prepare the slides also there. So these are the fever treatment depots where we can prepare the slides also, and those who are positive we are giving them the drugs. So just remember that in the village we are having a drug distribution centers and the fever treatment depots. These are related to malaria program. Now classification of the states based on the API, it is not much required at your level, so you can skip also. Now again the classification of the PSCs based on the API, again you can skip. Now what is the national guidelines for malaria program? Now we are planning to have a malaria elimination. So the guideline is the national framework for 2016 till 2030, and very important is that we have to remember that what is the goal. The goal is that we have to eliminate the malaria by 2030. So we have to remember that we have to eliminate the goal by 2030. Okay. Now this is first question, that for watch time we have to do the elimination. Now as I told you yesterday also, that exact meaning of the elimination is there should be the complete break in the chain of transmission, so no new case will happen. But in India, in our national programs, we had set certain criteria, means our new cases are below that criteria, almost negligible, we say that we had eliminated. So what is the criteria for elimination of malaria? That API should be less than a 1 in all the districts. So this is the criteria for elimination. So we have to remember the criteria also. So API we all know that is annual parasite incidence, means agar a new confirmed cases of malaria are per thousand population per year, if they are less than a 1, then we can say that we had eliminated the disease, but it should be in all the districts. Now what activities we are doing to do the elimination? So elimination is achieved by, so activities are, we are doing an active surveillance. Active surveillance is done by which worker? Who is the worker for active surveillance of the malaria? It is the multi-purpose worker male. Very important question, many times has been asked. So the multi-purpose worker male is active surveillance, and we know that active surveillance means visiting house to house, and कोई भी suspicious case है, preparing the slides, and simultaneously we are trying to control the vector also. Now as you can remember, what is the vector for malaria? Is the which mosquito? Anopheles. And one important point we have to remember here is, here the female Anopheles bites, and female Anopheles human bite के बाद, blood meal के बाद usually कमरे में बैठती है. So female Anopheles sits inside the house. It is not going outside. So अगर हमें उस फीमेल एनाफ्लीस को मारना है जिसने ब्लड मील दिया है, बिकॉज वही ट्रांसमिट कर सकती है दूसरे को इन्फेक्शन, सो हमें इंसेक्टिसाइडल स्प्रे घर के अंदर करना होगा, क्योंकि बाहर करेंगे तो कोई फायदा नहीं है, फीमेल एनाफ्लीस नहीं मरेगी. सो वी आर गोइंग टू डू द इंडोर स्प्रे, दैट इज वेरी इंपॉर्टेंट फॉर मलेरिया. सो मलेरिया में in the rural areas we are mainly focusing on the control of adult mosquitoes. We are mainly focusing on the control of the adult mosquitoes, and we are doing the indoor residual spray. ठीक है। एंड रेसिडुअल आपको याद होगा कि two medicines are having a residual effect. The DDT, its effect is lasting for 6 to 12 months. That's why every 6 months we are doing the spray of the DDT along with the pyrethrum, or we can do the malathion every 3 months. तो यहाँ पे हमारा जो environmental health का जो knowledge था, we will be using in management of various vector-borne diseases. Clear? And so rural area में हमारा जो focus होता है, it is you can write somewhere that in rural areas में because आप water collection को avoid नहीं कर सकते, farming होती है. So rural areas में the main control is the control of adult mosquitoes for all other diseases. Not only for the malaria, it is for the other diseases also. Rural area में our main focus is control of the adult mosquitoes, while in the urban areas focus is on the control of larvas. Means we can avoid the artificial water collection, और अगर water collection है भी small areas में है, so we can put the chemical there or fishes there, but rural areas में we cannot do because वहाँ farming होता है. So vector control अगर करना है malaria के लिए rural area में adult control, and adult control is doing by the IRS is the indoor residual spray. Urban areas में it is the anti-larval measures. In those areas जहाँ पे कि API 5 या 5 से ज़्यादा है, we are using the long-lasting insecticide net. I'm not writing again because सारा हमने लिखा है. Long-lasting means there the mosquito net are coated with a chemical combined with some material which is water resistant. And if the API is between 2 to 5, it is indoor residual spray with insecticide treated bed nets. So this is how we are trying to control the vector. Now we are having a different malaria programs as in the urban and the rural areas. Only the point what we have to remember in the urban, that main focus is on anti-larval measures. So in which areas we had a urban malaria scheme? So the question was asked is all are true for the urban malaria scheme. It is in the area where the population is more than 50,000, where the slight positivity rate is more than 5%, and here the control is, it is a anti-larva control, and the points in the anti-larva control are either we avoid the mosquito breeding, or we are putting the fishes, or we are putting some chemicals. It is same the repetition. So this is about the urban malaria scheme covering a population of more than 50,000, slight positivity rate more than 5%, and having a anti-larval control. Now a vaccine what we are having, it has been approved by the WHO, and the vaccine is Mosquirix, and the strain is RTS AS01. RTS AS01 is the strain for Mosquirix vaccine, and it is blocking the liver infiltration by the parasite. So there is no hepatic cycle is going on and malaria is prevented. So this is all about the one very important disease as is malaria. Just give me a minute. Now, another important disease is filariasis. Now, filariasis, we all know it is by the Helix mosquito bite. And this was the image asked in one exam. Actually, what this does, when the mosquito bites, it leaves the microfilarias. And these microfilarias, they grow into an adult worm. And these worms, they block the lymphatics. So there is a massive swelling on the peripheral part. And sometimes the legs are swollen, जैसे हाथी के पैर की तरह से हो जाते हैं. And इसीलिए periphery में this is called as हाथी पाँव disease या elephantiasis. Sometimes it is also a miserable condition, can block the genitalia and can cause a massive hydrocele, and sometimes it is also affecting the female private parts, also causing a massive swelling of the labia majora. and it is very distressing condition. And examination में यहाँ पे we are only doing the thick smear only, क्योंकि यहाँ पे we only have to find out the malaria microfilaria. There is no different species of the microfilaria, only we are doing the thick smear examination. And thick smear examination is usually preferred in the late evening because female, not female, the Culex mosquito, it is biting in the late evening only. And this is not supposed to be the best test as in the malaria, because sometimes we can miss the microfilaria. So the best test is supposed to be the membrane filtration technique. Suppose if you had a doubt in a glass of water that something is there, what you do? You will pass this water through the strainer, and same like we will pass a fixed amount of the blood through a membrane, and if microfilaria are there, they will be trapped here, and if you examine this supernatant fluid, there is a higher possibility of detecting the organisms. So the point to remember here is about the filariasis, that it is caused because of the Vaucheria bancrofti mainly, can be because of the Bugia malai also, but vector is mainly it is the Culex vector is there most commonly, but it can be caused with the Mansonian. And please make a point that Anopheles and the this Aedes mosquito can also cause the filariasis. So it can be caused by the all the type of mosquitoes, but the most common is a Culex. If you can remember the species of the Culex, fine, it is a Quincy fasciatus. Filariasis as the F is fasciatus. Now, biological cycle means in the vector it is only increasing in the size. So this is the cyclo developmental. Only increasing in the size is cyclodevelopmental. The definitive host here is the man, while mosquito it is acting as the intermediate host. Long incubation period is 8 to 16 a month, and that's why a very dangerous condition is asymptomatic microfilaria. Why? Because microfilarias are present in the blood, but that person is not knowing, and if a mosquito is biting them, it can transmit the infection to others. So asymptomatic microfilariemia means microfilarias are present in the blood, and this asymptomatic microfilaria is a most dangerous condition. Long incubation period of around 8 to 16 months. Sometimes we can have allergy to these worms also, causing eosinophilia. Diagnosis is by peripheral blood smear, but the best test is membrane filtration test. The best test is membrane filtration test because it is having a high sensitivity. Membrane filtration test is the best test because it is having the high sensitivity. Peripheral smear में the rest of the features are same as for the malaria, means multipurpose worker mail is preparing, the slide is prepared at the village as well as in the sub-center checked at the PSC, but only difference is that we are preparing only the single thick smear. Only we prepare the single thick smear, and it is usually prepared between the 8:30 to 11:30 p.m. Now there is a variability in the time. Some books they write between the 8 to the 11:30. Some books they write 8:30 to 11. Some they write the 8:30 to 11:30. It is hardly any differences there. So 8:30 to 11:30 p.m. is the time for preparation, and rest are same as for malaria. So these are only the two differences, single thick smear between the 8:30 p.m. to the 11:30 p.m. Now, once we have do the diagnosis, now we have to do the treatment. So drug of choice for the treatment, we are giving the three drugs, and that is called as IDA therapy. IDA therapy, it is ivermectin, dithylcarbamazine, and albendazole. So ivermectin, diethyl carbamazine, ivermectin, diethylcarbamazine, and the albendazole. Now, here we are supposed to remember their doses also. Now, ivermectin is given in the dose of 150 to 200 microgram per kg of the body weight as single dose. 150 to 200 microgram per kg the body weight as single dose. Now, diethylcarbamazine, it is given as 6 milligram per kg of the body weight per day for 12 days. Diethylcarbamazine is 6 milligram per kg of the body weight per day for 12 days. Albendazole is given as 400 milligram single dose. So, this is the IDA therapy. All the three drugs we are giving. So, it is for the treatment. Supportive treatment we have to give for the lymph collection. So here you have to remember mainly the IDA therapy, that the doses of all these three drugs. Now what is our goal? Again the goal is for elimination of the disease by 2020. And what is an elimination criteria? Elimination criteria is that microfilaria should be less than 1%. Microfilaria should be less than 1%. And what is microfilaria? Microfilaria means microfilaria worms. Emia means in the blood. So अगर हम blood slides check करते हैं तो उसमें less than 1% of the slides should show microfilarias. So microfilaria means the percentage of the slides positive for microfilaria. So our criteria is that microfilaria should be less than 1%. Try to understand. अगर मैंने आपका ब्लड चेक किया, आपके ब्लड में माइक्रोफाइलेरिया है या नहीं है, ये डिसाइड करेगा ट्रांसमिशन. आप एसिम्टोमेटिक हो, लेकिन अगर आपके ब्लड में माइक्रोफाइलेरिया है, मॉस्किटो ने आपको बाइट किया, तो मॉस्किटो आपके अंदर से माइक्रोफाइलेरिया लेके दूसरे को ड्रॉप कर देगा. लेकिन अगर आप में माइक्रोफाइलेरिया नहीं है तो मॉस्किटो ने अगर बाइट भी किया तो उससे कोई प्रॉब्लम नहीं है. आपने बाइट किया, आपका ब्लड ले लिया, लेकिन कोई इन्फेक्शन नहीं है तो दूसरे को ट्रांसमिट नहीं कर सकता. Now just try to understand. If you are having a microfilarias in the circulation, means you had an infection. Maybe you are asymptomatic, but if mosquito is biting you, mosquito can suck this microfilaria and mosquito can transmit this microfilaria to others. But suppose if you are not having a microfilaria, even if a mosquito is biting, you are not having any harm because only your blood is lost some amount, but you are not giving an infection to others. So the elimination criteria is that microfilaria should be less than 1, means percentage of the slides we are checking, it should be having a microfilaria in less than 1% of the slides, and this is to stop the transmission. So if a microfilaria will be less than 1%, it will stop the transmission of the disease. Clear? How we can achieve the goal? What are the activities? Now here what we are doing, because some are asymptomatic patients, many times even their the blood smear is negative because they are having a less number of the microfilarias. So what we are doing in those states and the districts where we are still having a more cases of microfilaria or more cases of filariasis, not a microfilaria, more cases of filariasis, or even if our slides are positive for microfilarias, we are giving the drug to whole of the community once in a year, and this is called as mass annual drug administration. So annual means once in a year, to a mass community we are giving. And can you recall we had discussed this point that mass chemotherapy in filariasis, what we are doing, it is serving as a two function. It is treating those who are asymptomatic, they are having a microfilarias. So it is preventing the transmission to others. So it is acting as a secondary level prevention for those who are having the infection, and it is preventing others, acting as primary level prevention. Okay. So the question is what drug we are giving and how long we have to give. So we are doing a triple annual MDA. MDA is mass drug administration. Mass drug administration, this is acting as a secondary level prevention. Mass drug administration is acting as a secondary level prevention. Clear? Now what drugs we are giving? The same drug what we had given for the treatment is the IDA. Only the difference is that we are giving once in a year. Okay? So ivermectin same 150 to 200 microgram. Diethyl carbamazine same 6 milligram per kg. Only the difference is treatment mein we were giving for 12 days, but here we are giving only the single dose. And albendazole 400 milligram single oral dose of once a year. So we are giving as a single oral dose of once in a year. Clear? So annual triple drug mass drug administration. We are trying to cover as much as population, at least more than 80% of the population. We are trying to give every year 5 to 6 rounds were supposed to give, but we are giving up to the even 10-12 rounds we ho gaye hain, but still we are not able to control. Along with this, we are doing the killing of the mosquito, and just listen. Anopheles mein we have discussed we are doing the indoor spray, but Culex is resting outside, so we are doing the outdoor fogging. Confusion nahi hona chahiye. Malaria ke liye we are doing indoor fogging, Culex ke liye we are doing outdoor fogging. Another activity what we are doing is namak to har aadmi khata hai. Everybody is taking the salt, so we are putting the diethyl carbamazine in the salt. So diethyl carbamazine fortified salt is being used by the community. Can remember the concentration? Fine. 1 to 4 gram of the drug is added in the per kg of the salt given for 6 to 9 months. So these activities we are doing to eliminate the disease, and we are still waiting for its elimination. Now supportive treatment we are giving as for the lymphangiodenitis. Now a little bit a higher point, if you can remember, fine. Mass drug administration is usually given in the month of November. Why? Because presuming rainy season में mosquito bites ज़्यादा है, production ज़्यादा है, transmission ज़्यादा होगा. So in the month of the November we are giving, and before giving we are doing the survey that actually how much of the population is affected, and usually we are doing a survey in 8 sites, and 500 individuals are checked in each site. So total हम 4,000 population का survey करते हैं, and will be deciding how much is the percentage of the microfilariemia, and then we are giving the drug. ठीक है? And routine survey में we are doing a 5 to 7% of the population a survey, but in the evaluation a survey how much it is effective, we are doing the a survey in more than 20% of the population. If you can remember, fine. But just remember that we are doing the mass drug administration in the month of November, and 4,000 people are screened out before giving these drugs. So this is all about your second disease, that is filariasis. Now the third disease is the dengue fever, and it is again very important because it is causing the hemorrhagic manifestations. And the most important point is that Aedes mosquitoes, they are breeding in an artificial water collection, so we can absolutely avoid this condition. So the agent for this dengue fever is, it is the group B arbovirus. So the diseases caused by the group B arbovirus other than the dengue infection, so it can cause the dengue, it can cause Casanur forest disease, Japanese encephalitis, Casanur forest disease, Japanese encephalitis, and yellow fever. So these are the diseases which are caused by ग्रुप बी arbovirus. So obviously B है तो A भी होगा. So the diseases caused by group A arbovirus is chikungunya. So disease caused by the group A arbovirus is the chikungunya, and the disease caused by the group B arbovirus are these four diseases. Now, if we talk about the dengue virus, group B arbovirus, the four strains are there, the V1, V2, V3 and V4. Now here the 2 points are important to remember. Number one, that suppose if you had a once infection with the V1, the antibodies which are formed, it is not protecting against the V2. So there is a no cross immunity. Like COVID में कह रहे हैं कि if you had an infection with the one strain, it is protecting you from the another strain also. But here there is no cross immunity. बल्कि उल्टा होता है. उल्टा क्या है कि अगर पहले आपने एक स्ट्रेन से इन्फेक्शन है, एंटीबॉडीज बन गई हैं, तो वो क्रॉस रिएक्ट करके इन्फेक्शन को फ्लेयर अप कर देती हैं. So if you had a previous infection with the one strain, and after that if you had an infection with another strain, the antigen antibody reaction flares up and you had a more complication. So the secondary infection with a new strain, it is more dangerous, can lead to the dengue hemorrhagic fever or the dengue shock syndrome. Clear? So the deadly combination is if you had a first V1 followed by the V2, this is most dangerous. So most dangerous combination is the V1 strain infection followed by the V2. So here the question was asked is that a reinfection with a new strain will be more dangerous in which disease? So reinfection with a new strain will be more dangerous in the dengue infection. Now vector, again this is an image based question. Mosquito with the white spots on the body, that is a tiger mosquito. So vector is your Aedes mosquito. Now short incubation period of about 5 to 6 days. It can present as a simple undifferentiated fever. It can have a classical dengue fever as a high grade fever, severe headache or the severe body ache or rashes, or it can be having a dengue hemorrhagic fever when we can have a bleeding from internal or the external sites, or we can have a features of the dengue shock syndrome. So these could be your clinical situations or the clinical story, the clinical symptoms in a long story, but we have to try to find out the keywords, and that is very important. So one very important point is that once we do the diagnosis में एक तो you have to look for the platelet count, you have to look for the tourniquet test, and you have to look for the RT-PCR or NS1 antigen. So the best test if we see for the diagnosis, it is the RT-PCR test. The best test is RT-PCR test, but the first test what we are doing, it is the NS1 antigen. Viral antigen we are detecting, and this is even positive on the day 1 of fever. So NS1 antigen, it is positive even on a day 1 of fever. Suppose आज fever हुआ है, so even that fever पे भी first day में भी that NS1 antigen will be positive. Clear? So best is RT-PCR, but RT-PCR is very expensive, not freely available. So NS1 की kit आती है and it is very easily checked. Or we can check for IgM antibodies or the IgG increase. Another important point is that we are looking for the platelet counts. Obviously we know that platelet count कम हो जाते हैं, platelet counts are reduced. Hematocrit value, because there is a damage to the capillaries, serum is going outside, plasma is going outside, so hemo concentration हो जाता है. So hematocrit value increases. So platelet count decreases, but hematocrit value increases. Another important is the tourniquet test. Now this could be a image based question also. Just try to understand that what we do here, we put the BP cuff and put a pressure between midway of systolic and diastolic for 5 minutes. And after 5 minutes, we look for these petechias. Okay? The you can remember what the petechias were. If it is a leakage of the blood is 1 to 2 millimeter, it is the petechias. 3 to 10 millimeter is the purpura. More than 10 is a chymosis. We had already discussed in our derma classes. So we are looking for these petechial hemorrhages. If it is more than 10 per square inch area, it is suggestive of the dengue fever. But if it is more than 20, it is suggestive of a dengue hemorrhagic fever. So we are looking for this petechias. If there is more than a 20 per square inch of the petechias, it is suggestive of the dengue hemorrhagic fever. But if it is more than 10, it is a suggestive of the dengue fever. So if it is more than 10, it is suggestive of the dengue fever, but if it is more than 20, it is suggestive of the dengue hemorrhagic fever. Now treatment, it is only the supportive treatment we are giving because it's a viral infection. Now one practical point है यहाँ पे we have to maintain the IV fluid because bleeding होती है, IV fluid maintain करना है, and that's why we usually hospitalize all our patients of dengue fever, and we are maintaining the IV fluid. We should arrange, mind my words, we should arrange the blood. आप ब्लड ट्रांसफ्यूज करके रख लो, आप प्लेटलेट्स ट्रांसफ्यूज करके मैच करके यू कैन कीप, but there is no urgency to do the platelet transfusion. Now some of our friends in the dengue epidemic, they just make the community panic. कम्युनिटी को पैनिक कर देते कौन, आपका प्लेटलेट 80,000 हो गया, 90,000 हो गया, कम हो रहा है, आपको जम्बो पैक अरेंज करना पड़ेगा, नहीं तो पेशेंट मर जाएगा. So some of our friends, they are making a panic state. If patient is not actively bleeding, अगर patient actively bleed नहीं कर रहा है, तो even if a platelet count is dropping up to 10,000, there is no need for the platelet transfusion. But yes, it should be cross meshed and kept ready कि कभी भी अगर जरा सी भी bleeding होगी, then the tolerance will be very less and we have to transfuse. So always keep a cross match platelets ready, but there is no urgency for the transfusion until unless the condition appears. Clear? So we have to maintain the IV fluid. That is one important point. Platelet transfusion is only given if it is platelet count is less than 10,000 or if there is abnormal coagulopathy or the abnormal bleeding, but keep cross match ready. Or sometimes we can give the RBCs or the whole blood also if there is a more than a 10% of the blood volume is lost or a patient is in the refractory shock. Otherwise, with the supportive treatment, within 4-5 days when fever drops, automatically the platelets increases. But very, 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 very important is the prevention. Now, as EDs are breeding in artificial water collection. So if we can avoid the artificial water collection, we can avoid the breeding, and that is your primordial level prevention. So avoid the mosquito breeding. That is most important. It is your primordial level prevention. And that's why you might have seen many slogans are prepared and the message comes कि especially in the rainy season every week आपको पानी चेंज करना है कूलर में, फ्लावर वासेस में, because egg से लेके adult mosquitoes तक बनने में it takes around 2 weeks time. So every week अगर आप उसको change कर दोगे, so these eggs will not be converted into the adult mosquitoes. Or we can do the mosquito control. Mosquito control is done by outdoor fogging. So avoid the mosquito breeding. किसी भी कारण से, चाहे avoid the artificial water, you are putting a larvicidal fishes or you are putting the chemicals in that. We have to avoid the mosquito breeding as well as avoiding the conversion of eggs into the adult mosquitoes. Now, vaccine is also available and it is under the trial, that is Dengavaxia. Now here the one question was asked, but we should be ready with the 2-3 more questions. It is a type of live attenuated vaccine. It is dissolved in a 0.9% of the sodium chloride. same like we are using in the treatment in the dissolving the BCG vaccine or the HIV vaccine or the Japanese this HIV vaccine, yellow fever vaccine. So all these vaccines are dissolved in a normal saline. This distilled water में कौन सी dissolve हो रही है? Only the two vaccines, the measles and the MMR vaccine. While the BCG vaccine, the HIV vaccine, the yellow fever vaccine, Japanese encephalitis vaccine, and this is the dengue vaccine are dissolved in a sodium chloride. Now, in one exam, they had asked the strain of this vaccine. It is a CYDTDV is the strain. Tetravalent means it is against all the four strains. The three doses are given at an interval of the 6 months duration and to be given between 9 to 14 years of the age group. So, at least you have to remember these 2 points, the strain, and it is a type of live vaccine dissolved in a sodium chloride. And this could be also your image based question that if you find some artificial water collection around the well or around the tires or around the buckets or somewhere flower vases, so this is none other than the breeding of Aedes mosquito. Now, what is a global strategy? Not very important for the dengue. For the dengue prevention and the control, for the year 2012 till 2020, we have tried to decrease the mortality by 50%. We have tried to reduce the morbidity by 25%. So, this is all about our first group of infection, that is the vector-borne infections. So, now coming to the few questions what has been asked from this topic. Patient returned to the Delhi from Assam. On the first day, had fever, second day dizziness, third day seizures, confirmed as Plasmodium falciparum. So Plasmodium falciparum hai, so and it is coming from the Assam. So we have to give the ACTL combination with a prima queen. Now here another important point आप ध्यान रखना जब भी क्वेश्चन में है अगर patient is having the central nervous system manifestation means patient is a dizzy, having conversion, irritation, cannot take the medicine orally, then we have to give intravenous only. So chloroquine is not given, the quinine is not given because it is non-pregnant, mefloquine is not given, so we are giving the IV artesunate. Although the artemether is the drug of choice, but here it is IV is given, so IV is preferred over the oral, so it is a IV artesunate. Clear? Reinfection in the presence of the antibodies in the blood will flare up the symptoms of the dengue infection. If you want to know about the recent malarial transmission in that area, the preferred indicator is it is the infant parasite rate. Now, one more point to ask is you can write somewhere a Vaucheria bancrofti, they can be present in the urine is not seen. They can be present in the urine. They can be seen in the ascitic fluid. They can be seen in the pleural effusion, but they are not seen in the saliva. You can write somewhere the Vaucheria bancrofti are not seen in the saliva. In the central India, the most common species of the malaria parasite. Now, northeast states में falciparum है, central India में it is a vivax infection. A lady with a swollen leg, giving the history of the fever and the rigors. Swollen legs है, elephantiasis है, so this is your filariasis. A person before entering into the India had started the malaria prophylaxis. When now he is returning back to America, how long they had to continue? So after leaving that area, we have to continue for 4 weeks. So these were the few important points about this group of infection. Now the question is mass chemotherapy, how this is a secondary level prevention. Now please try to understand. As I told you, this filariasis as having a long incubation period. Agar new cases are appearing, it means the disease is being transmitted. A disease is being transmitted, it means a person must be having the microfilaria in the blood, which is being transmitted by the mosquito. So what we are doing, if we are not able to detect the microfilaria, but still we are presuming that microfilaria are present in the blood, that's why the disease is transmitting. So we are having a new cases. So our purpose is that by giving the drug, if any person is having a microfilaria which is in the hidden phase, will be treated. So that is actually a early treatment for that particular person, and because of that treatment we are preventing the others. So it is a primary for others. So in correct word, it is both primary and the secondary. Primary is for preventing the healthy person, and secondary for treating the asymptomatic patients. But if nothing has been mentioned, we have to go with the higher category, and that is your a secondary level prevention. Clear? Now another query is, so this AMPM is, yes beta, it is we are collecting माइक्रोफाइलेरियास फाइलेरिया का जो है इट इज फ्रॉम बिटवीन द 8:30 पीएम टू 11:30 पीएम. यस, सो बेसिकली बेटा यहाँ पे पेशेंट इज नॉट कमिंग टू योर सेंटर, it is an active surveillance. So multi-purpose worker is usually visiting house to house, and sometimes in the late evening in filaria endemic areas we are preparing the slide anytime between 8:30 to 11:30 p.m. And if you want to prepare in the daytime, please correct it. It is 8:30 p.m. till 11:30 p.m. 8:30 p.m. आपने पीएम नहीं लिखा है बेटा. 8:30 पीएम टिल 11:30 पीएम तो शाम को लेना है, ठीक है, दिन में नहीं लेना है. पर दिन में अगर आप लेना चाहते हो, इफ यू वांट टू टेक अ स्मीयर इन द डे टाइम, सो व्हाट वी आर डूइंग समटाइम्स वी आर गिविंग देम अ सिंगल डोज ऑफ द डाइथाइल कार्बामाजिन. वो क्या होगा कि सोते सोते ऑर्गेनिज्म को जगा देगा. जैसे रामायण में हुआ था ना, कुंभकर्ण को सोते सोते जगाया गया था. So same like if these microfilarias, they are not coming into the circulation, they are in the lymphatics. So if you are giving them the diethyl carbamazine drug, they will be getting irritated and they will come into the blood, and then you can check. Clear? So this was about a first a group, that is vector-borne diseases. Now coming to the second group of the disease, that is the zoonotic diseases. Now zoonotic diseases mein basically we are supposed to know the few important diseases like rabies and the leishmaniasis, rabies, leishmaniasis. Then we are talking about the Japanese encephalitis. We are talking about yellow fever, plague. Then we'll be talking about the two more infestations which has animals in them, that is the teniasis and the echinococcus. So and the rickettsial diseases where we had again the involvement of the animals. So basically here we should be knowing that what is the role of animals, whether they are simply transmitting the infection directly or they are acting as a reservoir, and through the vectors the disease is being transmitted. And we had a national programs for the three important diseases like a Japanese encephalitis, leishmaniasis, as well as for the rabies, because we are trying to avoid these diseases. So coming to the first very important disease is the rabies. Rabies may basically what they are supposed to ask from us, because rabies is having 100% case fatality rate. So at any cost we have to prevent the disease. So here we are giving the vaccination before the bite also, that is called as a pre-exposure to our veterinary doctors or the forest officers, or if they had a bite after the exposure, then we are giving them the vaccination again, as well as we are giving the vaccination to the community who are never vaccinated earlier. So at what stage, what are the doses we are giving, by which route we are giving, we had a different schedule for different route of administration, like an intramuscular route or the intradermal route. Another question what they ask is how we are diagnosing the rabies. The rabies is being confirmed by looking for Negri bodies inside the brain tissue. So these are the important points what we are supposed to know in a rabies infection. So what happens here? It is the rabbit animal, the saliva of a rabbit dog. It is containing the viruses, and when this is biting the human body, like anywhere, it is depositing this saliva with the viruses along with the muscles. Then these viruses they are passing along with the nerves. They reach to the central nervous system. Mainly, the site is the hypothalamus and cerebellum, and from here these viruses they are passing the message through the sympathetic and the parasympathetic system, and it is having an excessive secretion from the eyes, excessive lacrimation, excessive salivation is there, and these there is a spasm of the muscles of the pharynx, especially on the site of the water. So what we say, it's a hydrophobia, and there is an excessive secretion, salivary secretions is there. So the excessive frothing is also coming in the person who are affected with the rabies. But mainly we are not allowing our patients to reach to this stage. But if a vaccination is not given, they can die. So in the literature till now, it is said that only the 3 patients has been saved from the rabies. But what was the reason? God knows. Only by giving a supportive therapy. But in general, we say it is having an 100% mortality, case fatality rate. That's why we all are worried about this. So the point to remember about the rabies is that agent, it is caused by the ELISA virus. It is caused by the ELISA virus, and ELISA virus is two types. The first is, it is the wild virus or the street virus, which is mainly responsible for the disease. The wild virus or the street virus, which is mainly responsible for the disease. Another one, it is the fixed virus, which is used for a vaccine preparation. The fixed virus, which is used for vaccine preparation. Now, reservoirs are usually the wild animals. Please remember one practical point. Many times the patients comes to us and they say, Doctor, रात में चूहे ने काट लिया. So rabies is not seen with the rat bite. But अगर बिल्ली ने काट लिया है, cat bite है, so rabies can be possible. So nowadays a very common trend in the societies is to just pamper the cats. So be very careful with the cat. But yes, rat or chuha will not cause the disease. Now source is the saliva of a rabid animal. Saliva of a rabid animal is a source. Incubation period is on an average is 3 to 8 weeks. Secondary attack rate is 0%, means a 1% having a rabies, because here the viruses are attached to the nerves, he cannot transfer the infection to others. But yes, the 100% is the case fatality rate. Now, herd immunity is a 0. It means a person having a vaccine in the family cannot protect the others. Now, it is seen that if a state or a country it is surrounded with the water, the rabies will not seen. So the another question was asked is, which are the rabies free countries? It is usually the Australia. A rabies free country, that is Australia, because it is surrounded with the water. And the rabies free states in India, rabies free states in India are Andaman Nicobar, Andaman Nicobar Island and the Lakshadweep Island. So, rabies free states in India, they are the Andaman Nicobar Islands and the Lakshadweep Islands, and the rabies free country, it is the Australia. So, remember these points. Now, another very important point is asked is that how we can do the diagnosis. Diagnosis, the best test is demonstration of the Nagra bodies. The best is demonstration of the Nagra bodies. So first question, the Nagra bodies are seen in which disease? It is seen in the rabies. Second is, we cannot take a brain biopsy in a live person. So obviously the Nagra bodies is detected after the death in the post-mortem specimen. What these Nagra bodies are, these are the eosinophilic intracytoplasmic inclusion bodies. The next question is asked is which is the most common site for location of these Nagra bodies. The first site, it is the hippocampus, Ammon horn of the hippocampus, and the second site is the cerebellum. So it can be demonstrated in the hippocampus and the cerebellum. But if it is a alive person where we cannot take a biopsy. So what we are doing, we are trying to take this biopsy of the skin from the nape of the neck, and here we are demonstrating the viruses because they are ascending along with the nerves to the brain. So in a alive person or the animal, we are doing the skin biopsy and we are demonstrating the viral antigen. ठीक है. So be very careful whether it's a dead person and the alive person. So see, they had asked one question like this, that you had a doubt in a pet dog. So pet dog में if you had a doubt, then pet dog को तो आप मार नहीं सकते. So we have to go with the skin biopsy. Now in general what we say that if it is a street dog, then street dog ko yes you can kill and you can go for Niagara body, but as now the Animal Protection Act is there, so even we cannot kill the street dogs also. So अगर alive person है, we'll go with the skin biopsy, but if it is a dead person, we'll go with the Niagara bodies. Now very important is the management of the dog bite. Management will depend upon the grades of the dog bite. Now grade of the dog bite, the first grade is there is only the lick on intact skin. There is a lick on the intact skin means doggy आया आपको प्यार करके चाट करके चला गया, आप डर आपके अंदर डर छोड़ गया. Why it is a lick on the intact skin? We know that a skin, if it is intact, it is a multi-layered stratum corneum layer and it is protecting our body. Clear? So grade 1 is lick on the intact skin. Now grade 2, it is a nibbling or the scratch. Nibbling or the scratch, but very important, खून नहीं आया है. Nibbling or the scratch, but there is no blood. That is very important. Why it is important? That because if the blood is coming directly, the virus will enter into the circulation and within a few minutes it will be reaching to all over the body. Clear? So nibbling and scratch. Scratch hota hai, suppose if you had a fight with the dog, dog can just scratch with the nail and can deposit the saliva there. Clear? Or nibbling means the depression. You can remember these marks which you might have put on your sibling during the fight. So this is nothing. The nibbling means there is some damage or the depression in the corneal layer. So one crack is formed and through that the virus can enter, although will enter slowly, but can enter. So this is a nibbling or the scratch, but remember no blood. If it is a blood is coming, then it will be directly entering into the grade 3 bite. So what a grade 3 bite is, that any wound with the blood. any wound with the blood will be the grade 3 bite, or if there is a multiple lacerated wounds, any wound with the blood or the multiple lacerated wounds are there, or if there is a lick on the mucosa. Why it is important? The lick on the mucosal lining, because mucosal linings are the single layered tall columnar epithelium with a high vascularity below that. So if a virus is crossing this one layer, directly will enter into the circulation. So any lick on the mucous membrane. So these are the grades of the dog bite. The first grade, the lick on an intact skin. The grade 2 is a nibbling or the scratch without any blood. The grade 3 is any wound with the blood or the multiple lacerated wound or the lick on the mucous membrane. Because if we had the different type of the grades of the dog bite, we have to manage accordingly. And here the question comes how you're going to manage. They will give you a clinical situation. Like I say that you are just doing a morning walk in the park, and some dog come and just a lick on your hand, and you are wearing a shorts and just have a lick on your foot and went away. So what you are going to do? So that is that what you are supposed to do in a grade 1 bite. In the grade 1 bite, there is no action required, only we have to do the reassurance. No action is required, only the reassurance, or simple you can just clean the area. That's all. So no action is actually required, only we have to give the reassurance or clean the area. Clear? Now coming to the grade 2 bite. Now grade 2 is a nibbling or the scratch. There is a possibility that in a sometime the virus can enter. We are having a good time, so it can be prevented by the vaccination. So grade 2 bite, we are giving the vaccine plus clean the area. Just give the vaccine and clean the area. Or if it's a scratch or there or the some nibbling or the small erosions are there, or a wound care, means you have to put an antibiotic locally, or you have to just clean that area, wash that area. So vaccine or clean the area or wound care. Now grade 3 is very dangerous. Here we have to do the wound care, plus you have to give the vaccine, as well as for the immediate management you have to give the immunoglobulin also. So I hope you all had read the vaccine topic, and we had discussed that in 4 diseases we are giving vaccine and immunoglobulin simultaneously, and that was like we had discussed that tum hamare dil mein rehna is the tetanus, hepatitis B, diphtheria and the rabies. Okay, so these are the 4 diseases where we are giving active and passive simultaneously. Rest we are not giving simultaneously. This is one of them. Now the question is asked what we are supposed to do in a local wound care. Now we have to do a thorough cleaning of the wound with the running water for minimum 15 minutes. We have to do the thorough wound cleaning with the running water for minimum 15 minutes. So you just put the wound under the running tap water. So with the pressure of the water, we want that saliva with the virus should move or should wash away. So thorough cleaning of the wound with the running water. Very important is, if you find that a massive wound is there, the muscle is out, still no suture is given for 24 to 48 hours. If you have to choose one, go with the 24 hours. So thorough cleaning for minimum 15 minutes, no suture for minimum 24 hours, and we have to inject locally the immunoglobulin, and this local immunoglobulin is only given in the a grade 3 bite. अगर grade 3 bite है आपका, so we have to inject a local immunoglobulin. ठीक है, सिस्टमिक नहीं देते हैं, यहाँ पे लोकल देते हैं, बिकॉज यहाँ पे पर्पस है कि वायरस को वहीं पे मारना. So grade 3 में we are giving the local immunoglobulin, and here the question is asked is how much is the dose of the human immunoglobulin. If you are using a human immunoglobulin, the dose is 20 international units per kg of the body weight. If you are using an animal immunoglobulin, it is 40 international units per kg of the body weight. Practical point. Suppose अगर आपका weight 50 kg है and you are using an human immunoglobulin, total dose is 1000 international units. अगर आपका single wound है तो आप 1000 वहीं दे दीजिए. But if your wound are suppose 4 in number, so you have to give this 1000 unit equally distributed in all the wounds. So you can dissolve in a distilled water, and if it is a 2 ml, you can make it as a 8 ml, and you have to inject equal amount in the all the wounds. It is not that the total amount you are giving in a one wound and बाकी wound में आप कुछ नहीं दोगे, नहीं, आपको जितना total dose है, dose तो नहीं बढ़ा सकते, वो weight के हिसाब से है, तो total dose जितना भी है वो आप distribute करोगे सारे wounds में. Clear? So this is what is about the local care. Now very important, they ask about the vaccine schedule. Now vaccine अगर आपको याद हो earlier what we used to say कि टमी में यू विल बी गेटिंग अ 14 इंजेक्शन. बच्चे को डराते थे, डॉगी के पास मत जाना, कुत्ता काट जाएगा, पेट में 14 इंजेक्शन लगेंगे. मेरी माँ ने भी मुझे डराया था, बिकॉज शी हैड अ 14 इंजेक्शंस इन अ टमी इन हर चाइल्डहुड. सो what we used to say to a child that don't go near to the doggy, otherwise you'll have a 14 injections, because earlier what vaccine we were using, 10 ml was the dose, and 10 ml we cannot give intramuscular or the intradermal. It has to be given as a subcutaneous, and tummy is the best place. So earlier we were using a nervous tissue vaccine, which is not used nowadays. So we are not using nowadays the nervous tissue vaccine, and the vaccine what we are using is a chick embryo, duck embryo, or the human diploid cell vaccines, or the recombinant vaccine. So these are the vaccines what we are using. The preferred is the human diploid cell vaccine. Preferred is the human diploid cell vaccine. Clear? Now very important is the schedule. Now again listen carefully. I had told you that 3 conditions are there. One is a pre-exposure prophylaxis before the dog bite. Second is after the dog bite. After dog bite 2 conditions हो सकती हैं. एक तो already who had received the pre-exposure. पहले मैं हिंदी में बोलूँगी फिर इंग्लिश में. 2-3 डोजेस आपको याद रखनी है. एक डॉगी के काटने से पहले प्री एक्सपोजर, दूसरा पोस्ट एक्सपोजर. अब पोस्ट एक्सपोजर भी 2 कंडीशन हो सकती हैं. एक तो ऑलरेडी जिनको पहले कुछ वैक्सीन लगा हुआ है, अगर दोबारा काटेगा तो स्मॉल अमाउंट देना है. तीसरा क्या है कि जो आप और हम हैं जिसमें कभी भी वैक्सीन नहीं लगा तो हमें फुल डोज देना है. सो ये 3 तरह के वैक्सीन क्राइटेरियाज है. So 3 conditions are there. One is a pre-exposure prophylaxis before the dog bite. Second is after the dog bite in already those who had received the earlier vaccination. So we are giving a smaller dose. And the third one is like me and you who had never received the vaccine. So 3 situations are there, and mind my words, in all the conditions, whether it is a pre-exposure or the post-exposure, it is a primary level prevention, because after exposure also our purpose is to prevent the disease only. Clear? So a schedule in the pre-exposure prophylaxis. So you can put a note somewhere that pre or the post exposure, if it is prophylaxis, pre or post exposure prophylaxis, it is the primary prevention. ठीक है, pre or the post exposure, if it is a prophylaxis, it is a primary prevention. Same like we had discussed in contraception, whether we are using before the sexual act or as a emergency contraceptives, they are all to avoid the pregnancy, so they are primary level prevention. Now what is the schedule for the pre-exposure prophylaxis? The schedule what we call as a 0, 7, 21 or 28. 0, 7, 21 or 28. Here the number are the days. means on which days you are giving the injection. Day 0 means today if you are giving, that is counted as a day 0. So 0, 7, 21 or 28, any day you can choose. Now here it is given by intramuscular route. The goal is to maintain the antibody titer. If you can remember fine, although this is an AIMS level question, that antibody titer we are supposed to keep more than zero point 0.5 international units per ml, and we have to repeat the booster every 2 years. So this is how we are supposed to protect our forest officers or the veterinary doctors. Now, if it is a post-exposure prophylaxis, as I say that post-exposure prophylaxis will be in the first group, that is a vaccinated one who had already received the 0, 7, 21 or 28. Post-exposure prophylaxis in already the vaccinated one. Here we are giving the vaccine by two methods, either intramuscular or intradermal. If we are giving by the intramuscular, we write the schedule as 0, 3, and here this is the days when we are giving the vaccine. Always remember, जो day 0 है, it is not related to the day of the dog bite. It is related when you are giving the vaccine. आपको डॉग बाइट कब किया है उससे रिलेटेड नहीं है ये 0. आपका डॉग बाइट हो सकता है 2 घंटे पहले हो सकता है डॉग बाइट आपका 10 दिन पहले हो, बट जब आपने वैक्सीन लेना शुरू किया दैट विल बी द 0. सो द 0 इज रिलेटेड टू द start of the vaccine, not the dog bite. If you are giving intradermal, we write this as a 4 site on a day 0. 4 site on the day 0, and 4 site यहाँ पे क्या है, it is the 2 deltoid and the 2 lateral thigh. So 4 site पे we are giving intradermal. So now the question comes, which is supposed to be the better? Now obviously intradermal is supposed to be better over the intramuscular route. Intradermal is preferred over the intramuscular route. Why? Because it is having a better antibody production and the less dose is required. Better antibody production and the less dose is required. Suppose intramuscular में अगर आप 1 ml दे रहे हो, so intradermal में आपको खाली 0.2 ml देना है, because the intradermal dose is a 1/5 of intramuscular dose. So remember these points. कि intradermal is preferred over the intramuscular because the better antibody production and the lesser dose is required. The intradermal dose is 1/5 of the intramuscular dose. But even practically आपने देखा होगा कि some are giving the intramuscular because they are not comfortable with giving a intradermal this route. So they are giving an intramuscular. So this is your two schedule we have to remember in the post-exposure prophylaxis in vaccinated. If it is intramuscular, it is a 0, 3, these are the days. And if it is intradermal, it is a 4 site on the day 0. Clear? Now, in the vaccinated individuals, we had discussed. Now, what is in the non-vaccinated, like me and you, if you had a dog bite? So, the first regime is the ASN regime. ASN regime is the intramuscular regime, and here the schedule what we write as 0, 3, 7, 14, 28. 0, 3, 7, 14, 28, and obviously these numbers are representing the days when we are giving the vaccine. Now just forget about the Zagreb regime, it will be confusing you. And second is the Thai Red Cross regime. The Thai Red Cross regime, it is the intradermal regime, and intradermal regime what we write as it is 2, 2, 2, 0, 2. 22202, and here these numbers are representing the number of the site, means you have to give on a 2 site, 2 site, 2 site. Now question है कब देना है, on which day we have to give on these two sides. So the days will be same as the ASCEN regime. Means on the day 0 you have to give on a two side. On the day 3 you have to give on a two side. The day 7 you have to give again on a two side. Day 14 we are not calling our person to for the vaccination, and day 28 we are again giving at the two side. So the days are constant 0, 3, 7, 14, 28, and we are giving at 2, 2, 2, 0, 2 means two sites on the day 0, two sites and two sites यहाँ पे दो deltoid लेंगे, two site on a day 3, two site on a day 7, no vaccine on a day 14, two site on a day 18. So this is your Thai Red Cross regime. ठीक है? So this is very very important. So again I am repeating बिकॉज कन्फ्यूजन नहीं होना चाहिए. अगर आपको कहें कि प्री एक्सपोजर प्रोफाइलेक्सिस है, सो दिस इज 0, 7, 28 और 21, इट इज़ इन द डेज इंट्रामस्कुलर. अगर आपका पोस्ट एक्सपोजर है, सो वी कैन गिव इन ऑलरेडी वैक्सीनेटेड इंडिविजुअल्स. सो इंट्रामस्कुलर में स्मॉल डोजेज 0, 3 and the intradermal it is a 4 site on the day 0. But if it is in the non-vaccinated, intramuscular regime is called as a SN regime is 0, 3, 7, 14, 28, and the intradermal regime is called as a thyroid cross regime is the 2, 2, 2, 0, 2. This is on a two side on the same days as 0, 3, 4, 7, 14 and 28. Now one more practical point. अगर dog bite के बाद if you are able to trace the street dog or animal and after 10 days अगर dog आपका alive है, so आपको 14-28 days का वैक्सीन देने की ज़रूरत नहीं है. So if a dog is alive after 10 days, there is no need to give this 14-28. Only the 3 doses will be sufficient because अगर dog में rabies होगा तो वो 10 दिन के अंदर मर जाएगा. So if a dog is alive after the 10 days, then there is no need to give these vaccines because if a dog is having rabies, the dog will die within the 10 days. Clear? And I had already told this that rat dog bite is not causing the rabies, so there is no need to give a vaccine. But if it is a bite by the cat or any of a wild animal, a monkey even, then we have to give the rabies vaccination. So this is a very 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 important, and we should be knowing about the pre-exposure, post-exposure और intramuscular, intradermal. एग्जाम में confusion नहीं करना, ठीक है? So now one company is coming up with the vaccine Zydus Cadila. Abhi, it is not in the market and they are coming with the total 3-dose schedule. So we all are waiting. So instead of the 5 doses, then that will be enough to give the 3 doses only. So this is all. We can take a break here. So if any doubt, any query, suppose if they say that any reason if a person is not able to take in a grade 2 bite, then can he or she later develops the symptom. Now it is very difficult to say whether that actually the dog was a rabies animal, first thing, and second is how much is the viral load deposited there and how depth this virus has gone. So it is very difficult to say. Many patients they are asymptomatic because actually they don't have a virus, but some can develop the disease even after years together. So just cross your fingers if anybody you had seen a case like this, just cross your fingers because at this moment we cannot do anything. So we'll take here the lunch break, and the time by my watch is it is 1:18. So we'll take a break of 50 minutes. So we will be starting at 2:10. And meanwhile, if you had any doubt, any query, you can message me. So friends, welcome back. So we were discussing zoonotic diseases and we had covered one important disease, that is rabies. Now coming to other zoonotic diseases, and another important zoonotic disease is a Japanese encephalitis. So just try to understand that this is again a very important life cycle, because some disease life cycle they ask in examination. If we find mosquito bird cycle, and there is a role of the pigs in between, and if the mosquitoes are going towards a human, so if there's a birds and the pigs in the mosquitoes, it is the Japanese encephalitis cycle, and this is the mosquito responsible sitting parallel to the surface, no white spots on the body. So this is your Culex mosquito. So the point to remember about the Japanese encephalitis is the agent is, we had already covered which type of the arbovirus. It is the group B arbovirus. The vector is the Culex mosquito, and Culex, if you can remember the species, the filariasis was the Culex quincy fasciatus, and this is Tritineurhynchus. Now, breeding size, as we had discussed earlier, that this is breeding in a dirty water. So that's why the one question was asked is, which disease is commonly seen in the areas where we are having a rice paddy water. Now we know चावल के खेत में जब चावल का पौधा लगाते हैं, पानी से भर देते हैं, वो गंदा पानी होता है, वहाँ पे क्यूलेक्स ब्रीड करते हैं और उस एरिया में जापानीज इंसेफ्लाइटिस कॉमन होता है. सो इम्पॉर्टेंट पॉइंट इज दैट इन दोज एरियाज वेयर वी आर हैविंग अ राइस पैडी फील्ड, they are filled with the water, so they are prone for culex breeding. So it is question was asked is, which mosquito breeding is related to the rice paddy field. So rice paddy field is related to the Culex mosquitoes. Now fly range, we know that it is 9 to 11 kilometers. So if they are find an epidemic in one village, we have to look the breeding sites in another areas also. So these are the important points. Now another point is the man here, it is acting as a dead end infection, because here the virus are attached to the nerves. So a person having a Japanese encephalitis, same like a rabies, it cannot transfer the infection to others. Pigs are acting as the amplifiers. Amplifier means that the virus are increasing in the number, but the pigs never had a encephalitis. Now cattle, they are acting as a mosquito attractant, because these culex they bite in the night, and in the daytime they usually hide themselves in the hair of the tail of the cattle. So what is the role of the pigs, what is the role of the cattle, again asked in the examination. The treatment is supportive because this is a viral infection, and prevention is by the vaccine. I hope you all know about the vaccine of the Japanese encephalitis. It is a quick revision. It is a live attenuated vaccine which is dissolved in a phosphate saline buffer, not available than sodium chloride, starting at a 9 to 12 months, then second dose at 1.5 years in the endemic areas. And what are the endemic areas of leishmaniasis? The endemic areas of the leishmaniasis are the part of UP, the part of Bihar, part of Jharkhand, although we had already discussed in our derma classes, and the West Bengal. So these are the endemic areas of Japanese encephalitis, UP, Bihar, Jharkhand and the West Bengal. And as these mosquitoes are resting outside, so we have to do the outdoor fogging, and we will advise to use either the mosquito repellent net or the full close. So this is all about the Japanese encephalitis. Here mainly they had asked about the prevention. Then and a few important points what I had discussed about the epidemiology. Now coming to the next is the rickettsial diseases. Rickettsial diseases basically it is the what vector is responsible for which disease, although this is again a repetition what we had already discussed in our insect group. So please correct, this is not a louse, this should be the vector. So try to revise wherever you are, that epidemic typhus, the vector is, it is the louse. Endemic typhus, we had already discussed, it is the flea. Scrub typhus, it is the mite. Indian tick typhus, it is the heart tick. Rocky Mountain spotted fever, it is again the heart tick. Rickettsial pox, it is mite. Q fever, the first answer should be no vector. If no vector is not in the choice, you can go with the aerosol route. If aerosol is not there, then you can go with the soft tick. So remember, the first answer should be the no vector. Now, trench fever, ETR, epidemic typhus, trench fever, relapsing fever. So this is by the louse. Now, for few, you have to remember the agent also. The trench fever, Bartonella quintain. For the Q fever, Coxella burnetii. And for the three of the epidemic typhuses, on the top, like we has a Prime Video service, Prime services, Amazon Prime services. So on the top is epidemic typhus, so it's a Prowazaki. Endemic typhus, you can remember as a sandwich in between, Typhi. And scrub typhus, it's a Susugamushi is the agent for scrub typhus. Now, two more points we have to remember. As the bite site, it is covered with the central scab, it is the Ishar. Now, can you identify, we had also discussed in the leishmaniasis also, cutaneous leishmaniasis, we had a lesion with the covered with the central black scab. So, question can be coming how we are differentiating with the cutaneous leishmaniasis. In the leishmaniasis, if you had a doubt, you go with the RK39 dipstick test. Cutaneous leishmaniasis, the test will be positive and here it will be negative. Sometimes some of the rickettsial fever, they can develop as a rashes like a pox like rashes. It is a rickettsial pox. So the question is asked, Ishar is a characteristic of which a typhus? It is characteristic of the scrub typhus. So in the scrub typhus, we find the Ishar, that is a wound which is covered with the black scab. Now another question, as in the Q fever, it is transmitted mainly by the aerosol route because no vector is required. So we don't have any skin lesion. So only rickettsial disease without any skin lesion is the Q fever. So in the Q fever, we don't have a skin lesion. Ishar is present in the scrub typhus. We should remember the vector as well as the agent for these diseases. Now, next question is that what is the treatment? The drug of choice for these rickettsial diseases is the doxycycline. It is the doxycycline is the drug of choice for prophylaxis as well as for the treatment. For the prophylaxis and the treatment, the drug of choice is doxycycline. So this is about the rickettsial diseases. Now we will be talking the two diseases parallel, that is yellow fever and the plague. We know that yellow fever is caused because of the Aedes mosquito and this is a flea. We know that red flea, it is transmitted by the bite of this flea, but plague is transmitted by the bite of this flea, but pneumonic plague, it is transmitted through the aerosol. So actually what happens when this flea bites, it is the lesion, it is there and organism from that bite site reaches to the lymph nodes and we are having this lymphadenitis. It can be the axillary group of the lymph nodes are involved or the posterior auricular group of the lymph nodes are involved, and the lesion, it is from here it is spreading throughout the body. So once it is involving the lymph nodes, it is called as a bubonic phase. From the bubonic phase, it is entering into the circulation and reaching to the body, it is a septicemic phase, and when it is reaching to the lung and then the organism are passing through the droplets and droplets nuclei to the surrounding area. So this is the pneumonic type of the plague. If you have to confirm the plague, then if we take an aspirate from the lymph nodes, we are demonstrating these plague bacilli and in the Giemsa strain of that aspirate. So this is about your plague, and if you remember about the yellow fever, it is because of the Aedes mosquito. As the name suggests, it is a yellow, means a jaundice is there. So fever with the jaundice, we had high grade fever will be there. And we know that as it is a viral fever, and we can have a severe headache also, body ache also, we can have some rashes also, and some bleeding tendency also like a dengue fever. So we can have a hemorrhages from the different part of the body. Only a preventive aspect is if we can avoid the artificial water collection, or we can use the mosquito nets, or we can just do the fogging, or we are having a protective clothes are there, or we are using the vaccine. This can be only a preventive aspects. So the point to remember about these two diseases parallel is plague and the yellow fever. The agent for the plague, it is the Yersinia pestis. Yersinia pestis, and the yellow fever is, it is the group B arbovirus. So the agent is Yersinia pestis and the group B arbovirus for the yellow fever. The vector for the plague, it is the flea. Vector for the plague is the flea. This is also known as Xenopsilla chiopsis. So flea is also known as a Xenopsilla chiopsis, and the better will be the red flea because this flea is represented on the red. So the vector for the plague is the red flea, and this is also known as the zoological name is the Xenopsilla chiopsis. So sometimes we are asked as a zoological name. And the yellow fever is caused because of the mosquito, that is the Aedes mosquito. So agent is important, but more important is the vector. We have to remember the vector. The reservoir, it is the wild rat for the plague, and it is the wild animals for the yellow fever. Now incubation period, as we know that the plague, it is having 2 to 7 days of the incubation period. Please remember, if they ask what is the incubation period for the plague, you have to answer the 2 to 7 days. But they may ask what is the incubation period of the pneumonic plague, because it is transmitted through the respiratory route. The pneumonic plague incubation period is only 1 to 3 days, while the incubation period for the yellow fever is 2 to 6 days. And we had already discussed that what is a quarantine period for the yellow fever is 6 days. Quarantine is the maximum incubation period of the disease. So quarantine period for the yellow fever is 6 days. Now, which is the most common type of a plague? The most common type of the plague is the bubonic plague. But which is the most dangerous is pneumonic. Because if you even control the red fleas, the disease will be transmitting. Now, treatment is not very important. It is a streptomycin in cases of plague, and the yellow fever we have to give the supportive treatment. But yes, you can remember the chemoprophylaxis in the plague endemic area. We are giving the tetracycline to the community. Now, vaccine, plague vaccine, they usually don't ask, but it is available in both the type, killed and the live. So, it is the both the type of the vaccine, that is killed plus live for the plague, but most commonly what we are using is a kill type of the vaccine. So both the varieties are available, but most commonly we are using a killed vaccine in the plague. But yellow fever vaccine, it is a live attenuated vaccine, and we have to remember the strain also. It is a 17D, and the diluent, it is the sodium chloride or a normal saline. Now, control of the vector, because it is a vector-borne disease. Aedes are breeding in artificial water collection, so we have to avoid the mosquito breeding. And the plague ke liye, we have to spray the insecticidal agent which is killing the red flea. So, red flea index should be brought to 0 within 48 hours. Now, what is a red flea index is? Red flea index is number of a red flea per rat. So if there is any epidemic of plague, so what we do a spray, and within 48 hours we have to kill all the fleas. So what will happen now? The disease will not be actively transmitted until unless it has reached into the pneumonic phase, and we will be treating those who are affected. So rat flea index is number of the rat flea per rat. It may be thousands also, so we have to bring them to zero. Now one practical point, some of you might be becoming a medical officer. कभी भी अगर आपको लगता है कि आपके एरिया में सडनली चूहे मर रहे हैं, आपने कोई मेडिसिन भी नहीं डाला, कुछ नहीं डाला, तो ये एक प्लेग एपिडेमिक का इंडिकेशन हो सकता है. Now suppose if you see that suddenly the rats are dying without any spray of the medicine or the chemical, it may be an indication for impending plague epidemic. Now we have to remember the strategies, we all know the safe strategy for the trachoma. So one strategy for yellow fever is the eye strategy. Eye strategy is elimination of the yellow fever epidemic. It is the elimination of the yellow fever epidemic is the eye strategy. So this is about these two diseases. Now another important disease is leishmaniasis, again very commonly asked because we are trying to do the elimination. Now normally this cycle goes on, the animal scent fly cycle goes on, but sometimes these scent fly entering into the human, so the human scent fly cycle goes on. Now these are causing the fever and leading to the enlargement of the liver as well as to the spleen, and causing a blackish discoloration. So the cachectic look of the baby or the person with the abdominal distension because of the hepatosplenomegaly. It can be ending into the post-Kala-Jar dermal leishmaniasis, when we can have multiple skin nodules are there and the discharges are containing the Leishmania donovani organisms, and the scent fly can transmit them from one to another. Confirmation is by the LD bodies. When we take an aspirate from the bone marrow or the liver or the spleen or the lymph node, we can demonstrate the LD bodies inside the cell. So these are the intracytoplasmic inclusion bodies are there. So these are the LD bodies are demonstrated. So the important points about this leishmaniasis is that it is caused because of leishmania. So agent is a protozoal organism, that is leishmania. The varieties of this leishmania, Leishmania donovani, it is causing a visceral leishmaniasis. It is also known as the Kala-Azar. Visceral leishmaniasis or the Kala-Azar. Leishmania tropica, it is causing a cutaneous leishmaniasis, that is also known as the oriental sore. And the Leishmania brasiliensis, which is causing the mucocutaneous type of leishmaniasis. Now very important is the vector, could be an image based question. Straightforward the question is asked, what is this leishmaniasis is caused by? So vector is the sand fly. Again we have to remember its zoological name. It is the Phlebotomus fly. Sand fly or the Phlebotomus fly. Now one very important quality of this sand fly is that this can fly up to 6 feet height. जमीन से खाली 6 फीट ऊपर तक उड़ सकती है. So if we have to sprinkle the insecticidal spray, only we have to sprinkle up to the 6 feet, and that's why this disease leishmaniasis, it is not seen on the heights or the mountains. It is commonly seen in the plain area. So that's why we call that this disease or leishmaniasis is supposed to be a disease of the plain area. It is a disease of the plain area, and it is seen up to height of 600 meter or the 2000 feet above the sea level. So this disease is a disease of a plain area. This was the one question asked, till what height we can have a leishmaniasis. It can be seen up to the 600 meter height or the 2000 feet, because the this can fly up to the 6 feet. So this is supposed to be a disease of the plain area. Now incubation period is, in the scent fly it is 4 to 25 days, that is extrinsic. In the human body it is varying up to 1 to 4 months. Now very important point is, for the diagnosis, the peripheral test what we are using, this is the peripheral test of what we are using is the RK39 dipstick test. So whenever you had a doubt about the leishmaniasis, as we had discussed in our derma classes also, if there is a hyperpigmentary patch is there, we have to differentiate it from the leprosy and the leishmaniasis, we can go with the RK39 dipstick test. So RK39 dipstick test is detecting the proteins and it can be applied on the urine or on the blood, detecting the antibodies. Okay. So detecting the antibodies of the leishmania group of organism into the blood or the urine. Now confirmation is done by demonstrating the LD bodies. So confirmation is done by demonstrating the LD bodies, and these LD bodies are nothing the inclusion bodies, like a Negra bodies are seen in the rabies and the Leishmania donovani bodies are seen in Leishmaniasis. Now as we know that these Leishmania are the protozoal organisms which are having the flagella. So these flagella are lost in the human beings and they are present in the scent fly. So this is the question asked is, so non-flagellar form, that is also known as the non-flagell means absent of the flagella, or the amastigote form, it is seen in the man, and the flagellar form, this is also known as the promastigote form, it is seen in the scent fly. So the amastigote form, it is seen in the human beings, and the promastigote form, it is seen in the scent fly. And the aspirate for demonstrating the LD bodies, we can take it from the spleen, liver, bone marrow, or the skin lesions. Now we can do the Leishmanian test also. And Leishmanian test, as we had already discussed in the leprosy also, the tuberculosis also, it is only to see the immune status of the patient. It is never for diagnosis. So these are the important tests what we are doing. So first test is screening peripheral test, what we are doing is RK39 dipstick test, and the second confirmation is by the LD body demonstration. The very important, if we had confirmed that we have to treat the disease and the drug of choice for the treatment, it is the liposomal amphotericin B. That is a LAMP therapy, what we call as, it is the liposomal amphotericin B. So first question, what is the drug of choice? It is a liposomal amphotericin B. Second is the dose, it is given as a 10 milligram per kg of the body weight, IV infusion as single a dose. So only drawback of this drug is that it has to be given IV, so patient has to be hospitalized. 10 milligram per kg to be given as an IV. So the first drug preferred as a LAM, and the second drug what we are using, so first drug we are using as a LAM, the second drug what we are using as miltefosine. The advantage of the miltefosine is it can be given orally. And as for the post-Kala-Jar dermal leishmaniasis, we have to give a drug for a very long time. So for the post-Kala-Jar dermal leishmaniasis, the drug of choice is miltefosine. So no confusion. For the visceral leishmaniasis or the Kala-Jar, it is the LAM therapy. But for post-Kala-Jar dermal leishmaniasis, the drug of choice is miltefosine. So this is a drug of choice for the visceral leishmaniasis. Visceral leishmaniasis or any other type of leishmaniasis, like we can say the cutaneous leishmaniasis or the mucocutaneous type. But agar multiple skin nodules are there, then it is the post Kala-Jar dermal leishmaniasis है, तो drug of choice is miltefosine. So just remember, अगर उन्होंने कुछ मेंशन नहीं करा है या नो कन्फ्यूजन, आप सिंपल लिख लो विसरल लीशमैनियासिस के लिए। अगर उन्होंने कुछ में, प्लीज लिसन केयरफुली, इफ दे हैड नॉट मेंशन एनीथिंग लाइक कि इट इज द पोस्ट कालाजार और द कालाजार और it's a leishmaniasis or dermal leishmaniasis. So first choice should be, the drug of choice is liposomal amphotericin B. But if there is a multiple skin nodules as a post kalarjar dermal leishmaniasis, in that it is a miltefosine because it is given orally. Now, as the vector is the scent fly and the quality is scent fly that it cannot fly beyond the 6 feet. And one very important point more is that mosquito has developed the resistance to the DDT, but scent flies is still responding to the DDT. So, the vector control may, they still we prefer as a DDT the drug of choice. So, first drug is a DDT. Second drug we can use the BSC. BSC is a benzene hexachloride. It has to be sprinkled up to 6 feet height only, and we know that DDT is a residual effect lasts for 6 to 12 months. So, we are doing the spray every 6 months twice a year. Malathion ka every 3 months, DDT ka every 6 months. So, the basic knowledge of what vector control we had used earlier or we had studied earlier, it will be utilized in control of the vector while talking about the diseases. Now, what is the goal is the elimination of the disease by 2020. So, we have to remember the goals also and how we are achieving this goal. We know that active surveillance is done by ASHA worker. So, ASHA is an active surveillance worker for leishmaniasis, like a multipurpose worker male is for the malaria. The ASHA is searching the patient's house to house, and any doubt she can go for RK39 dipstick test. So, we have to search our patients every 3 months, and every 3 months for continuously 15 days we are searching the patients. This is called as a Kala-Azar fortnight survey. We are checking for the antibodies in the urine or the blood by RK39 dipstick test. Those who are positive, we are giving them a single dose of LAM therapy, and we are controlling the vector. Means the management is all those by the activities which we had already discussed in that particular disease. So, this is about a very important disease as leishmaniasis. Now, 3 diseases will be talking parallel as a KFD, brucellosis and leptospirosis. Now, KFD, it is a monkey disease. So, monkey tick cycle goes on. So, whenever these monkeys are entering into the residential area, these tick are causing the hemorrhagic fever into the human beings. The brucellosis is commonly seen in the farmers who are dealing with the animals and cattle, because they are dealing with their urine, their placenta, blood. So, from the organisms, either through the contact of the wound in the skin or by splash of a blood in the eyes or by drinking the milk of those animals, these organisms are entering inside our body and they are causing a low grade fever for a very long time, and it is a group B bioterrorism agent. And this is again an important image based question. जहाँ पे भी आपको लगता है water bodies हैं, rat है, and there is a presence of the rashes or the fever, it is a leptospirosis, because whenever there is a water, these rats are coming out from their burrows inside, they are passing the urine and organisms are coming in the urine, leptospiras, and they are mixing with the water. So, if this water is touching our body, either the eye mucosa or entering into the oral cavity or any of the wound present in the skin, these leptospira will enter inside our body. So, the point to remember about these 3 diseases, that is a KFD, brucellosis or the leptospirosis. The agent not very commonly asked is the group B arbovirus for the KFD, the Brucella melitensis for brucellosis and the Leptospira interrogans, but very commonly they ask about the vector. So, vector for the KFD outside India, it is the soft tick, but inside India it is the hard tick. Outside India it is the soft tick, inside India it is the hard tick. And again we have to remember the zoological name of the hard tick, that is just correct, is it is not a hemoptysis, it is Haemaphysalis Hemophysalis spinigera. Hemophysalis spinigera is the zoological name for heart tick. Brucellosis, it is through the food or through the airborne or by the direct contact. So, because there is no vector involved, so directly we say the source of infection. The first most important is the direct contact of the infected body tissue secretions, or it can be through the food or the airborne. And very important ask is in the leptospirosis, it is the urine of the infected rat. So leptospirosis, the source is the urine of the infected rat. Brucellosis, it is a direct contact with the infected body tissues or the secretions, and in the KFD it is the vector. Now reservoir again is important, that in the KFD it is the monkey, domestic animals in the brucellosis, and the rat is in the leptospirosis. Clinical features, it is not very much as, it is just a mix a feature in the clinical situation. The all are causing the fever with the chills and rigors, and there could be the body ache. So we are trying to find out the important keywords in the given question. So keywords are the rat urine, the rats are there, and if we do the diagnosis for KFD, as this is a viral disease, so it is only by the RT-PCR. But for the brucellosis, yes, we can detect the antibodies by the two tests, and that this we have to remember the name of the test, that is a Rose Bengal test and the milk ring test. So either we are detecting the bacteria by the RT-PCR, or the antibodies are detected by the Rose Bengal test or the milk ring test. And in the leptospirosis, by demonstrating the leptospira in the urine or the blood. So these are the important diagnostic points. The treatment is supportive for the KFD as viral disease. Now we have to remember the drug of choice for the brucellosis. This was asked, it is a doxycycline. As well as maximum cases, the mild cases, the doxycycline we are giving in the leptospirosis also. And for the chemoprophylaxis of the leptospirosis, it is again a doxycycline. So sometimes if you are going in an areas where we are coming in contact with the water games and the water bodies, some prefer to take a doxycycline in advance to avoid this leptospirosis. Now, brucellosis, as it is transmitting from the animals, so we are giving the vaccine to the cattle who are giving the milk and producing the babies, and to the farmers. So the live vaccine we are using to avoid the brucellosis, and this is given to the female cattle and the farmers, and KFD can be prevented by the killed vaccines. So these are the important points about these three diseases: parallel, KFD, brucellosis, and leptospirosis. Now the two worms we can have where there is the involvement of the animals. The one is the echinococcosis. Echinococcosis, usually the dogs are supposed to be the definitive host. They are passing the eggs into the stool, and if it is through the food and other items, it is entering into the human body. Then in the human, from the intestine, these are reaching into the reaching into the liver, and liver they are forming a hydrated cyst. So these are the presentations of the echinococcosis. Hydrated cysts, mostly they are asymptomatic, but if they are bigger one, they can cause the pressure symptoms, and we have to operate for these big hydrated cysts. Now one practical point here I want to share, that if we are trying to, although we have to remove any of the lesion or any of the tumor or the mass in a single frame, but if you are trying to remove such a big cyst, you have to give a very long incision, and the fluid sometimes can spill out and can cause allergic manifestations. So practically what we are doing, we are putting a suction cannula inside, sucking out the fluid, and then the collapsed cyst wall is removed. So this is about the echinococcosis. Now if it is a teniasis, there is an involvement of the pig or the cattle. So if you are eating the improperly cooked pork or the beef, the organisms they are entering from the oral cavity. Here their worms are growing and causing adult teniasis, and sometimes some of these proglottids they penetrate the intestinal mucosal lining, reaching to the human muscles, causing the human cysticercosis, or sometimes they can reach to the brain and can lead to the neurocysticercosis. And in this, sometimes a person is presenting with the asymptomatically, patient was absolutely fine, suddenly patient starts showing the fits and convulsions, and on investigations with the CT or the MRI and some space occupying lesion with the cyst inside we can find, and this is what is a neurocysticercosis. And you might have seen some of the patients are saying that डॉक्टर साहब ने बोला है दिमाग में कीड़े हैं 5 साल दवाई चलेगी. So some of the patients they say that doctor told us that there's a worms in the brain and we have to take a medicine for 4 to 5 years. So this is what is the neurocysticercosis. So here the point what we have to remember about these two diseases, we'll be talking again parallel. The agent not very commonly asked is Echinococcus granulosus in the echinococcosis, and the Tinea solium is related to the pork, or the Saginata related to the beef. This you can remember. The solium is with the pork and the Saginata it is with the beef. Definitive host is again very important for echinococcosis. It is the dogs are supposed to be the definitive host, while in Teniasis the man is supposed to be the definitive host. Intermediate host in echinococcosis is the man, while here it is the pigs and the cattle, they are the intermediate host. Clear? So remember, for the dog in the definitive host in echinococcosis, and the intermediate host in the Teniasis is the pig or the cattle. Now, clinical feature is hydrated cyst, again very commonly asked, that hydrated cyst is related to which disease. Now, another commonly asked question is, which is the most common site? It is seen in the posterior superior lobe of right lobe of liver. So this is seen in the posterior superior lobe of the right lobe of liver. So organ is liver, and in the right lobe, and right lobe may be posterior superior lobe. It is the clinical manifestation of the echinococcosis as hydrated cyst. Now in the Teniasis, it is present in the intestine causing a teniasis. If it is present in the muscle of the man, it is a cysticercosis. If it is present in the brain, it is the neurocysticercosis. So three sites can be the teniasis, cysticercosis or neurocysticercosis. Now the treatment, mebendazole or albendazole we are using for the treatment of echinococcosis. Now just remember, if you are treating the neurocysticercosis, the drug should cross the blood-brain barrier. But whatever the drug we are using for treatment of the teniasis is praziquantel or niclosamide, they are not crossing the blood-brain barrier. So if a question is asked what is the drug of choice for neurocysticercosis, it is the albendazole, because it is crossing the blood-brain barrier. Along with that, we are giving the steroids because it is reducing the inflammation. Along with that, we are giving the anti-epileptic drugs because the person are throwing the fit. So in the neurocysticercosis, we are giving the albendazole, steroids and the anti-epileptics, while for rest of the conditions, we are giving praziquantel or niclosamide. Now here one very important practical point है कि whenever we are giving the drugs, then they are killing the worms. Worms are very irritated, so they can penetrate the intestine and more of an entry inside the body. So we are giving them with the laxatives. So जैसे ही drugs आएगी, it is killing the worm, and with the laxatives or the diarrheal drugs, it is being flushed out. So the worm will not be able to penetrate. So this is about your echinococcosis and teniasis. And the last disease in this zoonotic group is that Nipah virus disease. So Nipah virus is actually image based question is asked for the cycle. A few years back we had Nipah virus seen in the Kerala, and it was related to the fruit bat. So these bats were contaminating the fruits with their secretions or with their urine or other excretions, and when the person was eating these contaminated fruits, or they are coming in contact with an infected person because it was transmitting through the respiratory route, then the person was having a this infection, and it was highly fatal. So the point to remember about the Nipah virus was that the short incubation period was as 4 to 14 days, obviously caused by the virus, And mode of the transmission was either the direct contact with the infected bat or the infected pigs or the infected people, either coming in contact with the bat, pigs or the people, or by consumption of the raw fruit which has been contaminated with the bat secretions or excretions. So these were the mode of transmission, very important. We have to remember this life cycle also. So we had seen that life cycle of malaria, the life cycle of Nipah virus, the life cycle of the Japanese encephalitis, very commonly asked life cycle of the leptospirosis. Again, they very commonly asked as an image based question. Clinical features, some was having no symptoms, some was having a respiratory tract infection. But why it was risky, that the case fatality rate was very high, up to 40 to 75%. And diagnosis as the viral infection, so was the RT-PCR only. So these are the important points about the zoonotic diseases. Now let's quickly see the questions which has been related to this. Is one was a question: a pregnant lady had the rabbit dog bite with the minor scratches, line of action. Now here minor scratch, so this is a grade 2 bite. But only the question was examiner wants to ask from you, because we all know we have to give the vaccine. But here examiner wants to ask from you, can we give the rabies vaccine in pregnancy? Answer is big yes, because the rabies is a kill type of the vaccine and it is very safe in pregnancy. But even if it would have been a live vaccine, we are giving because life is more important. So yes, in the pregnancy we are giving the rabies vaccine. So clean the wound and no vaccine, no. Clean the wound with the vaccine, yes. Clean the wound with the vaccine and immunoglobulin, no immunoglobulin is required because it's a minor scratch, no action needed, no. We have to give the vaccine with cleaning the wound. Clear? Rabies free state in the or the union territory, as we had already discussed, the water covered bodies. So the Andaman Nicobar Islands are the rabies free states in India. So these were the questions related to this group, that is a zoonotic group. Now we'll be moving to the another group. Now, one query is that in the grade 2 bite and the dog died after the 10 days because of the rabies and the patient didn't receive the vaccine. Grade 2 bite and the dog died after the 10 days. Anytime if you are means if you are able to know within a week or the within a month or within a 2 month, it is better you can take the vaccine. But if you had not taken the vaccine at all, now nothing can be done at this moment. Just cross your fingers and we have to wait and watch. Clear? Second is, after the dog bite, maximum time to give the first dose of the vaccine. There is no maximum time limit. The best is as soon as possible you have to take. Even you can take after a week also, after 10 days also, after 15 days also. जब भी आपको याद आ जाए तब ले लो. As soon as possible you can take. There is no maximum time limit. In clinical practice, I saw many doctors that they are giving the tetanus injection before the rabies vaccine. Now, why they are giving a tetanus injections along with the rabies vaccine is because dogs are playing in the soil, and when the dogs are biting, with that bite their saliva, because they are also scratching, so there is a possibility that some soil can be coming in contact, or you might be fighting, you may fall on the ground, so the dust can be there. So in that case, to avoid that dust related infection, that is the tetanus, we are giving a anti-tetanus vaccine. Otherwise it is not related to the rabies disease. I still remember I was in my village, and in the morning so this is what I told you, that tetanus we are giving just to avoid the any problem related to the soil contamination, and anti-rabies vaccine is to specifically avoid the rabies. And TT vaccine is sometimes easily available. So first we can give the TT vaccine, and then we have to arrange the rabies vaccine if it is not available. Okay, so both can be given, no problem. And second is also that if we are having a injury, there is an we can say the anaerobic atmosphere, necrosis of the tissue can happen, and that can favor the growth of the anaerobic organisms. And if it is contaminated with the soil, the tetanus spore can germinate, and that's why for the safety we are giving the tetanus vaccine. So this was all about the second group, that is the zoonotic infections. Now coming to the third group, that is sexually transmitted infections. Now here we will not be talking about the lesions, what we had already discussed in our derma classes. Here we are mainly concerned about the guidelines of our National AIDS Control Organization or National AIDS Control Program, NACO guidelines. What are the guidelines of the Suraksha clinics? What are the 7 color kits, although we had studied in our derma classes also? Who are considered as a high risk individuals for STDs? How we are doing their screening? Once we are diagnosed, how we are treating them? What are the guidelines of the national program? How we are preventing the transmission from the mother to the baby? All these we are studying in this section of sexually transmitted infections. So the third group of the disease is the STDs, and we all know that we are having the Suraksha clinics. So this is important logo. This is a logo for red ribbon. Jahan pe bhi hai, it is a logo for AIDS, because they say the red color is the color of the love, and these patients are not transmitting infection if you are simply sitting with them or talking with them or eating with them. So we have to love those individuals. So this is what is the NACO red ribbon, and like a pink ribbon we say it's for prevention of the cancers. The breast cancer, the cervix cancer prevention is the pink ribbon we are using. Then this is the logo for the Suraksha clinics. It's a cross sign with the dot inside. This was one in exam, they asked about this logo. And in the Suraksha clinics, we had a 7 color kits. We had already discussed this point. So first is what services are being provided by the Suraksha clinics. They are providing the RTI services or the STI services. Now RTI is a reproductive tract infection or sexually reproductive tract infection and the sexually transmitted infections. Now here we are treating based on the symptoms, not on the diagnosis. That is called as the syndromic approach of management. So Suraksha clinics are providing the RTI or the STI services. Here the treatment is done based on the symptoms, not on the diagnosis. We are having the 7 color kits are there, and these Suraksha clinics are present from district hospital onwards. They are present from the district hospital onwards. 7 color kits we had remembered with the one mnemonic: grey girl wearing beautiful, grey girl wearing beautiful red yellow bangle. So grey girl wearing beautiful red yellow bangle is the mnemonic for our colors of the kit what we are using for the Suraksha clinic. Okay. Now grey color kit, it is used for urethral discharge or the anorectal discharge. The grey color we are using for the urethral or the anorectal discharge. Green color kit we are using for a vaginal discharge. So grey we are using for urethral anorectal discharge. The grey color kit we are using the vaginal discharge. We are having the genital ulcers. Most of them they are responding to the penicillin because these are non-viral. If it is a viral or the herpes ulcers, we are giving the red color kit for the herpes genital ulcers. If it is a non-herpes, obviously they will respond to the penicillin. So we are giving the white color for the non-herpetic ulcers which are responding to the penicillin. But some are the allergic to the penicillin and non-herpetic. So we are giving them the other drugs. So a blue color kit we are giving for the genital ulcers which are, please correct, this is herpetic word is wrong, which are non-herpetic and they are allergic to the penicillin. So we are having the other drugs like doxycycline we had in that. So this is a blue color kit is there, and the red color kit is for the genital ulcer which are herpes in origin. The yellow color kit we are giving for the lower abdominal pain. And the black color kit is given for the inguinal buboes. So buboes are nothing but the inflamed lymph nodes. Now, if you are not able to remember all four, at least remember all seven, at least remember these four because these are very commonly asked in the examination. Now, one more point in one question they would ask is patient is coming with both vaginal discharge and the abdominal pain. So, we have to give the importance to the higher category, and higher category is the pain because it may be because of the PID. So, here we had to go with the yellow color kit. Now, how we are trying to identify the cases? The first is we are trying to screen the high risk cases. So, this is one question. Who are considered as high risk cases for STDs? Sex workers, transgenders, man having the sex with man, long distance truck drivers, street children, or the IV drug users. So they are considered to be as a high risk for STDs. Now, one very practical point is during the sexual activity, if there is a damage to the genital mucosal linings, there is a high possibility of transmission. So, if there is any presence of the ulcer there or any lesion which is causing the ulceration or the erosion, so higher possibility of the transmission of infection, one thing. Second is the homosexual transmission is a more. If it is a man-to-man sex is there, so more damage to the anal mucosal lining and there is a higher possibility of the transmission in comparison to the heterosexual route because the vagina is bigger diameter size and it is having a elasticity. So these are the important practical points we have to remember. Now, coming to the other high risk individuals where we can detect. So, first we'll do the screening in these high risk groups, and any one of them is positive, we'll try to identify their close contacts. So, the contact tracing, and again we are trying to find out the more and more cases. Then third is the cluster testing. Just try to understand what this is the cluster testing. Cluster hota hai groups. It means if we are trying to screen in a group, and कौन से group हैं, we are trying to screen all individuals moving in the same socio-sexual background. Now what it means? Now suppose a male person who is 30 year by age, who is driver by occupation, and who is belonging to the low socio-economic status. Clear? Now he has to do some job to support the family. He is living in a village, not able to get any job there, so he moved to the city. In the city, he got a driver job. Now, as he is a driver, so he is usually away from the house because it's a long distance truck driver, away from the house for a long time. As he is in a sexually active age group, can go in a wrong place, can have the infection. So, we are trying to test all over the drivers of the same age group who are coming from the low socioeconomic status, may not be in a direct contact of a positive person because they had the same mindset, so they can be having the infection. So this is what is the testing of all the individuals moving in the same socio-sexual background. So in this way, we are trying to find out the more and more hidden cases. So what type of this surveillance is known as? Active, passive, or sentinel? Can you message me? What type of the surveillance is known as when we are trying to find out the hidden cases? It is active, passive, or sentinel. What type of surveillance it can be? Yes, excellent. So this is your sentinel surveillance. Excellent, excellent. So this type of the surveillance is, it is the sentinel surveillance where we are trying to find out the hidden cases. Now we'll be talking about a few points about the HIV and the AIDS. We know that it is caused because of the HIV 1 and 2 virus. Incubation period is supposed to be the 10 years. Means from the HIV infection to develop the AIDS manifestation, it takes 10 years. So the most common age group is around 30 to 35 years. Because sexual activity starts around 20, has an infection. So 10 years ke baad mein we can have the disease. The prevalence of the disease is 0.26% in India. Although this appears to be quite low, but as we had a high population, so overall prevalence is very high. What is supposed to be the window period? The window period is the time interval between entry of the organism, to first detectable antibody. Suppose today you had a contact, and suppose after a day or two you try to do the ELISA, it will negative because body takes some time for antibodies to develop and to reach to that concentration that it can be detected by the a test. So this is what is the window period and time interval between entry of the organism and the first detectable antibody. And this window period is supposed to be the 3 weeks to 12 weeks. So now the next question is, in this period, if you want to check for the infection, you are not going for antibodies, you are going for directly detection of the antigen, clear, or the virus. So the test for detecting the infection in the window period, the best will be the RT-PCR. If RT-PCR is not given in your choice, you can go with the P24 antigen. So very commonly the question is asked like this: a HIV positive mother has delivered a baby, and we know that time of transmission from the mother to the baby is at the time of the delivery, and on the day 15 of the neonate life, if you want to check for the transmission from the mother, what test you will do, ELISA or P24. So because now the baby is in the window period, so we are not doing an ELISA, we are going for P24 antigen. Clear? अगर RT-PCR दिया है तो best will be the RT-PCR, RT-PCR नहीं है तो it will be P24 antigen. Now how much is there is a possibility of the transmission by the various route? If it is a sexual route, which is supposed to be the most common, but it is least dangerous, and the transmission is only 1:10,000. The transmission is only 1:10,000. But if it is parenteral, means either through the blood transfusion or the prick, it is least common, but it is most dangerous. So parenteral is least common, it is most dangerous. The most dangerous is through the blood transfusion. If accidentally the blood is transfused, 95% can have the infection. Following the needle prick, it is 1:300, or we can say 0.33% is the possibility of the transmission. Needle sharing, it is having a transmission risk of 0.66%. It is by needle sharing. Now, mother to child transmission, very, very important. There is a possibility up to 30% transmission from the mother to the baby. So earlier, if a mother was HIV positive, we usually advise them to have an abortion and then start the treatment, because there was a possibility of transmission. But now we are giving the treatment to the mother as well as to the prophylaxis to the baby, so we can reduce the transmission. So we can allow the HIV positive mother to have a pregnancy. Now breastfeeding is also not safe, and there is a risk of 12 to 16% transmission from the mother to the baby. So these are the possibilities of the transmission and asked in the examination. Now coming to what are the various stages, not very commonly asked. We are not supposed to remember the each and one. Just remember ki normal CD4 count is reduced, and if it is above 500 in the normal adults, we don't have an opportunistic infection. So in the children more than 6 years or in adults, the stage 1 is when the CD4 count is more than 500, it is safe. Below that we can have an infections. Just remember this. Clinical features, we know that in early stage simple viral infection की तरह से होता है. Then a patient can pass into the asymptomatic carrier stage. Then we can have a AIDS related complex like diarrhea for more than 1 month, the fever for more than 1 month, weight loss of more than 10%. So if whenever we come across a person having a diarrhea of unknown origin for more than 1 month, fever of unknown cause for more than 1 month, weight loss, we can go with the ELISA for HIV. And if we consider as a person with fever with cough and weight loss, we can investigate for tuberculosis. Now, if a CD4 count further reduces, we can have the opportunistic infections. And here the question is asked that at what CD4 count we can have what type of an opportunistic infection, or this can be a clue to a clinical story. If the CD4 count is more than 500, then there is no infection. Between the 500 to the 200, tuberculosis, candidiasis and the Kaposi sarcoma. Now tuberculosis is the most common opportunistic infection seen in the India. So most common opportunistic infection in India is tuberculosis. If it is 200, we can have pneumocystis cerevisiae pneumonia, fungal infections like cryptococcal meningitis and coccidioidomycosis. And pneumocystis cerevisiae pneumonia is most common opportunistic infection in the world. So most common opportunistic infection in the world is Pneumocystis cerevisiae pneumonia, and in India it is the tuberculosis. Now if it is 100 to 50, then we can have toxoplasmosis and the diarrhea because of the cryptosporidiosis. Less than 50, we can have the CMV retinitis, cytomegalovirus retinitis, or the MAC, that is a Mycobacterium avium complex. Mycobacterium avium complex. We can have some malignancies also with the HIV, like Kaposi sarcoma, non-Hodgkin's lymphoma, and the cervix cancer. This is not a cervical, it is a cervix cancer. Cervix cancer. Now see how they ask a clinical situations related to the opportunistic infection. Suppose if they say a 40-year-old man is reporting to the clinic with a cough for 2 months and on bronchoalveolar lavage in the Gomori-methamine stain, we are finding these fungal cysts are visible, or simple in the gram staining, we can find these fungal cysts are there, and the CD4 count is 150. What is the diagnosis? And on the X-ray, there is a bilateral hilar opacities. So, अगर CD4 count 150 है, below the 500 है, it means there is some opportunistic infections. And if they are talking about that fungal cyst is seen in the bronchoalveolar lavage and bilateral hilar opacities are there, so this is none other than the Pneumocystis cerevisiae pneumonia. So like that they can ask the diagnosis, and it can become your medicine question. They can ask what is the treatment, again it is a medicine or the side effect of the drug or the mechanism of action of the drug, it may be your pharma question. And if they ask anything about the National AIDS Control Program, it become your PSM question. So like that they can give you the clinical stories. So in the Pneumocystis cerevisiae pneumonia, the best is important, the CD4 count is between 200 to 100. So less than 200 or the 200 to 100. The fungal cyst we find in the bronchoalveolar lavage. BAL is a bronchoalveolar lavage. Bronchoalveolar lavage. X-ray में bilateral hilar opacities are there. The drug of choice for treatment is the cotrimoxazole as well as for the prophylaxis. Now another, they can ask you that a 40-year-old person is coming with the conversions, the neck stiffness, and on examination of the CT scan, we find the multiple eccentric opacities are present. CD4 count, it is 70 or less than 100. So what will be this diagnosis? So if the CD4 count is less than 100, it is because of the toxoplasmosis. The presenting symptom can be the seizure or the neurological damage. We can have a ring enhancing opacities are there, and the treatment is pyrimethamine, sulfadiazine, and the leucovorin, and the prevention is cotrimoxazole. So again, this is a medicine question basically, but it can be linked as opportunistic infections. Now, if we say that person is coming with the loss and the vision loss, and on examination we can find as a PISA-Pi appearance of retinitis. So this is the CMV retinitis. CD4 count is less than 50. Okay, and the drug of choice is the gencyclovir. Same if a image based question, that if vascular tumors are present in the oral cavity or on the hand, it is a Kaposi sarcoma. CD4 count is between 500 to 200, and this is a vascular tumors are there. Or we can have a cryptococcal meningitis. Again, they say the person is coming with the neck stiffness on examination. There is a fever, the neck stiffness, the Cunning sign is positive, and on taking a CSF examination, it is showing a fungal cysts are there, and the CD4 count is less than 200. So this is your cryptococcal meningitis. So clinical features of meningitis will be there. Then CSF examination will show the fungus infection, and we are treating with the liposomal amphotericin B. So they can give you a clinical story, and here the catchword is the CD4 count. Clear? Now coming to the diagnosis, how we do the diagnosis of this infection, the HIV, the first is doing by the screening. Now screening is done by the three tests, that is ELISA, rapid and the simple. So E stands for ELISA, R stands for rapid and the simple. So screening is done by ELISA, rapid and the simple, and the sensitivity of the screening test are more than 99%. So means they are trying to detect more and more of the patients on the cost of the false positive results. Now currently we are using the fourth generation screening test. These are actually the third generation test. Third generation test where we are detecting the antibodies. If we are using the fourth generation test, which are detecting the antibodies with the P24 antigen, these are having the sensitivity of more than 99.9%. So fourth generation tests are having the sensitivity of more than 99.9%. Confirmation is done by a Western blot test. In India, in our NACO program, we say it is by the Western blot test. But as per the world guidelines, they say the confirmation can be done by RT-PCR. So as per the Indian guidelines, the confirmation is by the Western blot, and as per the world guideline, it is by the RT-PCR test. It is having the specificity of more than 99.9%. Other tests we can go for a CD4 count, the viral load and others. We had already discussed in window period में we'll prefer with the RT-PCR, नहीं है तो P24 antigen. So this is about the diagnosis. Now once we had diagnosed, we have to treat the patients, and the treatment depends upon the 2-3 conditions. First is we'll be talking as the treatment in the general population who had been confirmed with the HIV infection. Second is if a person is having a surgical exposure or the sexual exposure, like we are the medical doctors. Suppose we had operated on a patient, we had some prick, and in the morning we come to know that that person is having an HIV infection, what to do? If you had a sexual exposure, later on comes to know that a person is HIV positive, what to do? Or how to prevent the transmission from the mother to the baby. So these are the three situations where we'll be talking about the treatment. So first group is treatment of the HIV positive or the AIDS patients. Here we are giving the drugs that is called as HAART therapy or the highly active ART treatment. Highly active ART drugs we are giving. The question is when to start. कब start करना है? It to be started as soon as possible on the diagnosis. जितनी जल्दी पता चले diagnosis पे we have to start. Every patient who is HIV positive should take the drug. So to whom we have to give? To the PLHIB, all the people living with HIV. All the people living with HIV, we have to give the drug. How long we have to give? We have to give the lifelong treatment. Lifelong drug we have to give. It is the FDC therapy. FDC therapy we are using at 2 places, in the HIV as well as in the tuberculosis. Now what this FDC is, it is a fixed dose combination. fixed dose combination matlab single tablet it is having all the desired drugs. So person has to take either one tablet or the two tablet or one and half based on the weight. So weight के हिसाब से उसको number of the tablets लेनी है, एक ही tablet में सारी drugs होती हैं. So it is a fixed dose combination therapy. First line drugs what we are giving for HIV, it is the tenofovir, lamivudine and the dolutegravir. Tenofovir, lamivudine and the dolutegravir. If it is not responding, then we are giving a second line drug as zidovudine, lamivudine and any of the combination like lopinavir, ritonavir or the atazanavir or ritonavir. दोनों में से कोई एक. So zidovudine, lamivudine and any one of this combination. ठीक है, ये नहीं कि ये तीन लो या नीचे वाले लो, नहीं, ये ड्रग लेनी है, ये ड्रग लेनी है और इनमें से कोई भी any one of this combination. Clear? So this is your second line drug. So this is how we are treating all the patients who have been confirmed with HIV. Now second is post exposure prophylaxis. Post exposure means after the sexual or surgical. It is prophylaxis. Why? Because अभी patient exposed person में disease start नहीं हुई है, हम उसको prevent कर रहे हैं. So this is a post exposure prophylaxis. When to start? Again, as soon as possible, maximum within 72 hours, as soon as possible, maximum within 72 hours, but for the best results within 2 hours. So वैसे तो जितनी जल्दी शुरू करें उतना अच्छा है. लास्ट हम 72 आवर्स तक दे सकते हैं, लेकिन अगर 2 घंटे में शुरू कर दिया तो उससे बेस्ट रिजल्ट्स हैं. सो बेस्ट रिजल्ट इज विद इन 2 आवर्स. हाउ लॉन्ग वी हैव टू गिव? यहाँ पे वी आर गिविंग फॉर द 4 वीक्स, लेकिन वी आर चेकिंग द एंटीबॉडीज आफ्टर द विंडो पीरियड. सो टेस्ट इज डन बाय ELISA आफ्टर 3 months. So test is done by ELISA after 3 months. So this is your post exposure prophylaxis, the second group. So first we had discussed in the treatment of an HIV or the AIDS person. Second is post exposure prophylaxis. Now third is prevention from mother to the baby, and the drugs what we are using in the post exposure, either the dolutegravir or the raltegravir, tenofovir and emtricitabine. Now the third is prevention from parents to the child transmission, PPTCT. So this is a branch of the National AIDS Control Program, and this is the logo of this. जब भी red ribbon होता है, it's related to the AIDS. It is protecting the family. So this is preventing the transmission from the parents to the baby. Now here the question is, mother can be in 2 states. या तो mother is a known case of HIV who is taking the treatment, and if she becomes pregnant, क्या करना है उसको? Whether she has to stop the medicine or she has to continue the medicine, this is the first question. Second is, if she doesn't know the status, during the antenatal checkup, if she comes to know that she is having an HIV, what to do? Whether she had to abort the pregnancy or she has to continue the pregnancy without medication, take the medicine after the delivery, or she has to start the medicine. So always remember, अगर पेशेंट मेडिसिन ले रही है एंड प्रेगनेंसी हो गई, कंटिन्यू रखना है. इफ अ पेशेंट इज ऑन द मेडिकेशन, शी कंसीव्ड, नो प्रॉब्लम, शी हैज टू कंटिन्यू द मेडिसिन इवन इन द फर्स्ट ट्राइमेस्टर. There is no side effects to the baby. This is what an examiner wants to ask from you. Second is, if she had been diagnosed during the pregnancy, she has to start as soon as possible, even in the first trimester. She has to take throughout the pregnancy. And after the delivery, she has to continue lifelong. And in addition, we had to give the drugs to the baby for prophylaxis. This is what a total treatment. So, we'll talk this under the two headings in the baby and the mother. So, in the mother, if she's a known case of HIV, continue the ART even in first trimester. Continue the ART even in the first trimester. If she is diagnosed during the, just cut it, it is the ANC screening. Start the therapy as soon as possible. If diagnosed during the ANC, start the ART as soon as possible. Continue during pregnancy, delivery, and the breastfeeding. Continue during delivery, pregnancy, and the breastfeeding, and lifelong. So this is what is the mother section. Only these 2 points are important. What examiner wants to ask: she is a known case of HIV, what to do? If she has been diagnosed for the first time, what to do? So we have to start as soon as possible or continue the ART. Now as the baby is born, baby is having the infection at the time of the delivery, so we have to give the prophylaxis to the baby. So when we have to start, the same question, it has to start as soon as possible, maximum within 72 hours, best within 2 hours. Maximum within 72 hours, best within 2 hours. Here we are giving for 6 weeks to 18 months. Depending upon the follow-up results. Minimum is for 6 weeks, can extend up to 18 months as prophylaxis. What drugs we are using? The two drugs we can use. The first is nevirapine. Nevirapine, its efficacy is 50%, means it is able to stop the transmission by 50%. It is preferred because it is given once a day. Nevirapine efficacy is 50%, it is preferred because it is given once a day. Second drug is zidovudine. Its efficacy is 66%. It is the best drug because its efficacy is 66%, but even it is not preferred because it has to be given twice a day. And छोटे बच्चे में drugs देना बहुत मुश्किल है. It's very difficult to give a medicine to the small baby because once we give the medicine, baby vomit out. So we have to repeat the dose. So preferred is a nevirapine because we are giving once a day. What to do with the breastfeeding? Because we had seen that breastfeeding is also transmitting 12 to 16%. In the developing countries, we say breastfeeding is permitted. Because if you are not giving the breastfeeding, we can have the more complications in the baby. But in the developed countries, it is contraindicated. Developing countries it is permitted, but in the developed countries it is contraindicated. And one important point, जैसे कि we had already discussed that exclusive feed for 6 months, and then we had to add the supplementary feed for 2 years. Now, if we are giving the breastfeeding, it should be given for 6 months, and after 6 months it should be stopped, and then we switch on totally to the top feed. There is no mixing of the food. There is a no mixing of the food means we will not continue the breastfeeding and the top feeding together. Reason is, when we do the follow-up, and if a baby is taking both breastfeed and the top feed, we don't know how much is the contribution of the breastfeed in the transmission of the infection. So we may be misguided. So if you are giving a breastfeeding, we know that it is a transmission is by the breastfeed. But once we stop the feed, totally to have to shift to the top feed. No mixing is allowed. We have to do the follow-up of the baby. We can remember the rule of 6. 6 weeks, 6 months, 12 months, 18 months. And whenever baby stops the feed, 6 weeks after stopping the breastfeed. And final result is at 18 months. 18 month पे if a baby is not having any infection, baby is safe. But अगर 18 month पे infection है, so now baby had an infection and we will giving the treatment lifelong. ठीक है? And we had already discussed 6 weeks पे testing will be done by P24 antigen or by the RT-PCR, because 6 weeks is the window period and we cannot go for ELISA, but after that we are doing with the ELISA. So this is how we are preventing the transmission from the mother to the baby. Very, very important. Now we are doing with different activities. We are giving the drug to the mother also. We are doing a cesarean section also if it is indicated. We are giving the drug to the baby also. So if we are giving a single activity, how much is the net result? If we are having a combined activity, how much is the net result? So how much is the possibility of prevention of a child transmission? Normally we have seen the pregnancy is transmitting the infection up to 30%. If we are giving the nevirapine, so just write mother to child transmission is up to 30%. If we are giving only nevirapine to the baby, we had seen its efficacy is 50%, means 30% का आधा रह जाएगा. So the net result of the transmission, if you are giving nevirapine only, it will be 15%. You got the point? अगर खाली nevirapine दिया, its efficacy is 50%, so the net effect is only 15%. If you are giving zidovudine to the baby, its efficacy is 66%, so the net result is only 10%. If you are doing cesarean section, its efficacy is 50%, so you can write here 66% efficacy, here the 50% efficacy. Cesarean section is efficacy is 50%. If you are doing only cesarean section, then again it will be net result is 15% because its efficacy is 50%. But if you are combining the cesarean section and the ART to the baby, the reduction is by 75%. So the net result is only 5 to 7%. But this doesn't mean that we are doing a cesarean section in each and every person. Remember, WHO says अगर आपको obstetric indication है तभी cesarean करिए, नहीं तो नहीं करना. Cesarean is done only if there is an obstetric indication as per the WHO guidelines. But what currently we are doing, if we are giving the ART to the mother and the baby, if you are giving the ART to the mother and the baby both, it is decreasing the possibility up to 95%, and the net result is less than 1% only. If you are giving the ART to the mother and the baby, the net reduction is up to 95%, and the net effect left is only less than 1%. And that's why we say that now if a this HIV positive mother conceives, we can allow her to deliver, because we are giving a safer drugs to the mother and the baby, and we can have a HIV negative baby even to an HIV positive mother. Clear? Now, classification of the districts and the states. Earlier we were classifying only the states, now we are classifying the districts. So here we have to remember the classification, because one question was asked. It is based on the high risk group, HRG is the high risk group, and in the antenatal patients. If it is a high prevalence state, matlab HRG group mein prevalence is more than 5% and antenatal cases mein prevalence is more than 1%. Who are the moderate prevalence states? If is in the high risk group is more than 5%, but ANC group is less than 1%. Who are considered as a low prevalence? जिसमें high risk में less than 5%, antenatal में less than 1%. But these are the low prevalence states जहाँ पे some areas में we had a hot spots also, means a high number of the cases. So now the districts are classified. The A category is same as a high prevalence states. B category is same as a moderate prevalence states. The low prevalence states are divided into the C and D, C with few hot spots and the D are without any hot spots. So these are the classification of the districts and the states. Now as we had seen the malaria program, we had a drug distribution centers and the fever treatment depots. So we are having a special centers in the AIDS program, and very important, just try to understand that this is very important, is the ICTC centers, integrated counseling and testing centers. These are present at the district hospitals. So whenever the person is going to the ICTC centers, we are motivating them, counseling them and checking if it is positive. At the same site, means at the district hospital onwards, at the place where we had ICTC centers, those who are positive, we are giving them the treatment through the ART centers. So ART centers are also present from the district hospital onwards. So these are providing the first line drugs. After taking the drug, the patient is coming to their hometown. And for the follow-up, they are not going back to the ART centers because there will be much load. They can go to the nearby, like if you had come from China and you had brought your mobile phone for service, you are not going to the China. You can go to any of the nearby center. So same like for the follow-up or for any minor problems, they are going to the linking centers, which are linking the community to the ART centers, that is a link ART centers or the link ART center plus. These are present at the community health center or the sub-district hospitals. Now, if a person is not responding, then a second line drug is given in the ART plus centers, which are the selected medical colleges. So these are the special centers we have to remember. So first question, the ICTC centers are related to which program? Related to the AIDS. ICTC is the integrated counseling and the testing centers. These are present from the district hospital onwards. Then we are having the ART centers. ART centers are providing the first line ART, first line ART, and where the ART centers are present, these ART centers are present from the in the district hospital and the medical colleges. ART plus, these are providing the second line ART, and some of the selected medical colleges are the ART plus centers, which are the link ART or the LAC. LAC is Link ART Center. Link ART or the Link ART Center Plus. These are for follow-up or the treatment of minor problems. These are for the follow-up and the treatment of the minor problems. And these are community health centers and the sub-district hospitals. So these are the special centers and we should be knowing where they are located and what are their functions. Now coming to what is the global strategy? The global strategy of the United Nations is that we have to end the AIDS epidemic by 2030. And what is the strategy of India? National Strategic Plan. Again, we have to end the AIDS epidemic by 2030. And here we are having 95-95-95 strategy. We have to end the AIDS epidemic and we follow the 95-95-95 strategy. It means that 95% of the patients should be diagnosed. 95% of the diagnosed patient should start the treatment, and those who are taking the treatment, 95% of the patients on the treatment should have a adequate control of a viral load. So 95% of the individuals should be diagnosed. Those who are diagnosed, at least 95% should be given a treatment, and those who are taking the treatment, 95% should have a adequate control of the viral load. If you are not able to remember all, at least remember in the HIV we are having a 95-95-95 strategy, because you can just put a note somewhere. In tuberculosis we follow the 90-90-90 strategy. Tuberculosis may we follow the 90-90-90 strategy, HIV may 95-95-95. Now, you might have heard about the HIV Red Ribbon Expresses, Red Ribbon Clubs for promotion of the prevention of HIV. So, we had a Red Ribbon Club. This is in the college, and this is for education about the prevention of STDs, education for prevention of the STDs. We are also having the Red Ribbon Express train. Same like a train होती है जिसमें we had a posters, models inside, and this is also for education for prevention of STDs. We are taking a help of some voluntary workers, the link workers, which are also spreading the information. We are checking the blood for the some diseases before the transfusion, and this was the question asked. Or what tests you are doing before the blood transfusion? We are checking for the HIV 1 and 2, hepatitis B, C, malaria and the syphilis. And now we had started the sex education for the students of the class 9th and 11th. So we had started the sex education in the school for the class 9th and 11th. This is again to prevent the STDs. So this is all about the sexually transmitted diseases, HIV, AIDS and its related programs. Very, very important and commonly asked in the exam. So quickly we'll see the questions which has been asked from this section. The all tests are done before the blood transfusion except we are doing hepatitis A, no, B, 1 and 2, hepatitis C, so A is not done. A 25-year-old lady coming with a complaint of the vaginal discharge and pain. सो खाली वेजाइनल डिस्चार्ज होता तो ग्रीन कलर किट, पेन है तो येलो कलर किट, taking a better one is the abdominal pain higher one, so we are going with the yellow color kit. A 19-year-old boy presented with the urethral discharge, so urethral discharge we are using the gray color kit. Identify the logo, this is the logo for Suraksha Clinics. A nurse has accidental prick while collecting the blood of a known case of an HIV. Prefer test for confirmation of the transmission. Now here there is a little bit controversial point. Now some students was saying that they had asked the test what we are doing for confirmation of the transmission at that particular means at a after 1 month or after a 2 month. So if it was that, then we are going for P24 antigen because that was in a window period. But if they say that what is the test for confirmation of the final confirmation of the transmission or the diagnosis, then we can go with the Western blot. Okay, so there is a little twist in the language. Now don't worry, you just understand the concept, and whatever the question is asked, you have to answer accordingly. If they say the best test for the diagnosis or the confirmation of the disease is the Western blot, but if they say that what is the test for detecting the transmission just after the exposure, then it will be the P24 antigen. Okay, so confusion nahi hona chahiye. So here if I say the preferred test for confirmation, so I'll go with the Western blot test, but some was saying it was a for the diagnosis, and just after the 2 weeks or the 3 weeks what it was mentioned, so it may be a P24 antigen also, so confusion nahi hona chahiye. Now a case of an HIV complaining of cough with fever, which test you will perform to diagnose the TB? Because in the HIV patients the tuberculosis is a very common opportunistic infection, and the tuberculosis may we cannot go with the sputum because HIV may become have a sputum negative also, so we'll prefer to have a CB-NAT test. A case of HIV CD4 count is less than 350, the probable infection is the tuberculosis. Nurse has spilled the blood on the floor, which chemical we are using? So actually this is a surface disinfection what we are using to disinfect the blood, and we are commonly using a chemical disinfectant as a 1% sodium hypochlorite. As we are discussed in our biomedical waste disposal that we are first doing their disinfection, and liquid waste ka or microbial waste, we are first doing the chemical disinfection or by the autoclave or by the microwave. So here pe blood is present on the floor, so we have to disinfect with a 1% sodium hypochlorite. So these are the a few questions asked from this section. So okay, we'll take here the break, have a cup of tea, coffee, and come back. So time by my watch is, it is 3:57, so we'll start at 4:20. And meanwhile, if you had any doubt, any query, you can message me. So friends, welcome back. Now we'll be moving to the next group, that is a surface infection. And in this infection, the three important diseases which we'll be talking as tetanus, trachoma and leprosy. So the first is about the trachoma. As you might have studied this in your ophthalmology classes also, and we know that now we are not having the trachoma cases and we are about to eliminate this disease. We are waiting for the certification, and the still few more points we are supposed to. No, beta, it is not muted. It is normal from my side. Please check your side. It is normal from my side. Please check. It is normal from my side, beta. Okay, great. So still, trachoma may the few points what we have to remember, because this is a disease which is causing the blindness and that is absolutely preventable. And we know that because of this trachoma, we had the follicles on the upper conjunctiva, and this is rubbing over the cornea, causing the corneal damage, corneal ulceration, and we can have the blindness. So this is preventable if we can avoid the transmission, if we can early treat with the azithromycin. So what is the problem with the trachoma? That it is causing the blindness, and this blindness is preventable. This is one point. Second is, what is the drug of choice for the treatment of this condition? It is the azithromycin. And we have to remember the dose as 20 milligram per kg the body weight, single dose oral. 20 milligram per kg the body weight, single dose oral, that is the drug of choice. Now, as we had discussed, the eye strategy was related to the yellow fever, elimination of the yellow fever epidemic. The second strategy we have to remember in relation to the trachoma, that is a safe strategy. So question, safe strategy is related to what? That is with the trachoma. Sometimes they ask what you mean by this safe also. The S stands for the surgery. Surgery for trichiasis or the entropion, we have to do the surgery. We are giving antibiotics, A for the antibiotic, that is azithromycin. We have to maintain the facial cleanliness, because the discharge, if it is present, transmitted by the housefly to one to another, and we have to maintain the environmental hygiene also. So these are the components of the safe strategy. Now another strategy related to the trachoma is the GATT strategy, and what is the full form of the GATT is the global elimination of trachoma. That is what we have to remember. So two strategies, the antibiotic is the azithromycin and the causing the blindness. That's all. Now tetanus, we all know that soil is acting as a reservoir for this. Whenever we had a roadside accident and any injury with a rusted any material item, knife, and the soil containing these spores, they are entering inside our body, and if we had a massive injury, anaerobic atmosphere is their necrosis, and these organisms, they germinate and they liberate the toxin. And what happens in this tetanus, because this toxin, it is inhibiting the or it is blocking the inhibitory spinal reflex. So we had a spasm, and sometimes the patient is presenting with a massive spasm of the back, that is a lordosis. And I have seen one patient, and I was in my final year, that one 25-year-old boy admitted to the hospital after a road accident, and didn't receive the tetanus vaccine at that particular time, and was in a very bad shape. But with the proper care, antibiotics, penicillin, and the antitoxin, repeated injections were given, and he was saved. He was discharged almost in a good condition after a month. So nowadays, as we are routinely vaccinating our children right from the 6 weeks, so we are finding very rare cases of the tetanus presently. So the question is that whenever the person is having the tetanus, so what is the treatment we are giving? Because the bacteria, they are the bacilli, they are responding to the penicillin. So drug of choice is the penicillin. And we remember that we had discussed earlier also. So whenever any disease is there with the toxin as its mechanism, so we have to give the antitoxin also to neutralize. So along with the penicillin, which is killing the organism, we have to neutralize the circulating toxin. So we are giving the immunoglobulins, or these are the actually the antitoxins. So it can be a human immunoglobulin or the TEDGLO, and the dose is, it is around 250 international units, 250 international units of the human immunoglobulin. And if we are using a anti-tetanic serum, that is an animal immunoglobulin, the dose is around the 1500 international units. If you are not able to remember the units, fine, you can remember the penicillin is the drug of choice for the tetanus, as well as we are giving the immunoglobulins. That's all. Now, we all know that for routine prevention, we are giving a tetanus vaccination as a part of the DPT to our children, and we are starting right from the 6 weeks, and we all know the schedule. So, the prevention is by the active immunization. We are giving a primary doses 6, 10 and 14. The first booster of the DPT 1.5 year, the second at 5 year, then the TD booster 10 year, and the second next booster at 16 years. So total 7 doses of the tetanus we are giving right from the 6 weeks till 16 years. And our goal is, if you can remember, the keep the antitoxin level more than 0.01. जैसे रेबीज में हमने देखा था more than 0.5, and here it is more than 0.01 international units per ml. But very importantly, they ask as a clinical based situation is post exposure prophylaxis, means if you had a accident, if you had any injury, what to do, how to manage. Now what we have to give, whether the vaccine or the immunoglobulin or the both, it depends upon the two factors. Number one, it depends upon what type of the wound you had, and second is when you had a last vaccine or the booster received, because they say that a one vaccine effect lasting for 5 years. So if you had a minor cut, who are considered as a minor wound, if it is a clean wound, it is less than 6 hour duration, non-penetrating, and the negligible tissue damage. So it means there is a least possibility of a growth of the organism. So these are the minor wounds, but rest other type of the wounds are considered as a major wounds. So if it is a condition when you had received a booster within a 5 years, means a good immunity is there, so there is no action is required in both the cases, because the good immunity is present in your body. But if you had a booster 5 to 10 years back, so we are expecting some reduction in the antibodies. So in that case, a single injection of the tetanus toxoid will be sufficient, means a vaccine is sufficient in both the cases. It will boost up the immunity. But if you had received the booster more than 10 years back, it means the a very low antibodies may be present. It is adequate to manage if it is a mild category of the wound by simple TT injection. But if it is a major category of the wound, we may be requiring to give the TT vaccine along with the immunoglobulin. So if a booster is more than 10 years back, in the major category of the wounds, we are requiring to give both vaccine and immunoglobulins. Clear? But if a person is not immunized at all, then in the minor category, we are giving the a vaccine at that particular point to manage, and the vaccine plus immunoglobulin in the major category of the wound to manage at that particular time. And we have to protect that person for a long, so we are giving the other vaccine, complete vaccination, complete vaccine we are giving as per the schedule. So immediate control ke liye we are giving a single dose of the TT and immunoglobulin, and we are giving them the complete vaccine. Complete vaccination as per the schedule. So this is about how you are going to manage. So they can give you a clinical situation. Suppose currently it is a 2020. So if I give an example that a student was going on a bike, had a accident, there was a massive injury on the calf muscles. The muscles was damaged and the extensive wound was there. And he had received the TT vaccine in 2020 following the accident. So how you are going to manage? So currently it is 2022 and he had received the vaccine in the 2020. So only the wound care can be sufficient, that there is no need to give the vaccine or the immunoglobulin. So like that they can ask you the clinical situations. Clear? So this is about the tetanus, and the very important is about the post exposure prophylaxis. We should be knowing about this status. Now we all know that India has eliminated the neonatal tetanus. So again, we have to remember here, what is the elimination criteria? The criteria was that incidence of the neonatal tetanus should be less than 1 per 1,000 live births. So incidence of neonatal tetanus is less than 1 per 1,000 live births, and we had achieved this. So, and we had declared the elimination from India in 2016. Now, why or the how we were able to eliminate? Because continuously we are vaccinating our pregnant mothers. So this elimination was possible because of the two very important reasons. One was the pregnant woman was given the 2 doses of the tetanus toxoid vaccination. In more than 90% of the pregnant ladies were vaccinated with the tetanus vaccine, and we are conducting the deliveries by the skilled person using the disposable delivery kit in more than 75% of the deliveries. So by vaccinating more than 90% of the pregnant women and conducting the safe deliveries in more than 75% of the individuals, we were able to do the elimination of the neonatal tetanus. Neonatal tetanus is also known as the 8th day disease. 8th day disease because the incubation period starts at the time of the delivery, and usually on the 8th day the child is showing the symptoms of the neonatal tetanus. Now please make a note here is that if a lady had not received the vaccination during the pregnancy, we can give the tetanus immunoglobulin to the baby after the delivery. ठीक है, लेकिन this neonatal tetanus cannot be prevented by giving a DPT vaccine to the baby, because vaccine we are giving at 6 weeks. Lowest age we can give the DPT vaccine to the baby at the 6 weeks, and this tetanus is developing on the 8th day. So just make a note here is that if mother is non-vaccinated, in that condition give tetanus immunoglobulin to the newborn after delivery. If a mother is non-vaccinated, give the tetanus immunoglobulin to the newborn after the delivery, but neonatal tetanus cannot be prevented by giving the DPT vaccine to the baby. Neonatal tetanus cannot be prevented by giving the DPT vaccine to the baby because DPT given at 6 weeks, while neonatal tetanus develop on the 8th day. Okay? So neonatal tetanus cannot be prevented by giving the DPT vaccine because the DPT vaccine is given at 6 weeks and the neonatal tetanus develops on the 8th day. So this was the one question asked, that neonatal tetanus can be prevented by all except giving a TT vaccine to the mother, giving the a TT vaccine to the baby, giving the TT immunoglobulin to the baby, and by conducting the safe delivery. So it is not by giving a TT vaccine to the baby because it is given at 6 weeks. By TT immunoglobulin, by giving a vaccine to the mother, or by conducting the safe delivery, we can avoid the neonatal tetanus. Now the next disease is the leprosy, and we know that still some cases are happening in the leprosy. So we are having our very important national program because this disease is causing the extensive damage and leading to the morbidities and the disabilities. So this is a disease which is highly infectious, but it is slowly progressing, and that's why we all know that if one person is having a leprosy, nobody wants to stay with them, nobody wants to touch them, because there is a risk of transmission. Now, average incubation period is around the 5 years. The most common nerve which is damaged is the ulnar nerve, and the least affected is the radial nerve. Now, in the leprosy, the main damage is in the nerves, and because of the nerve, the loss of sensation, so we can have a repeated trauma and can plantar ulcer. We had already discussed this point in our derma classes. So question was asked is, the plantar ulcer in the leprosy was which type of impairment? It is actually a secondary impairment, because the first damage or primary impairment was the nerve damage. So plantar ulcer in the leprosy is actually a secondary impairment, because the primary impairment was the nerve damage. And we all know that loss of sensation, it is first is the loss of temperature sense. The cold goes first, followed by the hot. This is followed by the touch, and then finally the pain goes. So this is a loss of sensation in order: the temperature, cold, hot, touch, and the pain. Now, the most common source of infection, the source of infection is the case of multibacillary leprosy. The nasal secretion of a patient of multibacillary leprosy is containing the bacilli. It can be coming in a close contact of a leprosy patient. If a person is breastfeeding, the breast milk is also transmitting the infection. And use of the tattoo needles. So future mein kabhi bhi agar if you are going for a tattoo, so be very careful, the needle should be sterile. Now, as we had discussed in the leishmaniasis, the leishmanian test, what we are doing for the prognosis, it is not for the diagnosis. Same here in the leprosy, we are doing a test, that is a Lepramin test. And Lepramin test, it is not done for the diagnosis of the disease, but it is done for evaluating the immune response to classify the type of leprosy and to see the prognosis. As we had already discussed in our derma classes, the 5 type of leprosy: TT, BT, BB, BL, and the LL type. And if you are going from a TT to the BT, TT to the LL side, the immunity reduces, bacterial count increases. So here we are taking the reading twice. The reading is taken twice. The first reading is taken after 48 hours, and the second reading is taken after 21 days. And the reading what is taken after 48 hours, it is known as the Fernandez reaction. Fernandez reaction, and the reading what we are taking after 21 days, it is called as a Mitsuda reaction. So till now we had discussed the patch test mein reading is taken after 48 hours and the 96 hours. The Lepramin test mein we are taking a reading after 48 hours and the 21 days. And the agent what we are using here by the name of the actor, you can remember, is the Dharmendra's antigen. So we are taking a reading twice after 48 hours and the 21 days. One question was asked is the reading which is taken after 21 days is known as Mitsuda reaction. So antigen is here is the Dharmendra's antigen, and it is not for the diagnosis. Now, very important program we had with the logo is a National Leprosy Eradication Program. So this is a National Leprosy Eradication Program. Earlier we had a control, then moved to elimination. Now currently we had an eradication program. Now, as we had discussed in the AIDS program, we had the ICTC centers, the ART plus centers, and in the malaria we had a drug distribution centers and the fever treatment reports. In leprosy we had a SET centers. So SET center is the survey, education, and the treatment center. We should be knowing how much is the population covered. They are present at a primary health center, and one is covering the 25,000 population. Its urban part, it is in the urban leprosy centers Obviously, urban PSCs are covering 50,000 population, so they are 1 per 50,000 population. And we had a leprosy care unit. It is covering roughly around a 4.5 lakh unit. If you are not able to remember all, at least remember the most important is the set center where we are doing the confirmation of the diagnosis at the level of primary health centers. Now, what are the indicators of the program? As we had discussed, the malaria ka API was the best indicator. And here we are having the indicator is the new case detection rate. Because if you are controlling the leprosy, obviously the new cases detected should be low. And those who are detected, we should be completely treating those cases. So, treatment completion rate and the new case detection rate. Now, as we had discussed in Dharma, based on the immunity, based on the clinical features, we are classifying into the 5 categories. But for a convenience for the treatment, in our national program, we are classifying the leprosy into the 2 basic groups. The one is called as the paucibacillary leprosy, another is multibacillary leprosy. And the important criteria is number of the skin lesions. If skin lesions are 1 to 5, they are the paucibacillary. If a skin lesion are more than 5, obviously they are the multibacillary. Now, another criteria is, there is no space, so I am writing above. It is the nerve involvement. The second criteria is nerve involvement. If there is no nerve involved or the single nerve involved, it is the paucibacillary. And if it are more than one nerve are involved, it is a multibacillary leprosy. So there are the 2 criteria. One is based on the skin lesions and the nerve affection. If there is no nerve is involved or only the single nerve is involved, that is a paucibacillary. More than one nerves are involved, it is multibacillary. Now, a treatment, I think we had already discussed this. This is a very, very, very important pack, and this could be an image based question also. And here we are giving a monthly pack, and on the day 1, we are calling the patient to the clinic. And day 1 pay, the medicine is given under supervision. Under supervision of a health worker, we are giving on the day 1. And this a white tablet is nothing but it is the Dapsone 100 milligram. These are the 2, or first we'll talk about these 3 capsules. These 3 capsules are the clofazimine 100 milligram each. So total is 300 milligram. The remaining are 2 capsules. These are of the rifampicin 300 milligram each. So on the day 1, we are giving the 100 milligram of the Dapsone, 300 milligram of the clofazimine, and the 600 milligram of the rifampicin, and then we are handing over this pack to the patient, and the patient is supposed to take daily this a combo. And what is this combo has? This is having the Dapsone 100 milligram and clofazimine 50 milligram. So this patient is taking daily, and then after 1 month patient is bringing this empty blister pack and we are giving the next pack. So this cycle goes on. Clear? So this is all the repetition what we had already discussed, but very, very important. So coming to the treatment. So question, what 3 drugs we are giving? It is the rifampicin, Dapsone and the clofazimine. And how we are giving the rifampicin? It is given as 600 milligram by the oral route once a month. 600 milligram oral once a month supervised. So rifampicin we are giving 600 milligram oral once a month supervised. Dapsone we are giving 100 milligram oral daily. Dapsone we are giving 100 milligram oral daily. Clofazimine we are giving in a 2 format, 300 milligram once a month oral supervised, once a month oral supervised, and then we are giving once a month oral supervised, and then we are giving 50 milligram oral daily. 50 milligram oral daily. So these are the important points about the doses of the drug. Now, for how long we are continuing this therapy, this is important. That is the duration of the treatment. It is continued for 6 months in the cases of the paucibacillary. It is continued for 12 months in the cases of the multibacillary. And we are doing the follow-up. It is yearly for 2 years in the cases of paucibacillary, and we are doing yearly for 5 years in the cases of multibacillary. So follow-up is important, the duration is important, how we are giving the drug, the treatment is important, what drug is given, every point is important in this national program guideline about the treatment. Okay. Now the question is, if a person is not able to come monthly to take the medicine, so sometimes any of the responsible person from the family or the village can take the medicine on behalf of that patient, and this is called as accompanied MDT. So accompanied MDT means any responsible person can take the medicine on behalf of the patient, that is accompanied MDT. As we know that the patients who had earlier the treatment of the or earlier had a leprosy which was not diagnosed early, they had the disabilities. So now we are trying to correct those disabilities and we are treating others to prevent the disabilities. So we are having another activity is the disability prevention, and those who had the disability, we are doing their rehabilitation. So the main problem is the nerve damage and the trauma. So we are providing them the microcellular rubber footwear, so they will not have the trauma repeatedly. Or those who had an ulcers, we are giving them a ulcer treatment kit. Those who had a disabilities, we are promoting them for the surgeries and we are giving them the incentive, so at least they will get the surgery done. The patient is being given the 8,000 rupees, as well as the institution who are providing the surgery fee of the cost to these patients, we are giving 5,000 rupees per surgery to the hospital. So this is about the disability prevention and rehabilitation. What are the guidelines of the national program? National program guidelines is that please listen carefully. I told you yesterday also, again I am saying that in India we had decided the criteria for elimination, means अगर number of the cases उस लेवल से नीचे हैं जो कि negligible है, तो हमने कहा था कि हमने disease eliminate कर दी है. हमने स्टार्टिंग में 2005 में लेप्रोसी के एलिमिनेशन क्राइटेरिया लिया था कि ओवरऑल प्रिवलेंस कितना है लेप्रोसी का, हमने उसको अचीव कर लिया. हमने कहा 2005 में हमने लेप्रोसी एलिमिनेट कर लिया, लेकिन हमने बाद में देखा कि कुछ एरियाज में केसेस ज़्यादा थे, तो हमने नया क्राइटेरिया किया कि हर डिस्ट्रिक्ट में हमारे इंसिडेंस भी कम होना चाहिए, प्रिवलेंस भी कम होना चाहिए इस पर्टिकुलर लेवल से. वो अभी हमने अचीव नहीं किया है, तो हम कोशिश कर रहे हैं ना. सो अभी भी हम कहते हैं कि हम लेप्रोसी को एलिमिनेट करना चाहते हैं एज पर द न्यू क्राइटेरिया. सो अभी भी हमारी एक्टिविटी चल रही है. नाउ एज आई टोल्ड यू यस्टरडे ऑल्सो दैट India has a different criteria for elimination of a disease, and earlier our criteria for leprosy elimination was the total prevalence of the cases, and we had achieved that criteria in 2005 and we had declared that leprosy eliminated. But later on we had seen that some cases are happening more in some areas. So now we had a revised criteria and each and every district should have a new cases and the total cases below that criteria, which is still we are trying to achieve. So we are focusing our activities. So we are still saying that we are working for elimination of the leprosy as per the new criteria. So if a question is asked whether we had eliminated the leprosy, you say yes, because of the old criteria we had already eliminated. So as per the national policy 2017, our criteria was elimination of the leprosy by 18, but currently we had extended to 2020. Why? Because our elimination criteria our criteria of elimination in the 2005 was that total prevalence should be less than a 0.5 per thousand population, and this we had already achieved. But currently our criteria is that each and every district, our prevalence should be less than 1 per 10,000 and the incidence should be less than 10 per 1 lakh, which we are trying to do. So we are focusing our activities for that. Clear? Now, what should be our cure rate? The cure rate in the paucibacillary should be more than 97% and in the multibacillary should be more than 95%. So, remember what should be our cure rate. Now, we had a global strategy also. This was a national strategy. The global strategy is that we have to make a world free from leprosy by 2020. India की strategy क्या है? That we have to eliminate by 2020 currently, and globally also we have to make a world free from leprosy by 2020. Now, what are the guidelines of the post-exposure leprosy vaccine? I'll be coming just now. The post-exposure prophylaxis. Post-exposure prophylaxis may means a person in the family has been detected with the leprosy, as it is a slow growing process, slowly the long incubation period. So other family members or the close contact can have the leprosy. So we are giving them a single dose of rifampicin. So what is a post-exposure chemoprophylaxis? Post-exposure chemoprophylaxis is single dose of rifampicin to the close contact. Although the dose of rifampicin, it varies as per the body weight. You can remember an average weight person, adult person, the single dose of rifampicin for the adult, it is 600 milligram. So 600 milligram single dose of the rifampicin is given to the close contact. ना यहाँ पे क्वेश्चन है कि who are considered as a close contact. ऐसा नहीं है कि the person who is coming with the leprosy patient sitting only for the 2 hours, 3 hours can have an infection. No. They decided that if a person is having a contact of more than 20 hours in a week, continuously for 3 months or more. So, a person who are living or working with the affected person for 20 hours per week or more for more than 3 months. For a patient who had been detected leprosy in the past 1 year will be considered as the close contact. ठीक है? So close contact will be that कि अगर newly detected patient के contact में in a past 1 year, if he remained for more than 3 months and the exposure every week is 20 hours or more, he will be considered as a person having a risk of infection will be given the post exposure prophylaxis. ठीक है? And it is usually given in a individual of 2 years or more. Now, coming to the, as I said, that a dose of rifampicin can vary as per the body weight. You can remember as a adult dose, and this is obviously the supervised will be there. So single dose of the rifampicin 600 milligram to the close contact, and this must be supervised. Supervised means by the health worker, and there should not be any vomiting after taking the drug. Now, we are having the leprosy vaccine under the trial. In the endemic areas of the leprosy, we are giving the leprosy vaccine, and to the close contact, and we are not very sure about the efficacy of the vaccine. So we are giving the vaccine along with the rifampicin. So this is what we have to remember. So a leprosy vaccine ka, what is the strain of the leprosy vaccine? The strain is Mycobacterium indicus prani, MIP is the strain, and this is given with a single dose of the rifampicin, same as we were giving for the prophylaxis, and this is given to the close contact of the newly detected case, and we all know what the close contact is. So this is about the leprosy vaccine. So this is given along with the single dose of the rifampicin to the close contact. Now coming to the involvement of the ASHA workers, or what other preventive activities we are doing. As we know that ASHA is a main worker for active leprosy surveillance, visiting house to house and trying to identify the cases, suspected cases. So main worker of an active surveillance of leprosy is ASHA worker. So leprosy ASHA worker is helping in a case detection. We are also taking the help of voluntary workers as a स्पर्श लेप्रोसी अवेयरनेस कैंपेन. स्पर्श होता है टच करना, कि सिंपल एक बार टच करने से आपको लेप्रोसी नहीं हो सकता. सो वी आर ट्राइंग टू डू द हेल्थ एजुकेशन टू द कम्युनिटी, and we are also taking help of an NGOs. This is the SET scheme. So this is all for the health education. So for the health education is Sparsh Leprosy Awareness Campaign or the SET campaign. And because abhi bhi there is a stigma in the periphery, if a person is having some symptoms, patient is not coming forward because he thinks that if anybody comes to know that I am having a leprosy, nobody is going to touch me, nobody is going to accept me in the society, I'll be isolated, I will be separated. So we are educating them, okay, it is a curable disease, you should come forward and you will be having a complete cure. Now, lepra reactions we had already discussed in our derma classes also. The type 1 lepra reaction is called as a reversal. Type 2, it is a erythema nodosum leprosum. The rule of 5, the type 1 is because of the type 4 hypersensitivity. Type 2 is because of the type 3 hypersensitivity reaction. In type 1, it is commonly seen in the paucibacillary leprosy cases because good immunity is there. Type 2, it is usually seen in the multibacillary leprosy cases. Type 1 में existing lesions increase होते हैं. So existing lesions, they become red erythematous. While in the type 2, multiple new lesions appear. While in the type 2, multiple new lesion appears. Nerve involvement is more in the type 1. Nerve involvement is less in the type 1. General symptoms are less severe in the type 1. General symptoms are more severe in the type 2. And a very important point what they ask is the treatment. We have to continue the anti-leprosy drugs. It is for the both. We have to continue the anti-leprosy drugs plus add steroid. We have to continue the anti-leprosy drugs and add the steroids. This is the treatment of lepra reactions. So this is about your leprosy, a very important disease and its natural program and the guidelines. Now coming to next group of the infection, and that group is the intestinal infections. Now in the intestinal infections, the entry of organism is through the infected food or the water. So if we are providing the safe drinking water in that area and we had a safe facilities for the sewage disposal, then we are avoiding the water contamination or the contamination of the food with the intestinal organisms. We can avoid all the intestinal infections. Now the main clinical manifestation of all these intestinal infection is the diarrhea. So the many questions has been asked about how you are managing a diarrhea. First is, what is the composition of an ORS? Because if it is a mild diarrhea, we are giving the oral fluid, the child can take oral. But if the child is severely dehydrated, it's a severe diarrhea. You might have already discussed the differences in the clinical basis, mild, moderate and the severe diarrhea. Then we are giving an IV fluid. So how much of an ORS, how much of an IV fluid, how long we are giving, then what is an additional vitamins we are giving, what is an additional mineral we are giving. So this is all we are supposed to know in the diarrhea, and the important diseases which can be prevented by taking proper care. And related to the intestinal infections are the polio we'll be talking, then cholera, typhoid, hepatitis A, and the various type of the food poisonings and the two worm infestations as the roundworm and the hookworm. So this is what we will be talking in our next group of the disease, that is the intestinal infections. So what is a composition for ORS? Now composition of ORS, the total osmolarity, what we say, it is the 245 millimole per liter. Means if you are dissolving a 1 sachet of the ORS in a 1 liter, whatever the osmolarity we get is the osmolarity of that liquid. So first question, that what is an osmolarity of the ORS what we are using now, it is the 245 millimole per liter. Now they had asked about the osmolarity of the individual content also. So sodium and the glucose are same, that is 75 millimole. Second is chloride, it is 65 millimole. So sodium glucose is same, then coming to the chloride, and then the potassium, it is 20, and the last is the citrate, it is 10. So we have to remember the osmolarity, at least not all. So they had asked for sodium and the glucose. So this is important. Now a weight of a sachet powder weight is 20.5 gram. They had not asked about in the weight. It's a sodium chloride is 2.6 gram, potassium chloride is 1.5 gram, sodium citrate is 2.9, and the major chunk is of the glucose. Now very importantly, they ask is that how much is the ORS we are giving. The ORS is usually given in the mild to the moderate diarrhea. So always remember, if in the question is given that child is able to drink, then the first preference will be the ORS. So mild to the moderate diarrhea, we are giving the ORS. And the dose of an ORS is, it is given as 75 ml per kg of the body weight to be given within 4 hours. So suppose if they say that 10 kg of the baby has been brought to the clinic with a history of the 5 to 6 loose motions since last 6 hours, the child is thirsty, fully conscious, how you are going to manage, or how much is the amount of the ORS. So 10 kg baby hai, so 750 ml will be given in the next 4 hours, slowly. Now how we are preparing the ORS, we had already discussed that 1 sachet in the 1 liter of the boiled cool water, and another question is to be used within 24 hours. It has to be used within 24 hours. I told you the story also. How we are telling them to prepare the ORS, it is by the demonstration. So demonstration is a method of health education. Now another question is asked is, mother is worried that my baby is having a diarrhea, should I breastfeed or not? So there is no contraindication to the breastfeed. They say breastfeed should be continued. Even if a baby is having a diarrhea, continue the breastfeed. Now if a ORS packet is not available, we can use either the coconut water, simple the rice water, or nothing is available. We tell to the relatives that take a glass of water, just squeeze the 1 lemon, put a 1 teaspoon of sugar, pinch of salt, mix and give to the baby. So that will be acting as at least some sugar, some salts are there, because sugar is not absorbed as such, it will be absorbed in the presence of electrolytes. So sodium is very helpful in absorption of liquid. So this is what we can use the other fluids. Now very important question, that if a baby is having a diarrhea, and suppose the dose of the OPV is due. Now what to do? Because if you are giving an OPV, we can expect that some amount of the dose is wasted. So should we wait till the diarrhea is controlled and then we have to give? Suppose it is a pulse polio program. Pulse polio mein to we cannot avoid the dose. So we say that you give the vaccine, but consider that some will be wasted. So consider this as a 0 dose and repeat the dose after 4 weeks. That is important. So if a OPV is not a contraindication with the diarrhea, now give the OPV and consider this as the 0 dose. So give the OPV on a time, consider as the 0 dose and repeat the OPV dose after 4 weeks. So this is the correct answer, that we are not avoiding the OPV. Give the OPV, consider as a 0 dose, repeat the dose after 4 weeks. If it is a severe diarrhea, then we are giving the IV fluid. So IV fluid is given in the cases of the severe diarrhea, or if the child is irritable, not able to take an oral fluid, we are giving a IV fluid. Now question is, how much of the dose we are giving? It is given 100 ml per kg in the divided doses to be given in 3 to 6 hours. ORS दे रहे थे 75 ml per kg in 4 hours. IV fluid दे रहे हैं 100 ml per kg in 3 to 6 hours. बच्चा छोटा है, slowly देना पड़ेगा. बच्चा बड़ा है, fast दे सकते हो. Small baby, give slowly. Bigger baby, you can give fast. Now in the 2 divided doses means initially we are giving little bit fast to overcome the dehydration, and then we are giving little bit slow. So 2 fractions we are dividing. So total is 100 ml per kg. It is divided into the 2 fractions. First 30 ml per kg, second is the 70 ml per kg. Now 30 ml per kg is given in a 1 hour if a baby is less than 1 year, and in the 30 minutes if the baby is more than 1 year. बड़े बच्चे में you can give in 30 minutes, and the remaining 70 ml per kg to be given in 5 hours if a baby is small, and can be given in 2.5 hours if a baby is big. So the total duration is 6 hours if a baby is small, and it is 3 hours if a baby is big. That's why we say it is to be given in 3 to 6 hours. If you are not able to remember these time, at least remember the dose total is 100 ml per kg, 2 fractions 30 ml and 70 ml, and to be given in 3 to 6 hours. ठीक है? Oral is ORS 75 ml per kg in 4 hours, IV fluid in severe diarrhea 100 ml per kg in 3 to 6 hours. Clear? Now, what fluid we have to give? Again, this is a question. Obviously, fluid के साथ में electrolytes जरूर होना चाहिए. So, a first preference is given to the diarrhea treatment solution. If it is not available, then second we can give the ringer lactate. If it is not available, we can give the normal saline, but never give dextrose. 5% of the 10% dextrose, because no electrolyte, it will not be absorbed. It will not be retained in the body. Clear? There must be the electrolytes. Now, this is what we had discussed: 70 ml per kg in 4 hours for the ORS, 100 ml per kg in the 3 to 6 hours. It is a loading dose. After that, we have to give the maintenance dose as per the loose motion or the stool frequency. So, maintenance dose, if it is a mild diarrhea, it is 100 ml per kg of the body weight per 24 hours. And in the severe diarrhea, it is 10 to 15 ml per kg of the body weight per hour. This is the maintenance fluid. If you are not able to remember, fine, but never forget the loading dose. Clear? Another very commonly asked question, what mineral is supplemented along with the diarrhea? It is the zinc. Dose they also ask. Baby small hai, less than 6 months. The dose is 10 milligram per day. If more than 6 months, it is 20 milligram per day. In both the situations, it is given for 14 days. So zinc is supplemented for 14 days because this help in a healing of mucosal lining of intestine. So 10 or 20 milligram per day depending upon the age. Are we routinely giving some vaccines to prevent the diarrhea? Yes, very common vaccine is the rotavirus. We had already discussed it is a live vaccine given by oral route, 5 drops, 3 doses at 6, 10 and 14 weeks. The first dose is given up to 14 a weeks, 6 days, and the third dose is given up to 32 weeks as per the WHO guideline and the 1 year as per the Indian guideline. Now a very common confusion happens कि भाई अगर कुछ नहीं mention किया है which guideline we have to follow. Now usually if nothing has been mentioned you have to follow the WHO guideline, but please remember if they are talking about any of our Indian national program, obviously we have to go with the guidelines of the Indian program. ठीक है, अगर कोई नेशनल प्रोग्राम की बात कर रहे हैं तो इंडिया की गाइडलाइन से जाना पड़ेगा, बट अगर कुछ नहीं मेंशन्ड है और जनरल बात कर रहे हैं not related to the Indian national program, then we can go with the WHO guideline. ठीक है. Now second vaccine what we are giving is measles because indirectly measles complication is the diarrhea. Now as we had already discussed in our disaster also, along with the diarrhea we can see the deficiency of vitamin A. So this is about the diarrhea, very commonly asked in the examination. Now the second important disease is the polio. Although the India has eliminated the polio, declared on 7th of March 2014, because the last case we had in 2011 and WHO waits for 3 years, and since then we don't had a single case. Like in other diseases which we had eliminated, we say the criteria because scattered cases are seen, but there is no case of polio since 2011. So a step further than the elimination, what we call as a free country. So currently India is polio free country. Currently the India is polio free, means a step ahead of the elimination. Polio free as no case after 2011. But still we are continuing our surveillance activities because elimination means the agent is persisting. So if you are not continuing our surveillance activities, we can have the recurrence, and what we see in some of the African countries, the polio has come back because if there is any discontinuity in the vaccination. So Government of India is very strict, cautious about the pulse polio program and other activities. So we are having a very important national program and its guidelines we should be knowing, that is a pulse national polio elimination program. Now here we are doing the routine polio vaccination, and we all know that injectable inactivated polio and oral polio both we are giving. Oral is starting at birth, that is called as a 0 dose, or 15 days in a home delivery. First, second and third dose 6, 10 and 14 weeks. Booster at 1.5 years. Inactivated polio 2 doses at 6 and 14 weeks by intradermal route. This we all know, it's a routine vaccination. Now the second activity what we are doing is a pulse polio immunization. Now we all know that every year 2 doses of oral polio vaccine is given to our kids. So here the question is, this program was started in 1995 and we all know that Amitabh Bachchan is a brand ambassador of this program. Here we are doing the mass vaccination, means all the children of the age group of 0 to 5 years, we are giving at the same time the 2 doses of oral polio vaccine every year on the same day, whether they had received their routine vaccine 1 day before or the 1 week before or the 1 year before. So we are giving them as per the schedule. The purpose is that at the same time when we are giving the vaccine, it is maintaining the local immunity. So कहीं भी circulating virus होगा, suppose at the same time we are giving the vaccine, so it is producing the local antibodies. So if there is any circulating virus is there, this will be destroyed by the antibodies. So the virus will not be circulating. So we are breaking the chain of transmission. Clear? So it is given to all the children. Now, many times some children are left out. So how we identify, we all had already seen that a child after pulse polio is given an ink mark on a little finger, like we all had an ink mark on the index finger after voting. So a health worker is visiting house to house and trying to find out if any children is left, the vaccine can be given at home. This is called as intensive pulse polio immunization. House to house survey in the vaccination. A very important is acute flaccid paralysis surveillance or AFP surveillance. Very important. Now just try to understand. Now suppose a report comes from the Bihar, a case of flaccid paralysis has been reported, because polio mein the paralysis type is flaccid and usually it is having the first or preceded by the fever, sudden onset paralysis. So agar a report is there that a 3-year-old child had a fever followed by sudden paralysis in the limb, lower limb. So we should be alert, the department should be alert, and we must think like that polio has come back. So we have to start our control activity immediately. And we all had seen in the epidemiology that a first step in a epidemiological investigation is we have to confirm whether this paralysis is because of polio or other disease. And we all know that how we are confirming by demonstrating the polio virus in the stool. So we are collecting this stool, sending this to the laboratory, and usually the report comes in for 4 weeks or 28 days. So during that time, we are not wasting the time thinking that it might be a polio case. We start vaccinating to the susceptible children all around in a ring immunization form. 1 dose we are giving, waiting for the result. And if the result comes negative, okay, now nothing is required to do further. So here the first question, although the polio is happening in the 5-year-old till 5-year children, because pulse polio we are giving a 0 to 5, but still we are giving an advantage or a benefit of doubt to the older children also. So we are investigating up to the 15-year age. This is very important. So the age group which is involved in the AFP surveillance is 0 to 15 years. Clear? Second is, any case of the acute flaccid paralysis should be considered as polio paralysis until diagnosed. Next question, how we do the diagnosis? The diagnosis is done by stool examination and what we are looking for in the stool, we have to demonstrate poliovirus. So the diagnosis is done by the stool examination. This is another question. The polio diagnosis is by the blood test, by the urine test, by the culture or by stool. Stool में culture करेंगे, but the best answer is the stool examination. Now another problem. Poliovirus is very sensitive to the heat and it is only seen in the stool for 2 weeks after the paralysis, that is a period of communicability. So obviously we have to collect the stool within that 2 weeks. As it is highly heat sensitive, so we have to transfer in a cold chain, that we had already discussed is the reverse cold chain. So what are the criteria for adequate stool sample? This is again very important. So adequate stool sample, what we call that sample, if it is collected within 14 days of the paralysis. We are collecting the two samples at a gap of 24 hours. Could be an adequate amount of the stool sample of 8 gram each, like a size of a thumb. It should be transported in a +2 to +8 in a reverse cold chain. So collect within a 14 days of the paralysis. Two samples we are collecting. Transport at a +2 to +8. Another very important. Suppose you had dispatched a sample from Delhi, it has to go to Pune. The person who is taking the sample think, okay, let me go to Mumbai. Just see the Mumbai for 2 days and then I'll be going to Pune. Nobody is going to look, follow me. Now, sample should be reached within 48 hours, otherwise the cold chain will be damaged. So, sample should be reached to the laboratory within 48 hours. And once the sample is reaching, ऐसा नहीं कि वहाँ पे जाके dump हो गया. It should be adequately checked and reported. And we have to receive the report within 4 weeks. So, all these are the guidelines of an adequate stool sample. Now, please listen another point. If you are doing a proper study, you are coming across the flaccid paralysis cases in the community. And suppose अगर आप report लिख रहे हो कि in the last 1 year, 2 year, I didn't come any flaccid paralysis case, it means your study is a fraud study. You are manipulating. You are not studying properly. कि अगर आपने कम्युनिटी को स्टडी किया होता तो आपको फ्लैसिड पैरालिसिस के केसेस मिलने चाहिए, because there are so many viruses are in the environment which are causing the flaccid paralysis. So you should be saying that I come across these flaccid paralysis cases, I had investigated them, and then you have to prove it is not a polio virus, it is some other virus. So what are the indicators of the AFP surveillance that you should detect a non-polio AFP cases at a rate of more than 1 per 1 lakh population. So, non-polio AFP cases should be present at a rate of more than 1 per 1 lakh. And if you are sending the sample, at least in the more than 80%, you should get the report. The sample what you had sent, the 2 samples within a 14 days, in more than 80%, you should be getting the report. So, these are the 2 very, very important indicators of the program. You should be proving that paralytic cases are there, and in more than 80%, you should be getting the report as the negative. Clear? Now, as I told you, once we had said the sample report is coming in 4 weeks, during that 4 weeks, we cannot wait. We cannot do the Akhand Ramayana part, but we have to take some action. So, we had taken the sample, sent to the laboratory, and we are giving the, suppose this is my suspected child. So, to all the susceptible children around this child, I am giving the vaccine. And this is what is the concept of, this is what is the concept of the ring immunization. We had already discussed कि 100-yard radius में we have to vaccinate the susceptible. So, outbreak response immunization means vaccine we are giving following a outbreak or epidemic. So, single dose of oral polio vaccine we are giving to all the susceptibles in the age group of 0 to 5 years in that area around the suspected case. So, again local immunity के लिए we are giving the OPV. So, this is another question. So, should we choose IPV or OPV? क्योंकि IPV क्या करेगा, local immunity नहीं करेगा. So, we have to give the local immunity, and it is given in the children of 0 to 5 years. Clear? And earlier this question was asked when we were having the more of paralysis, कि some of the muscle weakness recovers, but after 2 months whatever the weakness is there, that is persistent. So, assessment of the residual paralysis is done after 60 days. Assessment of the residual paralysis is done after 60 days. So this is about the polio, very, very important disease, and we have to remember the points. Now coming to the next disease, that is the cholera. Cholera is again a disease which is transmitted through the fecal-oral route, and we can avoid this by simple education. Like if we say that if you are drinking the safe water, if you are washing our hands before meal, if you are eating the covered food, taking the vaccine, keeping the hygiene and the environment outside, then we can avoid the cholera. We all know that is a rice watery stool is there, projectile vomiting and the diarrhea, and the child is having the dehydration. And John Snow has studied this cholera epidemic, came to know that it is a waterborne infection. So now the points to remember here is, I'll be talking only the important epidemiological points, that which is considered as a father of public health. It is not a name of any scientist, it is a cholera disease itself is considered as father of public health. Short incubation period of 1 to 2 days on an average. High number of the subclinical cases and carriers, so showing the iceberg phenomena. As we had discussed in earlier also, so many types of the carriers are seen. During the incubatory period also, it is transmitting the infection. So incubatory carriers are 1 to 5 days. Convalescent are the recovery. This was the one question asked. What is the duration of the convalescent carrier phase? Convalescent is the recovery phase. It is 2 to 3 weeks. Healthy means had an infection, had an organism, no infection. So it is less than 10 days. And chronic if it is more than 1 year. So different type of the carriers we can come across. Now what are the various strains for any disease? It is important to know the strains of the organism because vaccines are prepared against that strain. Some are like a monovalent vaccines होते हैं जिसमें सिंगल स्ट्रेन के अगेंस्ट वैक्सीन है, some are bivalent, some are quadrivalent. So जितने स्ट्रेन्स हैं उनके अगेंस्ट अगर सबके अगेंस्ट वैक्सीन है, so that is a better. So cholera में two type of groups are there, group O and non-group O. जो मैंने बॉक्स में लिखे हैं, that is more important. So group O and non-group O, mainly the epidemics has happened with the group O. Group O is of a two types, two serogroups, O1 and O139. This is important क्योंकि जो cholera के vaccines हैं, monovalent it is for either O1 or O139, bivalent it is for both. ठीक है. Now out of this the O1 is more important. O1 के two biotypes हैं, classical and Altor. Altor is mainly responsible. Two serotypes, the Ogawa and the Inaba. Ogawa is more responsible. So mainly the vaccines are present for these O1 and O139. Okay. Now coming to the this is a disease under the IHR. So yes, this is a disease under the International Health Regulation. And we know that what are the diseases under the IHR? The three diseases are there. One is the cholera, yellow fever, and the plague. So these are the three diseases under the IHR. Can you message me within how much time we have to inform to the WHO? Within how much time we have to inform to the WHO about these diseases? 6 hours, 24 hours, or 1 week? Within how much time we have to inform to the WHO? Yes, excellent. So we have to inform to the WHO within 24 hours of their occurrence. Very good. Now, which is the most effective prophylactic measure? Only the education will play a role, that how we can protect or avoid the cholera. So the preventive or prophylactic measure is none other than the health education. Now dehydration is corrected either by the ORS if it is a mild diarrhea, or by the IV fluid it is a severe diarrhea. So we have to correct the dehydration. Now, along with the dehydration, as it is a bacterial infection, so we have to give the antibiotics also. So drug of the choice in adults, it is the doxycycline. Children में azithro, pregnancy में azithro. You can remember general as an adult doxy, and pregnancy में it is azithromycin. Now chemoprophylaxis is given as tetracycline. Now another very important, that we are having the vomitus and the stool which is containing the organism. So this is a liquid chemical waste. We are not collecting in any of the collection bag, we had already discussed. We have to do their disinfection and discarding into the domestic drain. So question is, what is the disinfectant you are using for stool or the vomitus? Disinfection is done by 5% cresol. So disinfection is done by 5% cresol. Now as this is transmitted through the water, normally we are doing the chlorination in 5 to 7 days, but in cholera epidemic, the chlorination of the well water is done every 24 hours. The normally, if we are doing every 5 to 7 days. Normally we are doing 5 to 7 days mein, but in cholera epidemic we are doing daily. Now we are having the two type of the vaccine. As I said that the strains are important to know the vaccines. Cholera vaccine is both live plus killed. Cholera vaccine is both live and killed, but most commonly we are using the killed vaccines. Two type of the killed vaccines. If it is against a single group, monovalent, or it is against the both, that is bivalent. If you can remember the strain, fine, that is a monovalent is Dukoral and the bivalent is the Sencol. But just remember, these are the killed vaccines given by the oral route, mono or bivalent. Okay? We can have the live vaccine also with the strain of the CVD 103. This was an AIMS question, that what is the strain for the live vaccine. If you can remember, fine. But just remember, most commonly we are using the killed vaccine, either monovalent or the bivalent. Okay? So this is about the cholera. Now another important disease is typhoid. Now what we are supposed to know about the typhoid? Again, this is a bacterial infection causing a high grade fever with the rashes, and sometimes it can affect the intestine, leading to the intestinal perforation, and we know that it is prevented exclusively by the vaccination, and it is a disease which is spreading to the fecal-oral route of contamination. Now this is said to be a disease earlier happening up to the 15 years of the age group, because बच्चे बाहर का धीरे धीरे खाना खाना शुरू करते हैं. Body is getting a subclinical immunity, infection immunity, and they develop the immunity against the infection in adulthood. But आजकल क्या है, the parents are pampering their kids in a small childhood. So typhoid is seen in the older age also. So indirectly, if you are having a high incidence of the typhoid in our country, it is suggesting that our sanitation is poor. So which disease is considered as an index of the general sanitation of a country? This is the typhoid. High number of the subclinical cases and carriers are seen, showing an iceberg phenomena. We can have a recovery carriers, convalescent carriers, 6 to 8 week duration is there of the chronic carriers. Man is only the reservoir. Most common age is up to 14 years, but now any age can be affected. Diagnosis we can say by the Basu test. The first week may we are doing a blood culture. Second week may antibodies by the Vidal test. Then we are doing the stool culture, and the fourth week is the urine culture. But if we talk about which is the best test is the blood culture. But as this is not easily available everywhere and it is expensive also, and it is too late to detect in a second week by antibodies. So now what we are doing in a first week, we are doing the IgM detection. So IgM antibodies we are detecting, and the test what we are using is the TIFI.M. So now we are detecting the IgM antibodies in the first week by the TIFI.M test. So if it is positive, yes, we can confirm the typhoid. If you had a doubt, we can go in second week by Vidal. Treatment, the cases, the Cefixime is the drug of choice for the cases. Those who are resistant means you might have heard about the double typhoid means a relapse cases. In the resistant cases, we are giving the ceftriaxone along with azithromycin. So we are giving the ceftriaxone along with azithromycin, or you can say ceftriaxone and azithromycin. Carriers may we are giving ampicillin or amoxicillin with probenecid. Now just try to understand. Actually क्या होता है कि chronic carriers में we all know a story of a typhoid Mary. She was a cook and she used to transfer for 20 years. Now here the organism are present in the gallbladder. So gallbladder में bile a juice के साथ organism are coming into the intestine. And the person is not having any infection and transmitting the organism through the stool. So if you had a doubt of carrier, what we do through the endoscope, we are collecting the bile juice and we are detecting the typhoid bacilli. So if on bile juice the typhoid bacilli is present, then we have to do the cholecystectomy also. So carriers may we might be requiring to do the cholecystectomy also. If bacteria are present in bile juice. If the bacteria is present in the bile juice, if we are doing the cholecystectomy. Same here, we have to do the disinfection of the feces. Just correctly, it is not a feces. It is the feces, a urine and the vomitus by same 5% cresol. Do we have a vaccine available for the typhoid? Yes. Both the type of the vaccine is available, the live plus killed vaccine. Both the type of the vaccine is available. Typhoral, as the name suggests, it is given by the oral route. Strain is the TY21A. It is given by oral route live vaccine because जो live vaccine it is in the capsule form. Baby less than 5 years we cannot expect to swallow. 5 साल से छोटा बच्चा उसको swallow नहीं कर सकता, इसलिए 5 years के प्लस देते हैं. सो प्रैक्टिकली क्या प्रोटोकॉल फॉलो करते हैं कि 2 years के बाद, बिकॉज इट इज अ किल्ड जो है पॉलीसेक्राइड वैक्सीन है, सो वी आर गिविंग आफ्टर 2 years. सो सिंगल डोज लगा देते हैं 2 साल पे. दिस इज एक्टिंग फॉर 3 years. 5 years पे पेरेंट्स का चॉइस है वेदर दे कैन गिव अ लाइव और दे कैन कंटिन्यू विद द किल्ड. ठीक है. सो लाइफ स्टार्टेड एट 5 year बिकॉज कैप्सूल है and 3 capsule is a set. We are giving on day 1, 3 and 5, and we have to repeat this a 3 capsule set every 3 year. Now latest edition of the Harrison says that if we are giving a 4 capsule in a single row, day 1, 3, 5 and 7, then we might need to repeat after 5 years. ठीक है. What is the killed typhoid vaccine? It is a polysaccharide type of the vaccine, TIFI-M. It is given in a child of 2 years and more. Single dose intramuscular, repeat every 3 years. So both the type of the vaccines are given. The first shot we are giving at 2 year is the killed, or 5 year के बाद में depends upon the parents' choice. Now coming to hepatitis. Here we will be talking the prevention of both A and B. Although the B is not a intestinal infection, it is transmitted through the sexual route or hematogenous route. But only these are the two hepatitis for which we had a vaccine. So in general, अगर हम कहते हैं all the vaccines are caused by the virus, but in general अगर कहते हैं कि viral hepatitis, it is given a term for hepatitis A, and serum hepatitis is a term given for hepatitis B. Chronic carrier stage we are seeing in a hepatitis B, but a liver cancer it is seen with the hepatitis C. And practically we had seen so many doctors dying with the hepatic cancers. Ultimately they are diagnosed with the hepatitis C, because B vaccine they are taken and no vaccine is for C. So what I do, and I can just suggest you if it is acceptable to you, that annually you should try to get your blood checked, even for HIV, hepatitis B, hepatitis C, because we are dealing with the patients, we don't know when we had an infection. So at least as early as possible we can diagnose the infection. So hepatitis with the chronic, with the liver cancer, this was another question asked, that is hepatitis B, which is in a chronic carrier stage is the the liver cancer is with the C, and chronic carrier stage is the B. Now chronicity means chronic changes are causing by the hepatitis C. Hepatitis in the pregnancy with the maximum mortality is the hepatitis E, and all the hepatitis is caused by RNA virus except the hepatitis B, which is caused by the DNA virus. So this is the basic points. I'm not going detail about the markers of the hepatitis. You might have studied in your patho classes also and your micro classes also, like a surface marker, the Australia antigen, the envelope, the core antigen, the core antibodies, envelope antibodies. Now if we talk about the vaccine, hepatitis A, it is having both live plus killed vaccine, but most commonly we are using the killed variety. Most commonly we are using the killed variety, and started at a 1 year, 2 doses we are giving at 1 year and after 6 months. Live vaccine, again it's a AIMS level question. What is the strain of the live vaccine? If you can remember, fine. S2LA1 strain is there, not very commonly used. Now hepatitis B is actually a killed vaccine which has been prepared by the recombinant technique. Now please listen carefully. Ideal schedule of giving the hepatitis vaccine we call at 0, 1 and 6 month. अगर हमको adults में देना है या बच्चों में भी देना है. But as in our national program we are giving the pentavalent. Pentavalent means DPT, hepatitis B and the Hib, and we are giving the DPT and the Hib at 6, 10 and 14 weeks. So we are not calling our baby at 6 months. So that's why in our national program we are giving the hepatitis B at 6, 10 and 14, and one additional dose if it is a hospital delivery. So again listen, if I say what is the schedule for the hepatitis B, your first answer should be 0, 1 and 6 months. This was the question asked. 0, 1 and 6 days, 0, 1 and 6 weeks, 0, 1 and 6 months, 0, 1 and 6 years. It is a 0, 1 and 6 months. But currently in the hospital delivery we are giving the 4 doses at birth, 6, 10 and 14 weeks as our convenience, and if it is a home delivery we are giving the 3 doses at 6, 10 and 14 weeks. Clear? Now very important, like we had talked in AIDS में कहलाता था PPT-CT, prevention from parents, but यहाँ पे कहलाता है PMT-CT, prevention from mother to the child. because second partner if it is receiving the vaccine can be prevented, but HIV में prevent नहीं हो सकता, कोई vaccine नहीं है, until unless he or she is using the contraception. So this is a PMTCT. Now please listen carefully. यहाँ पे क्या करते हैं कि कोई भी पेशेंट एंटीनेटल में आ रही है, एनी एंटीनेटल पेशेंट, वी आर चेकिंग फॉर द हेपेटाइटिस बी. अगर ऑस्ट्रेलिया एंटीजन नेगेटिव है, और ऑस्ट्रेलिया इज ऑल्सो कॉल्ड एज सरफेस एंटीजन, सो नो प्रॉब्लम. द मदर इज नॉट हैविंग हेपेटाइटिस बी, कुछ नहीं करना. बट अगर सरफेस एंटीजन इज पॉजिटिव, then we have to look for envelope antigen, because envelope antigen will tell us what is the rate of multiplication of the bacteria, how much is the mother infective. अगर envelope antigen present है, it means the mother is highly infective. In that case baby में आप vaccine and immunoglobulin दोनों दोगे. But अगर envelope antigen negative है mother में, surface is positive, it means mother is not infectious too much. So baby में खाली vaccine will be sufficient. This is what they ask. So in the presence of surface antigen but envelope antigen also present, both are present, we are giving the vaccine plus immunoglobulin both to the newborn. So how we are protecting the newborn? If both surface antigen and envelope antigen is present, protecting by giving a vaccine and immunoglobulin both. Your answer finishes here only. If you want to remember that how much of the immunoglobulin we are giving, a 0.05 to 0.07 ml to be given within 48 hours. Best results if you can give in 6 hours. Second dose to be repeat after 30 days, but your answer finishes if you can remember this, that both vaccine and immunoglobulin. Agar surface antigen is present but envelope antigen is absent, the mother is not highly infectious. In that condition, we are giving only a vaccine to the newborn. Clear? Now, please listen. If nothing is mentioned about the envelope antigen, only they mention that a mother is surface antigen positive, how you are protecting the baby, give the benefit of the doubt to the baby, give both vaccine and immunoglobulin. So you can put a note somewhere. If only mention as surface antigen positive, then give both vaccine plus immunoglobulin. So you have to give the benefit of the doubt अगर envelope का status नहीं दिया है तो. So this is about your prevention for B and A. Because we don't had any vaccine for the C, no vaccine for E, and the D is counter protected by the B. No vaccine for C and the E. The global strategy, if you can remember, fine, not very commonly asked, that we have to decrease the incidence of B and C by 90%, and we have to decrease the death by the viral hepatitis by 65%. So this is about your hepatitis A and hepatitis B. Now coming to the worm infestations. We know that two worms we had discussed as Echinococcosis and Teniasis, which had an animal involvement. Two worms are directly related to the intestine. One is, this is a hookworm which are hooking the intestine, and it is having a fecal route of contamination. It is passing out with the feces, and these eggs, they germinate in the soil and they ascend upwards with the grass. If you are going for a morning defecation, open field defecation with the sleepers, so these worms are getting entry in between the toes. From here they are, through the circulation they reaches to the lung, and then through the expectoration they are coming into the oral cavity. Person swallows, reaching to the intestine, and they are hooking the intestine. So we are trying to avoid the open field defecation, and the government is promoting for having a sanitary toilets And what we say, the Nirmal Gram Yojana, means the whole of the village should be devoid of this open field defecation. Now, if you talk about the Ascariasis, these are the roundworms acting as a parasite, eating the food what is being taken by the child, and child is not growing, might be causing a pain in abdomen. Sometimes they can present as an intestinal obstruction also, very, very miserable condition. When you open the intestine, thousands of the live worms, they come on the table, they just move here and there. Sometimes the child can have a vomiting, and these worms can come out from the oral cavity, from the nasal cavity also. So the point to remember about is that the few basic points, and very important index is the Chandler index. So most common worm infestation in India is the roundworm or Ascariasis. A worm which is related to the anemia is hookworm or Ankylostomiasis. Worm which was related to the Staphyl. Staphyl means, you might have seen the Bavaries in the palaces. When person has to go down and the foot was inside the water, but now we are not using this as a source of water supply. So we had already eliminated this condition. Just a historical, it is the dracunculosis. Dracunculosis or the guinea worm. 10th of February is the National Deworming Day for India. Very, very important index is the Chandler index. The point to remember, it is related to the which worm? It is related to the hookworm. What do you mean by the Chandler index? It is defined as number of hookworm eggs per gram of the stool. Number of the hookworm eggs per gram of the stool. When we can say it is a major public health problem? When the Chandler index is more than 300. If a more than 300 eggs are present per gram of the stool, it is a major public health problem. If it is between 250 to 300, it is a minor problem. If it is between 200 to 250, it is a potential danger. If it is between or the less than 200, it is non-significant. If you're not able to remember all, at least remember when it is called as a major public health problem, when the eggs are more than 300 or the Chandler index is more than 300. How we are calculating? The calculation is done by a technique that is called as Kato-Kaats technique. So, the straightforward question, the Chandler index is related to the hookworm. It is a number of the eggs per gram of the stool. It is calculated by the Kato-Kaats technique, and it's a major problem if our index is more than 300. Obviously, the drug of choice for the treatment is albendazole. Now, are we routinely giving a albendazole tablet to our children? Yes. Every 6 months we are giving. So, what is our deworming program? First question, how frequently we are giving albendazole? It is given twice in a year. As the February is the deworming day, तो एक तो February में दोगे, उसके 6 months के बाद August में दोगे. We are giving to a child between 1 to 19 years. Now, first 1 to 2 year में आधी tablet देते हैं, बाद में full tablet. If you are not able to remember, at least remember the albendazole adult dose we are giving 400 milligram in the age group of 1 to 19 years. ठीक है? The albendazole 400 milligram in the age group of 1 to 19 years. This is how, because the time is left less, We have to remember so many things so we can just study smartly. Now, suppose आपको market नहीं जाना, you don't want to go to market, you want fruits, your friend is going, you tell friend, okay, bring some fruits for me also. आप नहीं गए, आपके fruits आ गए. Same like we are using the staff vehicle of the immunization program, and we know that every 6 months we are giving the vitamin A tablet, vitamin A syrup. So if a staff of a national vaccination program is going, we tell them to give the albendazole tablet also. So this is what is the UIP plus activity. Universal immunization program के साथ में some additional activity. So this is linking of vitamin A with the albendazole tablets. Now, some infection can cause the diarrhea, vomiting as a food poisoning, although I already had studied in your micro classes. Most common food poisoning is the staphylococcal aureus poisoning. Staphylococcus aureus poisoning is the most common. All food poisoning causes the diarrhea and vomiting, but botulism is causing the neurological manifestation. So food poisoning which is causing the not causing diarrhea or vomiting, it is the neurological manifestation is a botulism. Although they can, some of them can have constipation, but not the diarrhea, vomiting. Now, when we are taking the food, if it is infected with organisms, some can produce the toxin outside the body already. And when we take the food which is toxin is already present, so immediately it is acting on the stomach. So we can have a short incubation period, and the mainly it is presenting is a vomiting. But if our food is not having the toxin, so by the time it is organism is producing the toxin inside our body, food is already reaches to the intestine, and the main presenting symptom is the diarrhea, and incubation period is more than 6 hours. But two food poisonings are there which are because of already formed toxins. So food poisoning with the pre-formed toxins, the first is Staph aureus, and that's why the incubation period of this is 0 to 6 hours. Another is botulism. It is also because of the preformed toxins, but problem यहाँ पे ये है कि its manifestation is the neurological symptom. So it is taking some time for the toxin to absorb and to act on the nervous system. So the incubation period is 6 to 24 hours, although the preformed toxin, but incubation period is more. What are the agents which can cause the food poisoning? Fried rice can be responsible for the Bacillus cereus type of the poisoning. Pickles or the canned food is botulism, and that's why we say don't use the food after the expiry date. Meat and the poultry products are responsible for Clostridium perfringens poisoning, are responsible for Clostridium perfringens poisoning. Milk and milk products are responsible for Staphylococcus aureus poisoning. So these are the various foodstuffs which are responsible for various type of the food poisonings. Now, diarrhea can be seen in some other conditions other than the food poisoning, and the most common cause of the diarrhea in travelers, it is because of the E. coli. Neonates may because of the infection, that is necrotizing enterocolitis. HIV may it is because of the opportunistic fungal infection, Cryptosporidium. Less than 5 years it is because of the rotavirus. Okay, and we all had discussed that we are giving the two common vaccines to prevent the diarrhea. One is the rotavirus vaccine, second is the measles vaccine. So these are the two vaccines what we are giving to our children to prevent the diarrhea. So this is about this group. Now quickly we'll see the questions what has been asked from this section. A child presented with the history of the diarrhea for last 12 hours He is severely dehydrated and unable to drink. Obviously dehydrated, unable to drink, so we have to give the IV. So ORS is out. अब IV में भी 3 options हैं, Ringal lactate, saline और dextrose. So dextrose is out. Ringal lactate or saline में we'll prefer the Ringal lactate. So the correct answer is Ringal lactate. A student presented with a complaint of an abdominal pain. On examination, he was having a fever with the jaundice. Within a week, few more students presented with the similar problems. So fever है, jaundice है, few more students presented with the problems. On investigation, the medical officer confirmed that all students were sharing a food from a common canteen. So it is related to somewhere the food. Clear? So food से related है, jaundice है, तो कुछ hepatitis है. And we know that it is not a B because it is not related with the food. So this is out. It is A. So it is a recent investigation we are doing. So we will be preferring to go for IgM for hepatitis A. अगर a long back करना है आपको कि few months back, then we can go with IgG. It is only the within a few weeks or within a week. एक हफ्ते में ही सारे बच्चे हो गए. So it's a recent infection. We are going for IgA. A 6-month-old baby came to the primary health center with the diarrhea 10 to 18 times per 24 hours, vomiting, but child is irritable and able to drink the fluid. That is important. Irritable है लेकिन पी सकता है, अगर पी सकता है तो oral fluid देना है. So this is what we are giving the ORS. Purpose of giving the sodium in the ORS is to facilitate the glucose transmission. ठीक है? Sodium is because it is helping in absorption of the sugar and the fluid. So this was all about the intestinal infections. So as some of the students are requesting me to early wind up, so okay, we'll try to wind up by 7 o'clock. So just take a break of 10 minutes, relax and come back. So we'll be covering a few more topics. So time by my watch, I can say it's a 6:06. So we'll start at 6:16. Okay. So I'll leave at 7 o'clock. So at least you can study for your surgery class, surgery test also. Okay. So hello friends, welcome back. Now we will be starting our the next group of infection, and that is respiratory tract infections. And in the respiratory tract infections, the very important diseases we should be knowing about the measles, then meningococcal meningitis, then influenza, chickenpox, rubella, diphtheria, pertussis, pneumonia, tuberculosis, COVID infection, and upcoming is a monkeypox disease and the tomato fever. So these are a few more new guest has been added up in the list. हर सेशन में some new virus jumps up and leave a new disease for us. ठीक है. So now coming to the one very important disease is the measles. Many questions has been asked from this measles, short disease, but very important. Now in the measles, a small child, it is having a rashes all over the body, and these are starting mainly behind the ear, and it is spreading over the face, and it is spreading over the chest. Very concentrated erythematous rashes are there, and very important is day 10 pe it is starting the running nose, that is a cough coryza, and day 14 pe rash appears. Between the day 10 and day 14, if we want to confirm whether this is a measles or not, then we are looking for the internal rash, that is a Koplik spot. This is a bluish white rash on the red base on the buccal mucosa against the second molar teeth. So this is your Koplik spots. So the confirmation of this or the pathognomic rash of the measles is the Koplik spots, which usually appears before the eruptions. So this is your Koplik spot. This one, and these are the measles rash. So point to remember is the incubation period. Although we had already written earlier, it is a repetition. It is 10 to 14 days. If you have to choose one, go with the day 10. Period of communicability is rule of 45, means 4 days before the rash to 5 days after the rash. 4 days before the rash to 5 days after the rash. Highly infectious, secondary attack rate is more than 90%. We don't had our subclinical cases and carriers. Case of the measles is a source. 3 C's we can have as a prodromal symptoms like cough, coryza means running nose, and conjunctivitis, cough, coryza, and conjunctivitis. Now, very important is the Koplik spots. So, straightforward question is asked is Koplik spots are seen in which disease? They are seen in measles. Second is they are present in which phase? They are present in the pre-eruptive phase, means before the eruptions. So, Koplik spots in the measles, they are present in the pre-eruptive phase, and these are present on buccal mucosa. So these are the bluish white spot on the red base on the buccal mucosa against the second molar teeth. Sometimes we can have a hyperpigmented line on the conjunctiva. This is known as a Stimson's line, but very commonly they ask about the Koplik spots. Now, what are the common complications? Most common complication is otitis media. Most common complication is otitis media. Other complications can be diarrhea and pneumonia. So most common is otitis media, and other can be the diarrhea and pneumonia. Very rare complication again commonly asked is it can lead to SSPE. Rare complication is SSPE, that is subacute sclerosing panencephalitis. Subacute sclerosing panencephalitis is a rare complication. Measles is causing the diarrhea, so indirectly a vitamin A is seen as a deficient in the children with measles. As it is a viral infection, only the supportive, but very important is prevention. Many questions has been asked about the prevention. Pre-exposure is by the measles vaccination, and everything we have to know about the measles vaccination. It is a live vaccine, Admostron. This is an Admostron ajagrab strain. Distilled water as a diluent, given by subcutaneous route in the right shoulder. 2 doses, 9 to 12 months, first dose, and second dose in 1.5 years. We had already discussed one more point. In suspected epidemic in high risk babies, we are giving an additional dose between 6 to 9, that is considered as a zero dose. We had already discussed, and I am expecting all of you that you had studied the vaccine yesterday, because I requested you all, so you can understand everything. Now another very important question, this we had already discussed in the disaster chapter, that if a baby had been exposed to a child of measles infection, because here the antibodies are found within 7 days and incubation period is 10 days. So if within our first 3 days of an exposure we can give the vaccine, it is effective. So the post exposure, this is examiner wants to ask, within how much time we can give the measles vaccine. So measles vaccine is given within 3 days of exposure. It is given in a 3 days of an exposure. But if a child is immunocompromised child, where we are not expecting the good antibodies to be formed, or the child has been treated after 3 days of an exposure, where we cannot expect the antibodies to be formed properly, so we are giving immunoglobulin. So immunoglobulin we are giving in 2 conditions: either exposure is more than 3 days back. If the exposure is more than 3 days back, or if the child is immunocompromised. So if a child is immunocompromised or the exposure is more than 3 days back, we are giving immunoglobulin. But if exposure is within the 3 days and obviously the child is with a good immunity, we are giving the vaccine. So this is important, and that we have to remember within how much time we have to give. Goal is important, that we have to eliminate the measles by 2020. We have discussed the 2 strategies rather than 3. Safe and get for trachoma, I for the yellow fever, and this is another strategy 2 more for measles. We have to remember their names. One is the ARM strategy given by the UNICEF, and ARMS is accelerated measles mortality reduction strategy. Accelerated measles mortality reduction strategy means we are trying to reduce the mortality because of the measles. How we can reduce? If we are covering more and more vaccination of the children. So if we are having a high population coverage of the 2 doses of the measles containing vaccine, more than 90% in the national level, and individual district level is more than 80%. So first strategy is the ARM strategy given by WHO UNICEF. Second strategy was given by WHO, and that is catch up, keep up. Catch up, keep up, and follow up strategy. So catch up, keep up, follow up strategy, it is given by WHO, and WHO UNICEF is arm strategy. Now one more point here, as you can remember that in the AFP surveillance we are calculating the doing the survey in a children of 0 to 15 years. Now here we are including the children between 9 months to 14 years. We are including the children between 9 months to 14 years in the catch up, keep up and follow. Actually, what is the strategy here is that what we do, first of all, we catch all the children in this age group and we vaccinate them with a 1 dose of measles containing vaccine irrespective of their previous vaccination. Then we will go on vaccinating the newborn babies as per the schedule. And again, after the some 2, 3, 4 years, we are again vaccinating all the children. Purpose is to maintain the herd immunity. Okay? So just remember the two strategy with the measles: accelerated measles mortality reduction strategy and the catch up, keep up and follow up strategy. And the age group for a catch up, keep up and the follow up is 9 months to 14 years. Clear? Now, what is our global plan? Obviously, the global plan for measles and rubella together, because we are giving the MR or the MMR vaccine, that more and more children should be receiving the 2 doses of the MR vaccine. Okay? So, this is what is a global elimination. Nothing much is required. So, this is what is short disease, but every point is a question. Now, coming to the second disease is the chicken pox. Chicken pox ka incubation period is 14 to 16 days. Secondary attack rate is highly infectious, more than 90%. Period of communicability is a rule of 25, means 2 days before the rash to 5 days after the rash. Obviously, a case of infection will transmit the disease. This is an image we had already seen in derma classes also. Pleomorphic rashes. We can have a papule, we can have a vesicles, we can have a pustules, we can have a ulcers. Pleomorphic rashes are there. So the characteristic of a rash is pleomorphic. Variety of the rash. It is mainly distributed on the central part of the body. So centripetal distribution. In difference to the monkeypox or the smallpox, which are more peripherally distributed, so it is mainly distributed in the central part of the body. We all had experienced some those who had a chickenpox. The blisters they rupture, they form a small ulcer which heals with a crusting. And a period of communicability is only till 5 days after the rash, means these crusts are not containing the virus. While in the monkeypox and the smallpox, we say the 3 weeks is a isolation because that crust is containing the virus. So here the crusts are non-infective and we are having a fever with each crop of rash. Fever with each crop of rash is C. So these are the rash characteristics. So question was asked is all other features of the chickenpox except. In viral infection we had seen during the COVID time also, only paracetamol was given, no anti-inflammatories, because aspirin or other anti-inflammatories in the viral infection can damage the liver, leading to acute encephalopathy, and this is known as the Reye syndrome. So damaged liver, acute encephalopathy with analgesics. Viral disease, only the supportive treatment. Prevention is yes by the vaccine. And as this is not included in our national program, so we should be knowing the type of the vaccine and the strain of the vaccine. It is a live attenuated vaccine. Oka is the strain. 2 doses, one at 1 year and another at preschool age group. Very, very important is post-exposure prophylaxis. Now here they will give you a clinical situation like a lady who is pregnant by 4 months, 3 months is coming in contact of a patient of chicken pox. What to do? Because chicken pox infection in the pregnancy is risky, we cannot give the live vaccine here. We have to give the immunoglobulin. But here what the examiner wants to ask, don't jump for giving the immunoglobulin. We have to know the status of that woman, whether she had past infection which she doesn't know, whether she had received the vaccine which she forgot, by looking for IgG antibodies. So the post-exposure prophylaxis, the first to go for varicella zoster IgG antibodies. So first look for varicella zoster IgG antibodies. If these IgG antibodies are present, it means that lady is safe and no action is required. You got the point? अगर varicella zoster immunoglobulin present है, it means that patient is either vaccinated in past or had a natural infection, now it is safe. But if varicella zoster immunoglobulin is absent, it means that lady is unsafe. Now here the question is what to do? We cannot give the vaccine, so we have to give varicella zoster immunoglobulin. So we have to give the varicella zoster immunoglobulin. Now here they ask you the dose also. We are giving in a dose of 12.5 international units per kg the body weight intramuscular as single dose. So if varicella zoster immunoglobulin are absent and especially in the pregnancy, post-exposure prophylaxis in the pregnancy. Now, if it is in a non-pregnant state, we can give the immunoglobulin or we can wait if a chicken pox happens or not, because it can happen, but if it is happening, then it is not dangerous. So, more important in the pregnancy, but yes, in a non-pregnant state also we can give the immunoglobulins. So, if it is IgG, immunoglobulins are absent, we have to look for the varicella, the IgG antibodies are absent, we have to give the varicella zoster immunoglobulins. Clear? Now, another important point is, like rubella mein the most dangerous period is the first trimester, but यहाँ पे the most dangerous period is the second trimester. So, if maternal infection is happening between 13 to 20 weeks, then there is a risk of congenital malformation in 2% babies. But if the infection is happening in less than 13 weeks, then the risk of transmission is only 0.4%. So here the risky period is the second trimester. Now, suppose if a mother has the chicken pox around the delivery, so mother is in a phase of communicability. So in that case, newborn is to be protected by immunoglobulin. So if a mother has an infection, we are taking a margin, because although we say it's a 2 days before to 5 days after the rash, but here we are taking a margin of 5 days before. Why? Because during the incubation period, sometimes the viral load is high before the rash appearance and it can transmit the infection to the baby. So if a mother has an infection 5 days before to 2 days after the delivery, at any time, if a mother has an infection between 5 days before the delivery to 2 days after the delivery, we are giving the immunoglobulin to the newborn. And the dose is same, 12.5 units per kg the body weight. Okay? So this is all about the chicken pox, what we have to remember. Another important disease is influenza. We know that many cases of the influenza, they passes as a simple viral infection, but in some it can cause complications. So, short incubation period of around 18 hours to the 72 hours. 4 types of viral strains A, B, C, D, and out of this the most common is the A type. Sorry. Different strains are causing the human influenza. The strains of type A, H1N1 and H3N2, and the strain of the type B, Victoria and Yamagata. So these are the 4 strains against which we had a vaccine, quadrivalent vaccine. Bird flu can be caused by H5N1 or H7N9. We can remember the human influenza strains. We all know that every year these viruses are changing their strains, and this process is known as, if a sudden change is seen, it is called as a shift phenomena, and it is because of the genetic recombination or the rearrangement, major changes. And if it is happening a gradual change, it is the drift phenomena. It is because of the point mutation or minor changes. So major changes, sudden genetic structure will change, although it is rare, but it is causing a major change. And the gradual, it is common. It is because of the point mutations. We are having the 3 categories of the patient: category A, category B, and the category C. Category A are uncomplicated, means having only the signs and symptoms of upper respiratory tract infection. Only signs and symptoms of the upper respiratory tract infection. Category B are having a signs and symptoms of a lower respiratory tract infection, means the pneumonia is also there. But if along with the pneumonia, they had a multi-organ failure, signs and symptoms of the multi-organ failure, they are the progressive patients. So one question was asked is, which is most dangerous category? Obviously the progressive category is most dangerous. Which category requires hospitalization? It is category C. So category C, or the progressive category, which is having a multi-organ failure, is most dangerous and require hospitalization. Treatment. The drug of choice is oseltamivir because it is given by the oral route, and the normal adult dose is 75 milligram BID for 5 days. So drug of choice is oseltamivir. It is given by the oral route. Adult dose is 75 milligram twice a day for 5 days. Other drugs are zanamivir given by nasal route, paramavir, parenteral, P for parenteral, it is the IV route. Zanamivir, N for the nasal, it is given by the nasal route. Oseltamivir, O, by the oral route. Clear? Now, they had asked in 1 or 2 questions the dose of the oseltamivir as per the body weight also. So at this point, I can say, if you can remember, it is fine. If you cannot remember, okay, don't worry, remember the adult dose only. Okay? But if you can remember the body weight wise. If a body weight more than 40, presuming the normal adult, the dose is 75 milligram BID. 24 to 39, it is 60 milligram. 15 to 23, it is a 45 milligram. Less than 15, it is the 30 milligram. Infants में less than 3 month 12 milligram. 3 to 5 month 20 milligram, 6 to 11 month 25 milligrams. So this is in the infant. In both we are giving, in all these we are giving twice a day for 5 days. So if you can remember, fine, but at least don't forget the adult dose. Prevention can be done by wearing the mask. We know that N99 or N95 mask. We can prevent by the vaccination, and the third is by chemo prophylaxis. Chemo prophylaxis is given to the close contact. The drug which is given is oseltamivir. Dose is, if I say the adult dose, it is 75 milligram once a day for 10 days. 75 milligram once a day for 10 days. You can put a notice same as for body weight used for treatment. So dose is same as for the body weight used for the treatment. Only the difference is that we are giving once a day for 10 days. Treatment mein we were giving twice a day for 5 days. That's all. What are the type of the vaccines we had? Both the live and the kill vaccines are we are having. Here the important question is the route of administration. And we all know that live influenza vaccine is given by nasal route, and the killed influenza is given by intramuscular route. So nasal route is very commonly asked because it's a unique route. Live is mainly for the quadrivalent like H1N1, H3N2, Victoria and Yamagata, while killed is maybe mono, maybe quadri. Dose, if you can remember, live is given single dose, repeat every year. Killed is given the 2 doses, repeat every year. Now one very important question. Usually all other vaccines we avoid in pregnancy, and here if the influenza happens in pregnancy, it is very risky. So on priority basis, it is the pregnant woman is on the top priority. So we have to give the influenza vaccine in pregnancy. So obviously the question is whether we can give the live or killed. Live is not given. So we are giving the killed influenza vaccine first priority in the pregnancy. Like rubella mein hoga ki it is absolutely contraindicated in pregnancy, but influenza vaccine, yes, we are giving in a pregnancy. So this is about your meningococcal meningitis. I think influenza. Now the last disease we can cover up and then we'll wind up. That is meningococcal meningitis. The meningococcal meningitis, we know it is because of the Neisseria meningitidis, which is having a high number of the subclinical cases and carriers, high case fatality rate up to 80%. High case fatality rate, that is very, very important. So we are trying to prevent the disease by giving the vaccination or the chemoprophylaxis. But if we cannot prevent, then our focus will be early diagnosis. Okay? So early diagnosis and the treatment can reduce the case fatality rate up to only 10%. So see, 80% deaths are reduced to 10%. Okay? So our purpose will be, so you can put a note somewhere. Our goal is prevention by either the vaccine or by chemoprophylaxis. Our goal is the prevention by the vaccine or chemoprophylaxis. If not possible, then do early diagnosis and the treatment. Okay? So goal in this is, because it is highly fatal, if we have to do the prevention by the chemoprophylaxis or the vaccine, but if it is not possible, then we have to do the early diagnosis and treatment. And that's why, if you can recall, we had discussed one activity as IMNCI by the multipurpose worker male in sub-center. They have to fill the form. First of all, they have to IMNCI mein they have to diagnose. Any patient is coming with the neck stiffness, immediately they have to refer the patient to higher center to avoid the mortality. And under the IDSP project, they have to fill a form, S form, showing whether they had come across any patients in the last week with a fever with stiffness. If I are coming with the new cases of the fever with the stiffness, it means there could be an impending epidemic of meningococcal meningitis. So we have to treat that. Okay? Now, serotypes A, B, C, W135 and Y. Here the question is, the strain we know that we can produce the vaccine, but the question here is asked is, B is not able to produce the vaccine. So B is non-immunogenic. So earlier we were having the vaccine only for the 4 strains, but now we had a separate vaccine for the B also. So you can put a note here, as the B is non-immunogenic, so I am writing here. So vaccine is available for A, C, W135 and Y, that is a quadrivalent. And now we had a separate vaccine for B also. So B ka we had combined with some protein, and that is able to stimulate the antibodies. See the question? Because examiner sometimes wants to know that which strain is non-immunogenic. So try to see the question carefully, because still we had a quadrivalent vaccine which is commonly used, and we had a separate vaccine for B. Short incubation period, 3 to 4 days. Neisseria meningitidis is the organism. High grade fever with the neck stiffness, headache. Stiffness can be elicited by the Cunning sign or the Brodzinski sign. You might have studied in your medicine classes. If we talk about the treatment, the drug of choice is, if they say, please listen carefully, the drug of choice is penicillin for Neisseria meningitidis or meningococcal meningitis. If they mention it is a Neisseria meningitidis or meningococcal meningitis, the drug of choice is penicillin. But if they didn't mention that what is the type of meningitis, then the drug of choice is ceftriaxone for all the types of meningitis. अगर उन्होंने मेंशन नहीं करा कि कौन सी टाइप की मेनिंजाइटिस है, सो सेफोटैक्सिन. अगर मेंशन करा है मेनिंगोकोकल मेनिंजाइटिस और नाइजीरिया मेनिंजाइटिस, देन इट इज पेनिसिलिन. हाई नंबर ऑफ द कैरियर्स आर देयर. सो कैरियर्स के लिए द ड्रग ऑफ चॉइस इज सिप्रोफ्लॉक्सासिन. कैरियर्स के लिए द ड्रग ऑफ चॉइस इज सिप्रोफ्लॉक्सासिन. As I say that we have to give the chemoprophylaxis to the close contact because it is highly infectious and high mortality. So again we are using as a post-exposure chemoprophylaxis ciprofloxacin. But one question was asked is that if the pregnant woman is being exposed then we are not preferring the ciprofloxacin. We are using the ceftriaxone in pregnancy. Non-pregnancy means ciprofloxacin. If in the community we are having a high meningococcal meningitis cases or epidemic, we can give the prophylaxis to whole community because again it is a highly fatal. So mass chemoprophylaxis, again the drug of choice, it is the ciprofloxacin. So mass chemoprophylaxis can be given to the close contact or the members of the health team. Now prophylaxis by the vaccine. So we can have prophylaxis either by chemoprophylaxis, by the use of the mask, by the use of a vaccine. So we can have a prophylaxis by chemoprophylaxis, mask or the vaccine, like we had seen for influenza also. Vaccine may, the first question, what is this type of the vaccine? We know it's a polysaccharide vaccine. So polysaccharide cannot be given in a children less than 2 years. So obviously it has to be given more than 2 years of the age. It is a quadrivalent vaccine we had discussed. It is for ACW135 and Y. B is non-immunogenic. In repeated epidemic areas, we can repeat the booster every 3 years. And yes, as the disease is highly fatal, so we can go for mass vaccination also. If there's an epidemic in the community, so we can vaccinate to the large group of individuals also. So either we are vaccinating the large group of individuals or we are giving them chemoprophylaxis, or those who are not receiving the vaccine or the chemoprophylaxis, our aim is early diagnosis and the treatment. So this is all about a very, very important disease, that is meningococcal meningitis. So okay, although I was planning to complete a little more syllabus, but as you all are requesting that you had a surgery test today, so I don't want to just squeeze you further. So okay, we are winding the session here. So just relax, revise for your surgery test, but don't forget to revise the content after the test also. And tomorrow we'll be trying to finish the syllabus. And if you had any doubt, any query, you can ask me. So bye bye, take care, God bless you, all the best for your test.